hello, 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 check, check, hello, 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 check, check, hello, 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 hello.
morning, everyone. After a very successful scientific and entertainment program yesterday, the things are a little delayed today. This yesterday evening's effect. People are a little relaxed after the good program by Department of Medicine. So they are on their way, and we expect more people, but we cannot wait longer. Already we have postponed for half an hour. So today's scientific program will start immediately. I'll first request Professor Manoranjan Behera to wrap up the yesterday's scientific advancement, and Professor K.N. Podhari, our Chairman Scientific, to tell about today's plan. Dr. Behera.
Very warm welcome and good morning to all. Yesterday we had a very brain stimulating and scintillating events. We had 4 workshops and almost 200 students and medicine specialists that have attended the program. We had 4 workshops on ECG, echocardiography in the Department of Cardiology, 1 in critical care and ICU management, Department of Anesthesiology, insulin therapy in our old auditorium by the Department of Medicine, and Department of Radiology on radiography. And there is a brief inauguration program, and it was call and order by none other than our Dean ICP, Professor Dr. Alka Deshpande. Then our scientific program started in this hall, both the hall, group Hall A and Hall B. Hall B is dedicated for virtual programs, and Hall A, all the live programs. So, Hall C, free paper. And the inaugural batsman was Dr. S. Arul Raj, who told on diabetes and hypertension, a deadly duo. He enlightened on how diabetes measures hypertension, and hypertension exacerbates the complications of diabetes, and both how combinedly they are deadly to the human mankind. And Professor Sambit Das from Bhubaneswar told on art of weight switching. He told us how to diligently choose a perfect oral anti-diabetic drug from glucocentric approach to a adipocentric approach, cardio-renal and CV benefit related approach. How the guideline have been changed over the years he has highlighted. Then one of the best diabetologists of the country of international stature, Professor Dr. Ashok Kumar Das, told on type 2 diabetes mellitus in Indian lessons for our nation, a compendium from latest mega studies. He highlighted on India study and the landmark studies. Professor Alka Deshpande told on management of infections in pregnancy. He told how the different infections like viral, bacterial and fungal infections complicate in pregnancy. He told us the management as well as the vaccination programs. Dr. Vinod Mittal told on NFLD, the metabolic changes. He told us how the nomenclature changed from NFL to MFLD. He told us the diagnosis from clinical features, ultrasound, fibroscan and MRI scan, and the role of bempedoic acid, the role of saroglitazar, ursodeoxycholic acid and obeticholic acid in the management. And HIV and AIDS treatment update 2023 was delivered by none other than Dr. B.V. Riwari. He also updated us the 2023 guideline on HIV AIDS management. Professor Soumitra Ghosh enlightened us on the filariasis, the clinical perspective, and the how to suspect, high degree of suspicion, and clinical diagnosis and management of both acute and chronic situations as regards to filariasis. There was a very brainstorming and scintillating debate on can tuberculosis be eliminated, and Sampath Das told in favor, and Dr. Manoranjan Das of Department of Pulmonary Medicine against the motion. And heart failure, newer methods to detect and treatment was delivered by Professor S.N. Rautray, Department of Cardiology, SC Medical College, Cuttack. He briefed us regarding the updated definition of heart failure, the diagnosis and management. And the conclusion talk was given by Dr. Aruna Acharya, nephrologist, Department of Nephrology, SC Medical College, Cuttack. He delivered us regarding the preventing and reverting to CKD. And the yesterday's program closed with our cultural program followed by dinner. Thank you all.
In the Hall B also, we had parallel sessions by faculties of national and international reputation. And today also, just after half an hour, from 10:30 onwards, we have interesting sessions on Hall B. And this whole conference is going in the webcast. And this is a hybrid conference. And yesterday, around 7,000 people have watched and logged in different halls, and including late night entertainment program, everything has been circulated. And today also, this is being webcasted, and the Hall B program will start, and Hall C program will start shortly with the pre-papers, and we have more than 140 papers, posters, pre-papers as posters, which will be judged today, and we have interesting prizes tomorrow in the valedictory function. I request Professor Padhiyari to tell about today's plan.
We are already late, so I do not want to discuss many things. Scientific program is already there, but I expect that all the speakers will stick to time. If possible, they should try to save some time. And the chairperson should see that the time is properly arranged. We have not kept any lunch break, official lunch break. That means lunch will be continuing from 12 to 3 p.m. and there will be scientific program will be continuing. So to save time and to accommodate more speakers, that arrangement has been done. We have to save time today because the evening is for some other purposes, like general body meeting. We do not know how long it will continue. And the second part is our inauguration. The health minister of the state is coming as chief guest. So we have to see their punctuality and we have to keep the hall ready by the time they arrive. So to do this, and the dinner is not in the venue, close to the venue, we have to go to a third place, that is Cuttack Club. So that transit time will be around half an hour. So unless we save time from this side, everything will be pushed far and far away. And thereby nobody will enjoy particularly the dinner. Dinner is the grand arrangement has been done, so we expect that all will enjoy it. And yesterday, because it was late, Cuttack people almost, Bhubaneswar people almost all left. So we do not want to be repeated today. So with this approach, I request the scientific session to start.
A very good morning to everyone. Myself, Dr. Rosalind Parida, welcoming you all to the day 2 of APICON ODISHA. I hope all our delegates are having a great time over here. Yesterday's session spoke volumes about enthusiasm, interest, and perseverance of the physician. For the second day of the APICON, so I'd like to invite you all to the first session of today, that is a symposium on dengue fever. I'd like to invite Dr. B.N. Mahapatra sir, Professor of Medicine, KIMS Bhubaneswar, Dr. Karthik Charan Raut sir, Senior
So, good morning to all of you and welcome to this 2 days conference, the second day. I see many senior people are here. Now, one of our iconic senior doctor is Dr. B.K. Mishra, who is sitting in front. He is inspiration to all of us from our young age. He comes regularly to the conferences and participate. He is our pride of our associations of ODISHA. So in his presence, we feel very happy to see him in the audience. All of you know that dengue, he is there, it was there, it is still. Odisha. So while we consider this is anybody's job, whether a patient is having fever of any reasons, we need investigations. And for these things, we'll start our program. I request the speaker, Dr. Baijayanti Mala Mishra, who is a very senior virologist of our state. He is the professor and head of the department of AIIMS Bhubaneswar. He has written a textbook on medical virology. He has a research worker and pride of our institutions, and also of Odisha. He is from Odisha, so I welcome him and request him to discuss about the topic of diagnosis of dengue fever, and that will make us all helpful for our treatment. Thank you. Dr.
At the outset, I would like to thank organizer for giving me this opportunity. I have been told to talk on the laboratory diagnosis of dengue. Now, dengue, as it was mentioned, that it's always in the news for some or other things, famous or infamous, in any way we can tell it. So why this lab diagnosis? When dengue started coming to the limelight, people thought why the diagnosis is required when we don't have antivirals, but we know that it has a specific line of management and there's no specific clinical manifestation and it can mimic many other diseases. So finally we know that it requires a confirmation in diagnosis, and unless it is confirmed, it remains as nothing but a mystery fever. Now, before I go to the lab diagnosis, it's important to know, as you, many of you already must be knowing, that this is the kinetic how the virus responds. The early part of the illness, that we have the virus and its components, virus, antigen, and its genome. And that cutoff, we can take it as day 5. So till day 5, we have this in patient. And after that, the IgM comes to picture. So in a way, so early part of illness, what we have is either virus or any component of virus, what is a direct method of diagnosis, and after that it's the indirect method by antibody response. So these are the various diagnostic tools as far as microbiological tools are concerned, which is virus isolation, serology, then molecular techniques. Now, I would like to focus here in this clinicians gathering what we exactly do in lab diagnosis for dengue. We have dengue IgM ELISA, we have NS1 ELISA, and of course for both we also have rapid diagnosis test. So this early marker, dengue NS1 antigen, which is now known as the marker of early infection, and this NS1 antigen is secreted from infected cell, and that's why we can detect it in the blood of the patient. And this starts from day 1, almost day 1 from symptoms, and persists till day 9 or maybe longer. I'll come to that detail. And this is commercially available both in ELISA and RDT format. Now, IgM antibody, it has its own advantage because only the ELISA system we can detect it, and it's produced in both primary and secondary dengue infection. And if we see the positivity, by 3 to 5 days, 50% are positive, and by 5 days, 80%, then as the days goes on, by 8 to 10 days, almost near 100% are positive. So you know the implication of this. So main disadvantage is if we go only by IgM, we'll miss the early cases, and it persists for months, for few months. So always a positive result doesn't always mean a current infection, but it's a recent infection, either current or recent infection. So if we go by the time, how it affects for IgM, it's later part of the first week of illness will get maximum IgM positivity. And NS1, as it's the early marker, the first early part of first week, the first few days, NS1 will be positive. And if we combinedly do both, then we'll be able to detect majority of the cases. So for all practical purpose, if we want to detect by diagnosis, then we have to go for both the tests. Now, if we see how this ELISA test perform, this side it shows the performance of various manufacturers' ELISA kit. This is the sensitivity and this is the specificity. Sensitivity, some of the manufacturer is very good, and specificity almost all are near 100%. Now, if we see the performance of rapid test, then this is the problem. Different rapid test, the sensitivity varies from 20% to 100%. So this creates problem, whereas specificity is more or less around 80%, we can say. Now, if we compare the sensitivity of ELISA versus rapid test, so what I showed here, this is quite reliable. ELISA is quite reliable as compared to rapid test, whereas specificity more or less is similar for both. Now, overall, if we see what the common manufacturer, what we use here all over our country, we can see that sensitivity of IgM is around 70 to 80%, whereas of NS1 is 50 to 60%, whereas specificity is around 80 to 90% or more than that in NS1. And if we combine both IgM and NS1 as expected, the sensitivity and specificity both goes high, around 90% and more than that. And as we know that dengue virus has 4 different serotypes. Now how these kits detect, are they able to detect all 4 dengue serotypes? Now if we see this table, this is for dengue 1, 2, 3, 4. Now this is NS1 antigen detection. Now we can see like for some of the serotypes, the sensitivity is less, particularly for dengue 2 and 4, whereas IgM antibody is more or less similar for all the serotypes. Probably this is the host response. And combined, obviously we are going to detect more for all the serotypes. So what is the scenario of false positivity for this IgM and NS1? What is more important for you as a clinician is if we see the NS1 ELISA, just focus on the last column. The false positivity is around from up to 8%, whereas for IgM it is up to 12% because this is a host response, so false positivity chance is more, but it is not that disturbing for if we go by the disease wise. Now another major problem is co-infection or cross-reactivity. As we know that dengue is a seasonal disease, and so as many other diseases like chikungunya, JE, leptospira, malaria, scrub typhus, and most of the disease, this tropical fever come in one particular season. And as clinician, you are like you don't know when we from lab give you positivity in 2 or more or anything can happen. So you can see many of these things keeps happening in our day-to-day scenario, cross-reactivity or dual infection. So when this type of scenario occurs, test for 2 different pathogen comes positive to you as a lab report. So whether it's a co-infection or it's a cross-reactivity. Now that's a big question to solve this issue, but we can say that if any test is positive by any of these direct method, at least we are sure that that infection is definitely there. But if it is by antibody, then there is a problem. Neither we can deny nor we can say that it's true or false positive. So there lies the problem. And if we remember this kinetics, at this point, when we don't have any of this viral antigen or genome, then only IgM positive, then we don't have any scope to prove by any direct methods. So that is the problem. So that problem remains if you get IgM positivity in both. And this co-infection from this chart that there are a lot of clinical manifestation which can happen in both dengue and COVID-19. And when I was searching the literature, there's so many literature I found that it's cross-reactivity and co-infection or cross-reaction. So I thought how this dengue and COVID can cross-react as far as virus family is concerned, they are poles apart. And these titles are quite misleading, that it appears as if cross-reaction, but going minute to these articles, actually what I found is there is no cross-reaction, so we can safely take, this is a study by CDC, where you can see that diagnosis of dengue or Zika virus disease with the serological assays described in this report are not affected by COVID-19, nor do dengue or Zika virus disease interfere with the diagnosis of COVID-19. So as clinician, feel safe, there is no cross-reaction with COVID and dengue or any other flavivirus. There are various molecular methods, as you know, PCR, RT-PCR and all that, and they can, it can be positive both in primary and secondary dengue infection, and the main advantage is it can detect the serotypes and genotypes. There are various methods. What we used to do previously is the conventional PCR for serotyping, and now of course multiplex RT-PCR is there, and of course we have shifted to this. Similarly, as we are talking these days a lot about diagnostic stewardship. So as clinician, you don't want to diagnose only dengue. You have all the differential diagnosis. Obviously, you would like to know in one shot whether it is dengue, chikungunya or any other tropical fever. So there was a time when we used to do conventional PCR, standardizing it for dengue and chikungunya and all that. And now we have multiplex PCR for dengue, chikungunya, Zika, and also for multiplex RT-PCR for many other tropical fevers. Now coming to primary and secondary infection, this is very important in every part of our country these days. Now here what I want to show you is look at this NS1 and this virus component. It persists for near 9 to 10 days, what I showed in the beginning. Whereas in the secondary dengue infection, it drops down quite early. So third, fourth day, it may be negative. So this is as far as IgM and IgG is concerned. IgG is already positive in a patient of secondary infection. Now, this is NS1 kinetics in dengue 1, 2, 3. What you can see here is primary infection and secondary infection. The first column and the second column, you can see the primary infection, the NS1 persists for a longer time, around 8 to 10 days or may go beyond that, whereas secondary infection, it becomes negative very fast. So what I want to convey here to this audience is, if NS1, though it is a very good early marker, if it comes negative even on day 4, 5, please do not rule out dengue. It can be dengue in secondary secondary infection of dengue. And in this type of scenario, particularly like in our country, even in Odisha, we can reduce the cutoff date or a day of 5 days to 3 days. As our country becomes more and more endemic, and we know that it's resource constrained always, so we can take the cutoff as less than 3 days and more than 3 days. So if less than 3 days you are getting NS1 positive, please do test by IgM ELISA before you rule out dengue completely. Now this is what is our like state and country status, circulation of all 4 dengue serotypes. Why this is important? This is an indicator of endemicity or hyperendemicity. And if you see the right side part, this is the status of all the states, and the last color, the brownish color, that's the circulation of multiple serotypes at one point of time, which indicates that most of our states are becoming hyperendemic. That means we are going to get more and more number of secondary dengue cases. So what I told about NS1 positivity ruling in or ruling out, please consider this aspect that your patient may be suffering from secondary dengue infection. So be careful only on the basis of NS1. So I'll conclude by saying that dengue IgM antibody or NS1 antigen ELISA are the recommended tests to confirm dengue infection. IgM combined IgM and NS1 gives higher sensitivity and wider coverage of detection. All 4 dengue serotypes can be detected by this test, though with variable sensitivity. RT-PCR can be used if you want to detect the dengue serotypes and genotypes. And presently, multiplex RT-PCR is used for dengue serotyping, and also preferred test to diagnose early cases of other arboviruses, and also for tropical fever pathogens. What, as a clinician, it will be most beneficial to you if we can give you the result of either it is dengue or chikungunya or Zika or any other tropical fever like scrub typhus, leptospira, and in one go. So this is how the dengue diagnostic tools have evolved over the years. When I was doing dengue diagnosis in early 2001, or even before that when I was student, from cell culture, immunofluorescence to start, now we have come to NS1 and combined RDT test. And from conventional PCR to RT-PCR and multiplex RT-PCR, and probably this is the future like droplet digital PCR or CRISPR-Cas. So thank you so much.
So, thank you, Dr. Mishra. The topic is open for discussions. I request the audience to have any queries. Yes, Dr. Vera.
Madam, Government of India, NVVDCP recommends that IgM should be done at 5th day.
Yes.
Okay. Another thing, in our locality, we are not getting any antigen test for scrub typhus and leptospira. We are only depending on ELISA IgM. So
yes,
it is very
leptospira
difficult.
antigen detection is not there. In fact, antigen detection for dengue is there. And in fact, you can say it is only there for dengue. We don't
Yes,
have
yes.
antigen detection for
leptospira?
chikungunya, JE, leptospira,
We don't
scrub.
have that antigen.
We don't
So-
have antigen
so
detection.
in the initial period, it will be difficult to whether there is
So
a
in
point.
that way, multiplex RT-PCR or RT-PCR to detect the early cases. See, this PCR, when we didn't have NS1 antigen, NS1 became a game changer to a large extent for dengue diagnosis. But before that, we used to do PCR, and that's the only thing which you can do. So similarly, now we have PCR or multiplex PCR for scrub, lepto, along with dengue, chikungunya. So early part, you have that scope only by PCR system.
Thank you, madam.
And IgM, what you said, 5 days. If you are going for only IgM, yes, 5 days should be the cutoff. But what I said is day 3. My point of conveying is, if you are getting NS1 negative, please do not rule out. Test it, because we have seen many cases when like day 3, day 4, you won't expect NS1 to be negative, but more and more we are getting secondary cases, and NS1 can be negative even before 5 days. In those cases, please do IgM before you rule out dengue.
So, thank you for discussions. It is well known that when you have febrile neutropenia and you have also leukopenia, you have thrombocytopenia, dengue is definitely a differential diagnosis in our setup.
Sir, one question.
Yes,
sometimes mother come with their child, that the child is suffering from fever for 2 to 3 days. I asked any fever before that, unable to remember such and such. In this case, it is a primary or secondary?
No, in children, it can be secondary in a way, because it behaves as a secondary, though the baby himself is not infected, but the maternal antibody can be there from the birth. If mother is infected beforehand, that antibody can be there in the child. So why in children the dengue is severe? This is also one of the hypotheses, because that child is having the pre-existing and the maternal antibody beforehand. So the first infection act as a sort of secondary infection. So what we know that secondary infection dengue can be severe. So in that way it is important.
In every case we suspect that the secondary or?
No, not in every case, but that situation can be there.
I don't think in clinical practice we are concentrating on primary or secondary. We don't consider that. We want positive, dengue or not dengue. I think we should do what the take-home message is, we should do both the tests, both NS1 and IgM by ELISA. Rapid diagnostic tests are not good. And if it's negative, we can repeat it after some days.
Yes.
That is the message we should take.
Yes.
And we should not be afraid that we may get some patients where there is combinations of other tropical diseases, like you can get scrub typhus combination dengue. You can have, earlier we have seen many cases of dengue with malaria. So many things comes up in practice. But if you do two two tests in by ELISA, we may be wise enough to get a result and can be repeated when it is negative. That's all that we should do. Thank you, madam. You have done a very excellent job. I congratulate. I also give a great applause to Dr. Mishra for your excellent presentations.
Yes.
Thank you, madam.
Thank you, sir.
So,
Good morning, everybody. Though the attendance is thin, but yet there I have been sandwiched by two most intelligent professors, Professor B.N. Mishra and Somanendra Das. And they are all medical college from the medical college, and I am from periphery. But I held the past, I'm the presidentship of this particular institution, APICON, for the last, probably in 2016. I have the pleasure of introducing another stalwart, particularly in this field. He is no other than Professor Ashutosh Biswas. He is the director and CEO of AIIMS Bhubaneswar. He has plenty authority, particularly in these exemplary bodies, and a master in most of the infectious diseases. We will be happy to listen from him about the pathogenesis of dengue, because the pathogenesis of dengue starts from inoculation till the florid manifestation of the disease. It's a very big subject, and I hope Dr. Biswas would, Professor Biswas would definitely clear up and at least chase away the confusions that is looming large in the minds of most of the physicians. And that too with clarity, lucidity, and with a lyrical voice. Thank you very much. And the mic is over now to Dr. Biswas.
Thank you, sir, for your good words, and it's really a great honor to be here today. I was a student, I'm the product of this college, SCB Medical College, about 43 years ago in 1979 batch. So after this, I was in New Delhi AIMS. I served in New Delhi AIMS for 30 years, and then I was a director and vice chancellor in Indira Gandhi Institute of Medical Sciences in Patna, and then from there I have taken up the charges of the AIMS Bhubaneswar. It's nice to be here, and thank you for the organizers, APICON, for giving me opportunity to speak in these occasions. So I have been given a very focused, specific topic, the pathogenesis of the dengue. And this is what, so without wasting time, I have been told to finish it within 15 to 18 minutes. So I have to run on the slides, but I'll try to speak a very focused part, would be, I think, able to do justice to this topic. So without this, we can't talk dengue. Trying to attack mosquito, different strategies, planning to attack them, and they are also planning strategies to attack human at their dining or maybe the breakfast table. So difficult to control. So just to share that, just I visited this country just in the northern part of the Australia that few months ago as a WHO expert to investigate the unknown fever, cause of unknown fever, and the people are dying. As I have been working also associated with WHO about 25 years in this emerging infectious disease and the neglected tropical disease with the WHO. So in that sense, this just recently I visited that country and found that the people who are dying, after investigation of course, the people who are dying due to dengue, which is not really a common disease in that. So with that, we are just, we know that in dengue, almost all parts of the body, organs are infected. So with the various ways they are infected, vascular symptoms, and then skin symptoms, vascular, various ways. So this is what. It also involves almost all the organs because it affects the vessels. Vessels are going through the organs and these organs are infected. So we know the severity and pathogenesis also sometimes depends on the type, serotypes and genotypes, which is more virulent. And commonly we find serotype 2 or 3 are predominant serotypes across our India and having more symptoms than DEN 1 and DEN 4. And this is what just linkages with the pathogenesis, the severity of the disease. If the viremia is more, then probably we are having more severe symptoms. The viral load is sometimes important to know whether you are having, in the beginning if you know the viral load, then you can predict the severity. So it has been correlated with the directly proportional to the severity and the viral load. And then other antibodies at the primary and the secondary antibodies, probably these are all infections related to this at different point of time. So these are the viral antigens are responsible for and what are they doing. You have the non-structural and the protein and then different non-structural. NS1 is one that we hook for the early diagnosis. Dr. Bujanti has told already that the importance of the NS1 and other IgM. And different non-structural proteins are also there. And it is also the replication of the RNAs. If you get these antigens, probably it cells, the virus are there, replicating phase, then host immune interaction. It also evokes the T cells and diagnostic marker, active transmission phase. If the NS1 is positive, that is you are in a active transmission phase, so active phase. So these are all the stages that there are 3 stages: febrile, critical and recovery. The beauty of this, that 70–80% of the patients are asymptomatic. We have the infection, but really it is mild fever, and then you are cured without any much progression to the severe stage. What if some severity, 15–20% patient, they go for moderate to severe stages, and that may go through the critical stage and the recovery. The recovery phase is that the beauty is that whatever the symptoms, the capillary leakage goes from intravascular to the extravascular component, is come back to the circulatory system. So reverse flow of the fluid, and then these are the all phases, and it is important to identify that what stage is critical and recovery. So quickly I am going into that. Before going into the most important, just I have taken up the few dates. In AIIMS New Delhi, I remember when I was a young faculty in medicine, 1996 was a serious outbreak in Delhi, dengue outbreak. I was young, I did not know much at that time what is dengue and how it is to be tackled. And there are 20% of dengue patients died in my department in medicine. You can imagine 20% death, it was a havoc. And management was very chaos, so we did not know whether this is the first time or this is exposure, immune response and all. Herd immunity was not there. So there are many questions there, but yes, that was a very disaster in AIIMS New Delhi. So from then, I started working on it too. So the pathogenesis I took up for more than 15–20 years. I have been working on pathogenesis of dengue. So this is one of the things that I analyzed many deaths in dengue. Just I have brought few deaths. You might be having also the same in your hospital. So ARDS, severe pancytopenia, then cardiopulmonary arrest, thrombocytopenia in hypertension, the thrombocytopenia, myocarditis, DM, then dengue, encephalitis, ARDS, cardiac arrest, LRTI, DM, coronary artery disease, refractory shock, whatever you do that not really working on it, aspiration pneumonia, metabolic encephalopathy, CKD, DM, these are all dengue encephalitis, and brainstem herniation, expanded dengue syndrome, dengue myocarditis, dengue fever, ARDS. These are all this. So you can see the common things, dengue encephalitis and polycirrhosis, sepsis, ARDS, hyperkalemia, myocarditis, shock, and dengue hemorrhagic fever and DIC shock. So like this, I thought probably it is important to share before we go for it. So death, we know the cause of death. Now how to prevent? Basically, to understand the pathogenic mechanism, where we can, what is the window, and what are the weapons that we have to attack this, to neutralize this pathogenic process. So basically, if I summarize the whole thing, whole game, the presentation are standing on two pillars. So we divide into vasculopathy and coagulopathy. There's the two pillars on which it is standing. Vasculopathy, that means that is the difference between the vasculopathy and vasculitis. We have to know that. Vasculitis that happens, there are many RNA viruses. Where we get the vasculitis, like the Ebola, Nipah, where you find the 90% mortality, almost 90–95% in Nipah, Ebola. Because of there, we find the vasculitis. And this RNA dengue is causing vasculopathy, only the leakage. So in which way we are going to discuss about that. And then another is the coagulopathy, impairment of the coagulation profile to cause the bleeding. And then vasculopathy causing the leakage, capillary leakage. So this is the whole game, having here how this leakage is happening. That is the ball game here. The most important, the look after what is happening, why the capillary leakage. So it's the most important area to work on this. We try to put all the capillaries under the electron microscope to see what structural changes happening. So we did a lot of work in the various way, molecular and all this way. So this is just, I'm going to share that. So this is one, the vasculopathy means the leakage. That is causing the leakage, and then leaking of the plasma and some blood cells components out of the cells. So this is vascular endothelial membrane. So battlefield is the vascular endothelial membrane, the vessels, and therefore the leakage is the water, blood cell, and the albumin. These are the very more common things, so causing hypotension, organ involvement, and therefore the severity and the mortality. So the leakage is more, the hypotension is more, hypoperfusion to the organ is more. If it is more longer time, so hypoxic damage to the organ and organ involvement, then probably the reversibility of that is not there. So leakage is directly proportional to the severity. And there are all this leakage, that is the all manifestation you find. And then show the coagulation profile. There are various ways to know which patient is going to bleed and why this is bleeding is not only the platelet. Platelet plays a very minor role for the bleeding. We chase the platelet, but we have proven that platelet really is not a very important factor to cause for bleeding. And there are many ways the patient can bleed, a minor and major bleeding, internal, there may be massive bleeding that we know. So this is the organ involvement, finally the leakage and the hypoxic damage and capillary leaking passing through the organ. That is how the cause of organ involvement. If this mechanism, the leakage is more, probably then the organ dysfunction. So almost all organs are affected because these are all circulated through the vessels and capillary. So this is how now we are going to look into that the dengue immunopathogenic mechanism, the immune deviations. Therefore, everything when the virus, any antigen trying to attack you and to have a symptomatic infection, probably the immune surveillance system, there is some weakness. So it bypassed the infections and the antigens probably inside. So we have all strong, robust immune system mechanism, surveillance mechanism. No one can pass without signing the immune surveillance pathway. So when it is deviation, probably you are then attacked by, and the gateway all with these machineries to multiply more and then cause infections and severity. So here is the most important through is the cytokine overproduction is the one, chemokine and cytokine. And along with that, vasculopathy, coagulopathy, and there are other important things. The antiplatelet antibodies are also there. Anti-endothelial cell antibody, which are playing battlefield, endothelial membrane causing the vasculopathy and the leakage and all that is the most. So these antibodies are sometimes playing the molecular mimicry, where this antibody has the receptor in different places to cause dysfunction. So that is what similar. So the infection monocyte and beta cells. This is how the virus when enters and passing through and different cells are activated, dendritic cells and macrophage. And what they are doing, they are activated and they release some cytokines and chemokines. And after 5 days, Dr. Bojanti has said there is no virus. No virus are eliminated. So these infections, your body, we don't need antiviral agents. Because after 5 days, there is no RNA present in your circulation. The dengue, all the viruses are cleared by your immune system. Your immune system is so strong, it's cleared off. Now what then, why we are dying? What is the cause of death? These are the molecules, the cytokines and chemokines are the important molecules which triggered this all the pathogenetic and the severity of the disease. So these are how these are released, so enhanced antibodies, and the releasing the cytokines and chemokines causing the vasculopathy and coagulopathy, the two pillars for this. So how they are? There are different, these are the players in our body, monocyte, mast cell, macrophage, T cell, B cell, dendritic cell and NK cells. Are the players, important players to enhance this all the antibody and causing severity and the mortality. How they are doing? This is all pathogenetic process, infection process and after entry, how this all dendritic cell, mast cells and all causing this. This is what. So this is all your the dendritic cell. I'm not going into detail. It's going to make you confusion. But through this process, the macrophage and the T cell, then the mast cell and all. Then finally, there are several factors: cytokines, chemokines, TNF alpha, and interleukins, and then finally the hemorrhagic syndromes and the shock. This is the outcome, and through this. So this is, as we know, secondary infections are always severe than the primary one. That is, we know secondary infection. That means if you are having second time infection, you likely to have more severity because of the antibody dependent enhancement. So it is always important to know whether this is a first time or second time. I think there is an alarm. I have been want to finish it up. So this is secondary infections, means there are non-neutralizing antibody. Neutralizing antibody to the infections are going to knock down the virus when trying to enter. But non-neutralizing antibody are creating nuisance. They are not fully wicked or powered to neutralize the virus. When this virus, non-neutralizing antibody and virus mix complex, they enter into the cell enhanced, and then the entry of that virus is more into the cell, the multiplication of the virus is more, and the viremia is more. That is why secondary infection is always seen. If you are infected with one type of virus, you are lifelong immunized. So you need to have fully immunized. If you survive from one, then second and third. So this is how it goes. Now we have, can I take just 1 minute more, sir?
Yeah, permit.
So this is how your capillary bed, now this is in the pressure, and then low pressure, high pressure, the intercellular space, the fluid goes in, and then also there is a reverse flow after later on. So capillary exchange is most important as battlefield of the endothelial membrane and causing the, so exchange, the endothelial damage, finally is the damage of the endothelium. There are various factors responsible for this, so vascular, so if it is the mast cell regulation, with the mast cell targeting the drugs, we can control this also, like this montelukast and then ketotifen. There are many membrane stabilizers. So you have to have that interleukin targeting, TNF targeting. So there are various drugs are now in development stage, clinical stage for the management of this, because we don't have at this moment antiviral drugs. So these are all local infections, systemic infection, secondary infection that you saw TNF alpha, prostaglandin, histamines, and then leukotrienes, histaminase, so chymase. These are all the various chemical released, and they are the causing damage and severity of the infection. This is very confused slide. This is very close to me, cytokine all. I have been working on the cytokine, several cytokine release and all to correlate with the severity. Finally, the hemorrhage and the hypotensions and cytokine release causing the cytokine storm. So it's known very cytokine storm, and we know the COVID is cytokine storm, and before that we knew already for this. So if you can target cytokine, probably you can. So coagulopathy, these are the all coagulation profile. And we need to know what is the cause, not the platelet, APTT, fibrinogen platelet, and coagulant, procoagulant, anticoagulant. These are all the things that we need to estimate to know the severity and the cause of bleeding. Now there is a paradigm shift of this, because there are two ways. One is earlier 15, 20 years mostly is the disease of the children. 80%, 85% dengue means all Southeast Asia and Thailand, the children are affected. Now it is mostly the disease of the adult and adolescent, is less in the children. And now this disease is another paradigm shift. Initially there was much of bleeding. Now we don't see much of bleeding severity, patient dying due to bleeding, but it is mostly due to the capillary leakage and the shock. So this is how there is a clinical profile changes and also infectivity in terms of the population. So there are several causes of dengue, and this is all the publication, few pathogenetic markers of severity. These are all few publications around the burden and dengue seroprevalence. Then there are management of dengue with the co-infection and eye involvement, and then clinical management, predictors of the dengue, some things that are correlated with the severity, and then your validity of the tourniquet test sometimes is not valid, is not correlating with the severity and diagnosis. That we have done. It is 1999. There are several. So this cardiac involvement is also well correlated with this. So there are many guidelines also that I am associated with national and WHO. Thank you very much, sir, for giving the opportunity. Thank you all for your kind help.
Thank you. Thank you very much, Professor Biswas, for your very brilliant elaboration of the pathogenesis of this thing. No? The microbiology of dengue is really complex, but it's comprehensible. And you have deliberated it really in a very comprehensive way. It's difficult, certain areas are very difficult to get into, but still then things were really better. I would like the House to interact with him with any question. Okay, no question.
Sir, very brief and lucid presentation. Sir, my question is many dengue patients present with dengue hemorrhagic fever with many complications, but they don't mount fever. What is afebrile dengue? And what is the mechanism behind that? Though they present with hemorrhagic fever, but they don't mount fever. Hemorrhagic feature, dengue hemorrhagic fever presentation, but they don't mount fever, afebrile patient.
So, afebrile dengue, you mean to say?
Yes.
There is the dengue patient coming with the bleeding but having no fever. Yeah, there we see, but initial stage there may be febrile phase, but sometimes there may be, if the cause of fever is when there high viremia stage.
No, sir, I have seen one case, also we will publish also that one patient presented with long segment myelitis, cervical myelitis with retroperitoneal hematoma, platelet count 15,000, dengue, ELISA, IgM was positive. 100 times we have asked, there is no fever, no fever, no fever.
Yeah, afebrile dengue is already known case. Yes, sometimes there may not be. So the variations are always there. You may get that. So directly, if the viremia is there, now to cause any organ damage, either the CNS or any other heart or lungs to cause ARDS, so naturally the viremia is the one. And sometimes there may be also cytokine related, the defensive mechanism, the cause of fever, all response may not be very robust. In case of immune suppressed patient, we may not get fever. Patients are on steroid and there may not be fever, but they may be having high viremia stage. So that could be the one you have to look for then, why the patient is immune suppressed.
Okay, thank you, thank you.
Very important question. First one is the three questions. The second question I will answer first. Now we are trying to attack air through air route, air attack by the drone. Now Bhubaneswar and all area, the drone is there to attack mosquito, spreading all that. That's joke. But now when we attack some species, they have also a very intelligent way to bypass any defensive mechanism or any attack we try to. So is a specific species try to exist in this world. So that's a natural phenomena. And we try to use so many spray, they are going to be resistant.
I think we should end the session.
So
next
for
session is delayed.
failing control is a very Herculean task, so we have to integrated way. I'm not sure how to control.
After the session is over, we can have interactions because it is already late.
The first one, platelet. We should not transfuse platelet until it is less than 10 or 20,000, if the patient is not bleeding. If the patient is bleeding, have a sign of bleeding, then even any count, maybe 1 lakh, you need to transfuse platelet. This is the guideline.
Thank you.
dear senior. Before he starts, let me say that I have very interesting observations or hypotheses, let us say, about the treatment part, which I will tell after his speech is over. Let me see how good he is going to present. If it clears my doubt, I will be satisfied. Let me first listen to Dr. De, how it treats dengue. Please, Dr. De.
Thank you, sir. I'd like to thank the organizing committee and scientific committee for giving me this chance. A lot of interest has been generated in treatment, and after the wonderful talk by our director and our HOD of microbiology, it's the right time to talk about the management. I will speak, for the sake of uniformity, I'll speak on the national guidelines for clinical management of dengue fever. The director of AIIMS Bhubaneswar was instrumental in preparing these guidelines released by the WHO. So I will be covering the clinical features in brief, case management. I'll talk about some comorbid illnesses, and then I'll talk about the very important fluid management in dengue. So this is the graph which shows the various manifestations and how we categorize dengue. So it can be an asymptomatic dengue also, as somebody just told. In the symptomatic category, we have mild, moderate, and severe. In the mild, it's an undifferentiated fever, just like any other fever, with no organ involvement and no evidence of capillary leakage. A moderate group is somewhere you have to be careful about, because it includes groups which are at risk, and it includes symptoms like vomiting, abdominal pain, generalized weakness, pleural effusion, hepatomegaly. These are commonly find things that we need to commonly see on daily basis, and that should ring our bells that it's moderate dengue may go to severity. So that is an important group that we all need to monitor always. And then comes the severe group that everyone is dealing with, the difficult ones, dengue fever, dengue hemorrhagic fever, dengue shock syndrome. And there is this expanded dengue, which contains all the organ involvement in dengue. So these are the core, the groups under which they are divided. And we'll go into details of each. So first is mild dengue. It's undifferentiated fever of around 2 to 7 days maximum duration, and presenting common link with a headache or a retroorbital pain or body pain, joint pain. And this is what we commonly see. And there's a rash, which usually comes 3rd, 4th day of fever, and it's a maculopapular rash. It can appear on the face, on the neck, and other parts of body. And there are no complications in this mild dengue, like bleeding or hypotension or organ involvement. These are not there. They are not found. And these can be managed at home with proper counseling, and everybody does that, sends these patients back home. But with a rider that we need to find out moderate dengue, and we can identify that with these symptoms: recurrent vomiting, or pain abdomen, or lethargy, restlessness, or minor bleeds like gum bleed, epistaxis, or mild scanty hemoptysis. Then pleural effusion, ascites seen on daily basis in the rounds, and hepatomegaly, and the rising hematocrit, which we need to monitor. Then, as I told, these are the at-risk groups, the extremes of age, pregnancy, hemoglobinopathies, or coronary artery disease, immunocompromised patients. These are high risk and need to be kept under supervision. Now, this is the group that concerns us, the severe dengue. Now, we can identify it by presence of shock, capillary leakage, wherein the hematocrit will rise more than 20%, more than equal to 20%. There will be significant bleeding, there will be severe organ involvement, and there will be severe metabolic abnormalities. So that is what defines the severe dengue category, and that has to be dealt with. So it calls for immediate admission and intensive care management too, as far as possible. Now, about organ involvement, one of the delegates had told about long segment myelitis. That is correct. We can find neurological manifestations. In fact, as I say here, we have already seen a patient who was present with a motor-sensory variety of axonal neuropathy in a patient in dengue. There have been patients of dengue encephalitis, patients of dengue with acute liver failure. In fact, we had a patient of acute liver failure, then renal involvement, then cardiac myocarditis, respiratory ARDS, and conjunctival bleed, macular hemorrhage. So these are all complications, all are possible, all these complications are seen. And intracranial bleed, then other things like pancreatitis, then tubular necrosis, cardiac arrhythmias, these things are also commonly found in dengue, and this will come as the expanded dengue syndrome. So coming to the clinical criteria, how we call them dengue, the first thing is the dengue fever, which is a 2 to 7 days fever with the symptoms I already told. Then we have a dengue hemorrhagic fever, which is all the above, plus hemorrhagic tendencies. Now how do we identify them? It is by a positive tourniquet test, that is one, then visible petechiae, ecchymosis, purpura, then bleeding from various sites like mucosa, GI tract, injection sites. Along with that, the patient will have thrombocytopenia of less than 1 lakh platelets per cubic millimeter, and there will be evidence of plasma leakage, and that will be seen by a rise in the hematocrit rate of more than equal to 20%, a more than 20% drop in the hematocrit rate following volume replacement, and obvious signs of plasma leakage like effusion and ascites. Then the dreaded one being the dengue shock syndrome, where there is circulatory failure along with the above, with rapid and weak pulse and narrow pulse pressure. So these are the 4 categorization: dengue fever, dengue hemorrhagic fever 1, 2, 3, and 4. The 4th one is dengue shock syndrome, and the other ones which I just told now, they are in the increasing severity and at last going to the dengue shock syndrome. So I'll now come to the management. How do we manage these patients? So first, being a dengue fever, which is very simple, just like any other viral fever, symptomatic and supportive, giving antipyretics. Be careful to avoid NSAIDs or aspirin or intramuscular injections, and adequate fluid and electrolytes and fruit juices, those can be given. And what we need to monitor for the next 24 to 48 hours will be whether patient is becoming afebrile, whether the hematocrits are stable, and whether the platelet count is more than 50,000 and not falling. Then comes the dengue hemorrhagic fever. The initial part is the febrile phase, which then goes to the critical phase. So during febrile phase, management is same as the previous one, with almost same fluids and antipyretics and the careful watching of the patient. Now here, the 3rd day of illness or the transition period is very important, when the patient will become afebrile and everything is fine, everything goes wrong. So that is where serial hematocrit determinations need to be done to find that right from 3rd day onwards until the temperature is normal and we do not find any complications. So when should we admit a patient of dengue? A patient having significant bleeding from any site, a patient showing signs of hypotension, patient having high-grade fever, not improving, persistent high-grade fever, platelets rapidly falling, evidence of any organ involvement, and those who are having warning signs and symptoms, as I have told earlier. So, I will be giving 3 slides on how we have to manage dengue hemorrhagic fever. This is grade 1 and 2. The next one is grade 3, and the last one is dengue shock syndrome. So, in the grade 1 and 2, the thing is more or less, the important thing here is about fluids, how the fluids are given and how the fluid is monitored. That is the most important and cornerstone of the treatment. So, as an initial guide, if you have a person with dengue hemorrhagic fever with some hemorrhagic bleeding tendencies and a thrombocytopenia and a hematocrit more than 20%, we can initiate fluids, crystalloids at the rate 6 milligram per kg per hour for around 1 to 2 hours. And then you need to again check hematocrit, serial hematocrits. If the hematocrit improves on treatment, well and fine, the rate of fluid can be decreased from 6 ml per kg to 3 to 1.5, and all these over intervals of 2 to 4 hours, and discontinue fluids after 48 hours. This is the easier part. Now, supposing the hematocrit does not improve on the initial fluid, in that case, the hematocrit keeps on rising, So you have to again repeat 10 ml per kg per hour crystalloid for 2 hours and again check the hematocrit, and the cycle goes on till the hematocrit improves. Now, on the converse, supposing you have given fluids and the hematocrit falls, precipitously it falls, and the vitals do not improve. The patient's blood pressure, the pulse, respiratory rate, all worsens. So in such cases, we can suspect internal hemorrhage, and in these conditions, we can go for blood transfusion as per the decision at that time. So the cornerstone is fluid and hematocrit and checking the vitals of the patient. The next will be a dengue grade 3, which is compensated shock. Now, in a compensated shock, the pulse pressure is less than 20 millimeters mercury, there is hypotension less than 90 systolic, and a high hematocrit more than 20. This is how we identify the grade 3 compensated shock. Here, the idea is same, but the thing here is that the fluid rate to start with is higher. It is 10 to 20 ml per kg per hour. And after that, the entire thing goes like that, checking the vitals, the respiratory rate, the pulse rate, whether the patient is having tachypnea, hypotension, all these things to be monitored, and again check the hematocrit, and if the hematocrit rises, give another bolus 10 to 20 ml per kg. So this cycle goes on, and once the hematocrit starts improving, you will decrease the fluid by again 6 ml, then 3 ml, then 1.5 ml in that way, and stop over next 24 to 48 hours. But if the hematocrit falls with no improvement in vitals or other patient worsening, it's a sign of internal hemorrhage, and that should be dealt with blood transfusion. And if it is refractory, they need to be, other things need to be looked, like if there is an acidosis which complicates hypotension, if there is a hypocalcemia which complicates, if there is a bleeding, or if the sugars are not good, all these things are contributing factors to hypotension and should be treated. The next one is dengue 4, which is dengue shock syndrome. Here there is a profound shock. There is hypotension, the blood pressure is undetectable here, and the hematocrit is more than 20%. So this is where you may start oxygen to the patient, and at the same time give a higher rate of volume replacement up to 20 ml per kg in a bolus mode over 30 minutes. That is the first and rapid way of replenishing the fluid. And again, monitor the patient for improvement. If no improvement in hematocrit, again, over 1 hour, the bolus to be repeated, and the cycle will continue till the hematocrit improves. On the right-hand side, if the hematocrit does not, the hematocrit rather falls precipitously and patient again deteriorates, will call for blood transfusion or for management of refractory hypotension, looking at other factors. And if required, worst case scenario, this is the one condition where inotropes can be given when you are dealing with a case which does not improve at all despite all measures. So, severe bleeding, if somebody is bleeding in a severe way, you need to see the cause and site of bleeding and stop the bleeding. GI tract is a common source of bleeding. Urgent life transfusion may be considered, and it's a life-saving way to do. And if the blood is not available, you can think about plasma expanders like Hemaxil to treat the refractory shock. With thrombocytopenia not improving, we have to give blood transfusion. We may go for platelet transfusion if the patient is having a refractory shock and thrombocytopenia. We can think about platelet transfusion. In cases of massive hemorrhage, uncontrolled, we can also rule out coagulopathy by checking prothrombin time. If required, treat the coagulopathy. So this is a complex interplay of factors which need to be seen and managed in patients of refractory shock. What are the indications of platelet transfusion? There is no need for prophylactic transfusion even when the platelets fall below 20,000. Prophylactic transfusion can be given if it is below 10,000 in absence of bleeding. So less than 10,000 is the critical level below which we can give prophylactic transfusions. In cases of prolonged shock, refractory hypotension, as I told, platelet may be tried, may be given, and massive bleeding, systemic massive bleeding, they can be given in addition to red cell transfusion. So the standard dosage also applies here. Now, when do we discharge a patient of dengue? So we can discharge the patient if he has recovered from the acute phase. There is no fever for at least 24 hours. The blood pressure is normal. The patient is passing adequate urine. There is no respiratory distress, no tachypnea, and the platelets are persistently more than 50,000 and showing an upward trend. So these are the conditions where we can discharge the patient home. Now, a word on comorbid illnesses. This is not much difference. It just needs to manage the comorbid illness like dengue hepatitis, where AST/ALT can be sometimes go very high, acute liver failure. This may supervene. It's very difficult to treat. As we had a patient, it was extremely challenging, and the low albumin may be a predictor in such patients, while hepatic failure regimen and all as standard can be given. Myocarditis, another complication, is the challenging aspect is giving fluids, which has to be monitored. Diabetes, insulin therapy, and acute tubular necrosis need to be looked at. The last part is fluid management, which is very important. How do we calculate the fluid? So these two slides show the way in which we can calculate the amount of fluid needed to be given. So the Holiday-Segar formula will give us the baseline requirement of a person, as in this formula. This is the last one, more than 20 kgs, this is the baseline requirement. And to add to this basic requirement will be covering 5% dehydration. And the 5% dehydration is equal to 50 ml per kg. So to the maintenance fluid, we will add a 5% dehydration 50 ml per kg, and that will roughly give us the fluid that we need to give to start with. So crystalloids is the word, and no need of colloids. And refractory shock, colloids may be tried. So the requirement of fluid on the basis of body weight, this is a rough guide, and this can be tried for the resuscitation. So these are my references I have already told from the national guidelines, and thank you for giving me a patient here.
You have finished right on time. I will ask the audience for one question, please, and it shall be followed by my own question and observations. So, due to lack of time, I will invite one question to perhaps they.
Sir, sometimes after 5 days, fever subside. He is a patient of dengue, NSN antigen fever subside. Can I give fit certificate to the patient before 40 hours or after 48 hours?
So that is the time when there occurs a shift from febrile to critical phase as per the pathogenesis. Cytokines and all take over, so that is the transition phase. So you can discharge the patient, but you need to keep a tab on the moderate dengue signs, the signs of warning signs that you need to definitely keep in mind. So before giving a fit certificate, you need to make sure that the platelets are stable and patient does not have any of the warning signs.
In dengue fever, without complication, can we give fluid more or same fluid as required?
You can advise oral fluids. You can advise adequate oral fluids. There's dehydration associated with the fever, so you definitely need to give more fluids. By oral, you can give juices and all, whatever you want. It's not only water, ORS, juice, anything the patient likes to take. It has to be more.
Sir, very good presentation, sir. I'm Dr. Datta from Vizag. So these things, sir, now all the discussions were exactly, sir, as per the guidelines. And it was very good. Only thing, sir, it is if you see the DSS-4 which you discussed, and if you see the Critical Care Society guidelines, IJCCM, or if you see the Survival Sepsis 21 guidelines, sir, when you are treating with hypotension, actually it is fluid responsiveness is more important. Nowadays we are going for dynamic parameters like lung ultrasound focus and echo-guided, so that fluid, because 50% of the patients DSS-4 will be fluid unresponsive, rather that will cause more pulmonary edema. And second, sir, is there any role of steroid? Because the Midwa studies by Bhalla et al. In 2014, in India only, they had a multi-center trial. In that, they used 1 gram of methylprednisolone. So what I feel after at least COVID experience and our which was the only hero in the whole battle, only medicine probably was steroid, probably the same pathophysiology here working. So is not it, probably we should also think, because WHO till now, I think it doesn't permit in 2014 the guidelines. But later on the scenario has changed. So one thing, the fluid responsiveness, clinically we should assess with the ultrasound or echo-guided or more dynamic things have come, leg raise testing. We should do it bedside also nowadays. And second is whether 1 gram methyl prednisone should be recommended or not, or should we go for more research on this? Thank you, sir.
Sir, you are absolutely correct. So IVC collapsibility is something that can be checked and the fluid can be given on the basis of that. So we are planning to do a study on that in our institute, and that is definitely possible to do, and that's a good thing to do. You can always look at that, and it will help in patients of myocarditis and incipient cardiac failure. Definitely, sir. As to the second part for steroids, I cannot vouch for steroids now because there's nothing to say to go for steroids. There may be some studies which may have found some result. Until we have robust evidence, we cannot tell to go for steroids.
Okay, now my question, Dr. Dey, and discussion, hypothesis, whatever it is, which I asked. Yes, you have to be fast, please.
Hello, sir.
So, thing is that you told IVC collapsibility, but it needs robust training, needs good setup, needs ultrasound. But in Odisha, dengue is very common, prevalent everywhere. We are dealing in district headquarters hospitals, small set of medical colleges. Even if medical college of this state, we don't have these access. So why not we'll go for fluid challenge test by giving small bolus of fluid of 250 ml or maximum 500 ml, check his heart rate, check his BP, and meticulous follow-up. If with that patient is improving, means patient needs more fluid. That is one thing. Second things, we should have highlighted on vasopressors. Which vasopressor, when to start and how to start. That is the point. Before giving colloid or albumin. So fluid, then vasopressor, then thick of albumin. If albumin is low, then bolus of albumin.
He has more or less discussed those things, I think.
Vasopressors, actually, because the guidelines, they don't bring it on top. The part is fluid replacement is the word. So vasopressor inotropes definitely will go for an noradrenaline as usual at the lab. But that usually comes in dengue shock syndrome towards the very end, after we have tried blood or platelets or everything.
Okay, give me a chance. What I wanted to say, few years back, one of my students, he should not be called a student nowadays, his colleague, okay. So nobody likes to be called a student nowadays. So he had a discussion with me, and he had a startling thing to say, and he said, my corporate hospital labels me as an expert in treatment of dengue. I said, what do you do? I gave steroids. Now, why not steroids? After I have listened to Dr. Biswas and all his gamut of cytokines and immune complexes, etc., and the most simple thing, the first thing to do, let us say not in dengue, say let us say ITP or any other immune causes of thrombocytopenia, you give steroids with dramatic result. And that doctor, no need to tell his name, he says, I give steroids and gives a tremendous response. That is 3-4 years back. So I thought, why not steroids? And because the whole thing, what is the mechanism? We are not still very clear about the mechanism. Why there is thrombocytopenia? Leaking is all right. Other things are understandable. But why there is thrombocytopenia? If there is thrombocytopenia, the bleeding is the topmost priority. Why not give steroids? And what is we had a discussion, a question before this. So why there is no widespread study on the role of steroids in thrombocytopenia induced by dengue? Please discuss.
Yes, sir. I think it should be done if not robust evidence is there. Just as in COVID, the very landmark trial which proved the steroid is the effective thing in COVID. So I think it can be tried, and we should look forward for it. I mean, there is nothing that cannot be tried. We definitely should. But as of now, we do not have evidence.
For any viral disease, initial part, steroids should not be given because it will enhance viral infection. In the case
Storm, cytokine storm.
Cytokine storm. So we have learned it from COVID. In those cases, it can be tried.
So we have a very good sessions. There is a lot many controversies in steroids. It needs further research. In the absence of research in critical ill patients giving some drugs, result is bad. What is going to happen to a doctor in court of law? You have to remember. You should not forget about that. So needs a research. There's no doubt it. The research goes on. There's nothing static. But so far in the present scenario, we cannot give a steroid as a standard regimen because that's not recommended by anybody. But needs further research. We are not saying no, but it cannot be given nowadays. About the vaccines, I want to tell you that phase 3 trials of some vaccines are going on in 20 countries. But what is result? Those who are not infected earlier given vaccines, they die more from dengue than others. Therefore, I don't consider that vaccine will ever be tried in India. So therefore, vaccine is in a very, very backward state, not at all a promising state. So, and the treatment has been dealt very well, diagnosis and pathogenesis. So all congratulations, and we appreciate the efforts of the speakers, the brilliant speakers. They spoke very brilliantly. I also appreciate the audience who also actively participated. So thank you all, and with this we close the sessions.
Thank you, sir.
Yes, memento, please.
I must thank the AIMS team. It's a very informative session, and dengue is a morning problem, you know. There is an increasing in the patient numbers, so we kept it as the beginning session on the day 2. Again, I'll appeal all the chairpersons, all the speakers to shave little time because we are running late, and we have back-to-back program followed by AGM and the inauguration. So we'll be little quick, same presentation, same academics, little first so that we can shave some time at the end of the day. I request the anchors to go ahead first.
Hello. I express my heartfelt thanks and gratitude to all the esteemed speakers for their wonderful talk, presentation and deliberation. And I was hearing there is so much of interaction, questions and counter questions, and it was really informative sessions. Now I request all our beloved chairperson to move to the podium, memento podium for the felicitation. Thank you. Thanks for your attendance. Now I hand over my mic to the colleague.
Moving on to the second session, which is a mixed symposium, I'd like to invite Dr. Niranjan Tripathi sir, past chairman, RSSDI Odisha and a senior consultant physician of Cuttack. Professor Lalatendu Mohanty sir, professor and head of Department of Medicine, KIMS KIT Deemed University of Bhubaneswar. And Dr. Prasanna Kumar Rathore sir, Associate Professor of Medicine, PRM Medical College, Paripada. Sir, kindly adorn the stage to carry out the next session.
Good morning. I welcome you all to the second session of second day of the 42nd APICON Odisha. And I congratulate the organizing team and headed by API Chairperson Odisha, Professor Jayant Panda, for such an eventful event. And keeping the time in view, I straightway call for the first speaker, Dr. Raman Puri. He is a senior interventional cardiologist, Cardiac Care Center, New Delhi, founder chairman, Lipid Association of India, formerly head Department of Cardiology, Safdarjung Hospital, New Delhi, and a member of International Lipid Expert Panel and Regional Federation of Asia Pacific. We have had close association with Dr. Raman Puri in 2014. We have organized the third National Dyslipidemia Meeting KIMS by Dr. Raman Puri, sir. I welcome you, sir, for the presentation.
It has to be changed. Slides has to be changed.
Slides, please.
So, good morning, everyone, and thanks, Dr. Panda, for giving me an opportunity. And I am going to discuss about Indian lipid guidelines. I think many of you may not be aware of it. Should I start? Okay. We started Lipid Association of India in, say, a brief background about that, in 2012. And we came out with number of recommendations. So far, we have published 9 scientific consensus statements. And so I'll discuss about why do we need Indian lipid guidelines and how we are different from international guidelines. How many of you know about your lipid profile? I just want to know. How many of you know? That's great. Okay. Now coming to a few facts about CHD in Indian, population. We develop heart disease 10 years earlier than other ethnic group. And Asian Indians have 3 to 4 times higher risk of CAD as compared to white Americans, 6 times higher than Chinese and 20 times higher than Japanese. And 40% of Indians with CAD are less than 40 years of age. And approximately 25% of those dying of coronary heart disease are also less than 40 years of age. And migrant Asian Indians also have 3 times more chances of CAD as compared to native population. Based upon these facts, ACC recently has put Asian ethnicity as high ethnic group. If you look into the CVD, CSD mortality in Western country, USA and Europe, there has been a significant decline of more than 50% in the last few decades. And one of the reasons for that is that they have their own guidelines and the treatment is also scientific evidence based. If you look into, and now we know that LDL cholesterol is the culprit of all lipoproteins. Only LDL has been so far found to be the culprit for ASCVD. If you look into the CVD mortality in India, in contrast to what is in the Western population and Europeans, we have shown 41% increase in CVD mortality from 1990 to 2015. So why we have a higher incidence of coronary artery disease? And remember one thing, that we are associated with higher incidence and it carries higher mortality and it is more severe. And one of the factors is high prevalence of atherogenic dyslipidemia, and there are a number of other factors also. And another important is our dietary pattern. We consume a lot of fat, trans fat consumption is very high, and physical activity is also much less. This is a comparison of lipid profile of an American versus Indian. Americans have significantly higher total cholesterol, LDL cholesterol, and non-HDL cholesterol as compared to Indians, and Indians have significantly higher triglyceride and low HDL as compared to Americans. And despite Indians have lower BMI and waist circumference. The study which we did in 2015 of 2,500 school-going children in the age group of 14 to 18, you can see there is a high prevalence of low HDL, 44%, high triglyceride, 45%. That shows that it's not uncommon to see atherogenic dyslipidemia in second decade of life. I'm just giving you a lipid profile of a 30-year-old Indian, and according to you, this is the best lipid profile, and the patient is not supposed to worry about it. His LDL cholesterol is 110, HDL cholesterol is 35, non-HDL is 140, and TG is 150. I think all of you will be very satisfied that this is a wonderful report. Now let me see what is the lifetime risk of this patient chances of his developing heart disease. And there is a GBS3 risk calculator. I have calculated this lifetime risk of this patient. It is about 37%. Means 37% people out of 100 will develop heart disease when they become 80 years. Now, in the next slide, I have changed only one thing from Indian ethnicity to other ethnic group. Listen, now the prevalence, the incidence of heart disease has come down from 37 to 25. That shows being an Indian, we are more prone to have coronary artery disease as compared to other ethnic group. And to understand, answer this problem, Lipid Association of India published their first expert consensus statement in 2016. Just give me 2 minutes before I have to stop. I'll stop there. So it took us 2 years to formulate these recommendations. And here we can classify our patients into 4 ASCVD risk group. It's very simple, table which if you keep in your pocket, you can put your patient, you can classify your patient into various ASCVD risk group. In this ASCVD risk algorithm, there are 5 major ASCVD risk factors, 7 other high risk features, and 4 moderate risk non-conventional risk factors. Remember, this is 2016 algorithm, not 2020, because we have updated that. Now, based upon number of ASCVD risk factors or presence or absence of other high risk features and moderate non-conventional risk factor, you can classify patient into one of these 4 groups. Remember, there is no class of recommendation. There are no level of evidence which you see in various international guidelines and recommendations, because according to us, it creates more confusion rather than it helps any healthcare professional to treat their patients. We were the first association again in 2015 to recommend LDL cholesterol of less than 50 milligram in patients with established ASCVD, in patients with diabetes, with 2 or more major ASCVD risk factor, or diabetes with target organ damage. We recommended LDL cholesterol of less than 70 milligram in those patients of diabetes who have only 1 or no major ASCVD risk factor, or diabetes without target organ damage. So we made our recommendation very simple so that it becomes easier for all of you to implement that. And this was not that it was without any scientific evidence. There was a very strong evidence based upon all these trials and studies and meta-analysis that lowering LDL cholesterol to less than 50 milligram benefits in reduction in cardiovascular event. In 2018, ODISHA outcome trial, in which there was 18,000 patients, post-ACS patients, in this alirocumab was given, which is a PCSK9 inhibitor over and above statin, and the mean LDL cholesterol achieved was around 53, and there was significant reduction in primary endpoint, and that strengthened our concept of lowering LDL cholesterol to less than 50 milligram, which we published in 2016. Then European guidelines in 2019 came out with their recommendation, and they brought down their target from 70 to 55 in 2019 in patients with ASCVD, whether it is diagnosed clinically or based upon imaging criteria. Now, despite bringing LDL cholesterol to 53 or 50, in IMPROVE-IT trial, there was 32% of patients had events in 7 years. And in our ODISHA outcome trial, 12.5% of these patients had events. So what are the baseline characteristics of these patients which makes them prone to have more events despite LDL lower to 50, which initially was thought to be very low? Remember, in 1988, the target of LDL cholesterol was less than 130 milligrams. So even at 50 milligrams, there are people who have events. So we worked on these, thought process. We had again series of meetings. It lasted for about 11 months. And we published expert consensus statement in 2020, November. Here, we added a new risk group, which was an extreme risk group, in addition to 4, which we published in 2016. And now this extreme risk group, we further classified into category A and category B. Category A are those patients of coronary artery disease who have 1 or more features of high risk group. And category B are those patients of coronary artery disease who have one or more features of very high risk group. So that is one of the distinction between category A and category B. There are no international guidelines or recommendations which classify extreme risk group. There are only few guidelines which have used the word extreme risk group, but there are no risk category which further divides into category A and category B. And the LDL cholesterol target in category A was less than 50, and the optional target was less than 30. And in category B, the goal of LDL cholesterol was 30. Again, in 2020, we became the first association in the world to be very aggressive, lowering LDL cholesterol to less than 30 milligram in patients with extreme risk group category B. Now, question is that you will ask me that what made you to think about extreme risk group? Why you created category A and B? What are the basis for it? We have a strong evidence. Now, there are 9 risk indicators. If they are present in patients with coronary artery disease, depending upon their number, the events increases. In this trial of stable myocardial infarction, when none of these indicators was present, in 3 years' time, the events were 3.5%. When additional 1 was present, event went up to 6.8%. And when 7 or more of these were present, the event went up to 58%. So you will understand, you will yourself realize it, that if you cannot put patients of CAD without risk indicator and 7 indicator in the same group, because they have more events, so you have to bring down those events, Then if I apply this, risk indicator in patients with IMPROVE-IT trial, I can see that patients who had 3 or more of this risk indicator had about 3 times more event as compared to those patients who had only coronary artery disease or 1, indicator. So this was our criteria for placing patients into very high risk group, category A and category B. Now there was in our ODISHA trial, it was found that those patients who had only coronary artery disease, in 4 years' time, only 8.6% of these patients had event. When there were 2 vascular bed, means CAD with peripheral artery disease, CAD with cerebrovascular disease, the event went up to 20.3. And when all 3 were involved, means CAD plus peripheral artery disease plus cerebrovascular disease, the events was 26.7. I think you will agree with us that all cannot be put into the same group. And therefore, how we divided patients into category A and category B. And this is, again, a study of patients who underwent angioplasty. There you can see that those patients of CAD plus diabetes and hypertension had maximum event as compared to patients of CAD plus diabetes and CAD plus hypertension, and patients with coronary artery disease has the least event. So these are the strong evidence which I have shown you that why there was a need for category extreme risk group and what was the need for category A and B. Now you will ask me, why did we come to number 30 milligram from 50 to 30 milligram? This is again based upon very strong scientific evidence, and one of the trial of 28,000 patients of stable ASCVD, lowering LDL cholesterol to 30 milligram, there was 15% reduction in event. And in CTT meta-analysis, it was found that if you reduce LDL cholesterol by 20 milligram, only 20, you expect 13% decrease in coronary death or myocardial infarction. So reducing LDL from 50 to 30 is 20 milligram. So we expected that we will have this benefit if we reduce LDL cholesterol from 50 to 30, especially in those patients who had more events despite bringing LDL cholesterol to 50 milligram. Then these are some of the post-hoc analysis, again highlighting that lowering LDL cholesterol below 30 milligram, there was significant reduction in events. And even in one of the trial, ODISHA trial, it was found that the minimum mortality was seen when the LDL cholesterol achieved was about 30 milligram. And these are again meta-analysis which shows lowering LDL cholesterol to below 30 milligram, there is significant reduction in event. In Fourier trial, it was seen that not only less than 30 milligram, even if you lower LDL cholesterol below 10 milligram, there are reduction in event. This means there is no lower level of LDL in which the benefit of CV event reduction is not seen. So we so far have not been able to define even the lowest level, because in Fourier trial, 2% of the population who achieved LDL cholesterol less than 10, the median was 7 milligrams. So even then there was benefit in those. And there are some loss of function mutation of PCSK9, where double loss of function mutation, where the LDL cholesterol in these populations are in 12, 13 or 14 milligram from birth, and they have been found to be very healthy, fertile, and they have a normal cognitive function. Not only these event-driven trials have shown benefit, but there are imaging trials also in which it was seen that if you bring down LDL cholesterol to less than 30 milligram, there is a significant reduction in atheroma. There is a regression in atheroma. The plaque becomes more stable. The fibrous cap thickness increases. A lipid core comes down. So these are some of the trials, Glavgod trial, Pacman acute ACS trial, and Hagen's trial. They have all shown that if you reduce LDL cholesterol below 30 milligram, there is benefit in reduction in percent atheroma volume. 1 year later, National Lipid Association of USA also created an extreme risk group in which they also recommended LDL cholesterol less than 30 milligram. This was 1 year after our recommendations. As far as safety is concerned, statin, acetamide, PCSK9 is absolutely safe. And now we have a 4-year extension study in which PCSK9 inhibitor was given a median of 7.4 years. Mean LDL cholesterol was 28 milligram. There was no significant adverse effect either because of low LDL cholesterol or because of PCSK9 inhibitor. These are some of the comparison. It's a very complex slide between ACC 2018, Euro 2019, LAI 2020, and National Lipid Association 2021. So it will not be possible for me to go into detail. That shows that how we are placed. We are definitely different from others. Thank you very much for your kind attention.
Thank you, sir, for finishing your talk in time. And you have rightly touched upon the most important thing, how low the LDL should be. And your Indian guidelines shows it is less than 70, I think. And in comorbid condition, it is reduced to less than 50. But as you have already discussed, the atherogenic dyslipidemia is one of the important factors. And non-HDL cholesterol now has become assuming significance in increasing the CAD risk. And thank you for an excellent talk. I open the talk for discussion in the House.
Thank you. Thank you.
Wonderful presentation, Dr. Puri, just from the
Sir,
pages of history.
Dr. Puri, sir, please.
Yeah, you said 2014 you started, but Lipid India was there since 1996 with Dr. Sainani as the chairman, Dr. M.J. Gandhi as the editor-in-chief. You can see the slide. Myself, Dr. Chandalia, Dr. Shishya, V. Mohan, others were in the editorial board. And 2002, under the auspices of Indian College of Physicians, we published this monogram, Lipid Disorders, Implications in Management, co-edited by myself and late Professor B. Vidrupati. Yes, I want to share this everywhere.
Namaskar, sir. I am Dr. Iyer here, Dr. Raman Puri.
Sir, this side.
I am receiving your mails and I really congratulate you on all this. One thing basically still remains that why there is an increase in the lipids in our country in young people. So just to give a background that I am practicing sleep medicine exclusively sleep medicine in Mumbai. And I have seen young people developing coronary artery disease and everything. And they have anatomical factors on the face since the childbirth, like macroglossia, retrognathia, and this was discovered by Dr. Anil Hiluwala. He compared the skulls of Indians with the Western population, and they found that the upper airway is narrower in Indians as compared to the Western people. And that is possibly the trigger point for developing insulin resistance and all the lipids. We need to look into this, sir. And this may be, only day before yesterday, we had a patient having coronary artery disease with no risk factors. And only complaint was that he cannot sleep on his back, he had to sleep on prone because of macroglossia. So these are all issues which we need to look into, and possibly the whole science of insulin resistance and metabolic disorders possibly lies in the sleep, and there is now a research to show that sleep apnea is possibly hereditary transmitted in our country. And the sleep apneics, they run in clusters in families. And I have got several families where all of them are suffering from sleep apnea. This is a very new research, but may take some time, and possibly this has to be considered in the times to come. Okay, thank you, sir.
If you look into the ICMR in that study, 80%, more than 80% of Indian population have at least one lipid abnormality, lipoprotein abnormality. Of course, the commonest is low HDL cholesterol. There is no doubt that insulin plays resistance plays an important role, part of a metabolic syndrome, premature diabetes, coronary artery. These can all be explained by this, and even the obstructive sleep apnea is a part of it. I think that metabolic syndrome and insulin resistance is a very vast field to discuss about, but definitely it is one of the triggering factor for atherogenic dyslipidemia. Insulin resistance is one of the reasons for atherogenic dyslipidemia rather.
I wish to, one more happy announcement that I have introduced the term lean metabolic syndrome for the first time in the country, where sleep apneas who are lean and thin, no obesity, and still they have very severe sleep apnea with all the, with additional comorbidities. So this is something we have introduced for the first time, sir.
Good.
Thank you very much.
Thank you, sir. Thank you, sir, for your nice presentation. Sir, Lipid Association of India categorized that. I've read the article recently published. So, extreme group to bring down to LDL cholesterol to 30 milligram. How can we bring with these conventional statins? We have to add some non-statin drugs. We do have 3-4 drugs. PSK9 inhibitors are practically not possible in our pattern because it is injectable, costly, at least monthly one dose required. Second thing is ezetimibe with us. Why not we focus on bempedoic acid? So your view on bempedoic acid, sir, combination.
Yeah. See, we recently published a statement on intensive LDL cholesterol lowering in patients with ACS. I think that will answer your question. What we have recommended that in patients which you categorize as an extreme risk group, start with 40 milligram of rosuvastatin or 80 milligram of atorvastatin plus ezetimibe. Okay. First, don't worry about statin dose. 80 milligram is very safe. One of our study has shown that we get about significant reduction in LDL cholesterol, more than 65 to 70% with these two combination. Now, after you have achieved the target, whatever the level of LDL cholesterol lowering you have done, if you require additional LDL cholesterol lowering over and above what you have achieved with high-intensity statin plus ezetimibe, add bempedoic acid. If it is additional requirement is less than 20%, if further LDL cholesterol lowering requirement is less than 20%, then you add bempedoic acid. Over and above high-intensity statin plus ezetimibe. But take care of uric acid is very important because uric acid can go up, it can precipitate gout. And if it is more than 20%, then we have no other option than PCSK9 inhibitor. But with limitation, even if you give these patients high-intensity statin plus ezetimibe plus bempedoic acid, make sure that you treat all other modifiable risk factors, extremely important. And patient follows aggressive lifestyle intervention. I think in majority of your patient, without PCSK9, you will achieve the targets.
Dr. Puri, thank you for your presentation. The thing is that you are in the lipid guideline of India, you are stressing everything on the LDL cholesterol. But in the Indian context, what we see in comparison to Europeans, the LDL is not very high. Still then, you are stressing on it. But what about the non-HDL cholesterol? Because even if you reduce the lipids by giving LDL cholesterol to the much lower level, still then there is residual risk, what you have already mentioned. So, what is your target about the non-HDL cholesterol? You have not very much highlighted on that.
Okay. One thing is that LDL cholesterol is one of the component of non-HDL cholesterol, remember. And non-HDL cholesterol is total atherogenic cholesterol circulating in the blood. And remember, each lipoprotein has one ApoB. Now I'll answer your question. We are talking about LDL cholesterol because all randomized controlled trial so far have focused on LDL cholesterol. And if you look into our guidelines, we have, though LDL cholesterol is a primary target, non-HDL cholesterol is co-primary target as important as LDL cholesterol. And now in our recent 2020 update, and which 23 update, which is expected next year, ApoB is going to play an important, will have an important position in our targets now, because future will be of ApoB, because each atherogenic particle carries one ApoB. So if you know the ApoB number, you know that how many atherogenic particles are in the circulation. Then the role of LDL, because if there are 100 LDL particles, some will carry amount X of cholesterol, some will carry amount Y, somebody will carry X1, like that. So all LDL particles are not carrying same cholesterol. So and all LDL particle will not have same atherogenicity, because if you have smaller LDL particles, small density particles, they are more atherogenic. So what we are now going to do is that ApoB is going to be our secondary target now, because our recommendations are very clear: achieve LDL cholesterol, achieve non-HDL cholesterol, and achieve ApoB level targets. These are extremely important. All three are extremely important. You cannot stop with LDL cholesterol. You have to treat non-HDL cholesterol.
Thank you. Thank you, first. Let us finish the talk. And mementos for the organization. Sir, Dr. Puri, sir. To start with, we'll have to have the second talk, Back to Basics. Our speaker for this talk is Dr. Anuj Maheshwari. All of you are aware of him. He is the professor and head in medicine, BBD University, Lucknow. He is a fellow American College of Endocrinology. He has got 57 papers presented at International National Flora, 44 publications on diabetes, hypertension, and its complications in index journals. He is a reviewer in Elsevier Journal of Diabetes and its complications for the last 10 years, and is Well-Being Champion 2018 by American College of Physicians. Dr. Maheshwari, and stage for you.
Thank you, Chairperson, for the kind introduction, and congratulations and thank you, Dr. Jain Panda, for the nice congress and this nice topic to be given. Dr. Jain Panda asked me a few days back, suggest some topics for the conference. I said him take the lead from the ACP program, and he has given me the theme topic of the ACP to speak me here. But it's good. Sometimes we should speak which is not exactly science, which is not exactly what we day-to-day practice, which is for our own introspections also. Science updation and medicine updation is a spontaneous and continuous process. But once upon a time, we should get an opportunity to introspect in ourselves and think, are we really doing the needful, what we should do? So this my topic is on the back to basics. Do we need to go back Osler's medicine? So before we know how to go with the Osler's medicine, we must know about something about the Osler. This saying you must have heard about many physicians, that good physician treats the disease, the great physician treats the patient who has the disease. And this saying is of the William Osler, and he was one of the outstanding clinicians who possessed extraordinary charm with inspiring many people. He has been very much regarded in the 4 countries. He was having a position in the 4 institutions. He has been a person who has stretched the bedside teaching, hard work, medical history, and lifelong learning. And all these things actually been taught by our own teachers also when we were in the medical school. But somehow we are not actually passing all these things to our own students, and they are not really thinking about the importance of these things. Dr. Osler was the prolific writer, and he has written the textbook which has been most popular and widely read by across the world. His humanistic philosophy was reflected in all aspects of his life. He blended the art of the medicine as well as the science of the medicine together to bring out the valuable role model for the students and physicians. So when he was asked once that whether what he should be liking to written on his gravestone, he confidently stated that he wanted to be known for his teaching, educating the medical students and always being near the bedside for the patient. I still remember my teacher, Professor A.R. Sarkar, was the same saying telling to us when we were medical students. Dr. Osler curated the infamous novel ideologies that still continue to thrive in the fraternity of the medicine across the globe, from inventing journal clubs for the medical professional to introducing the residency way of the learning and teaching in an effort to keep the physicians educated and informed at every step by their peers. So let's talk about the learning from the Osler's medicines and Osler's idea and looking for that, whether they are really relevant nowadays or not in today's practice. Variability is the law of life, and as no 2 faces are the same, so no 2 bodies are alike, and no 2 individuals react alike and behave alike under the abnormal conditions which we call disease. The question that matters among the many questions that might be asked about healthcare, perhaps 3 stand out. Is healthcare a service or a business? Will it be best achieved by cooperation or by competition? Whenever we think about this line, you must be remembering many of our colleagues and many of our fraternity, medical fraternity people compete with each other in a way. Whenever the patient comes to them from our neighbor physicians, they think that he was not right, I am right. So these kinds of the competition is actually not the way of practicing in medicine. We should be cooperative to each other, and probably this is one of the important reasons because of the what our profession is facing so much of the crisis in these days. Are medicines and nursing professions or trades? This is again a question which we should ask ourselves. Are we really dealing with the profession or we are sitting in the trades? So if we ever look back, refresh and reset, we must be knowing and we must be remembering that we all had done some or other mistakes in our life. But problem is that the mistakes which are being done by medical professionals, they are not acceptable just because they are endangering a person in the for his life. Although there are other professionals also, when they make mistake, person's life can come in the endangers, maybe lawyer, maybe advocate, maybe other people's, but they are getting an opportunity and they are having a room to correct it. But whenever a mistake occurs at the end of the doctor or end of the medical professional, the room of correction was not there. Room of correction usually doesn't remain there. So many a times there may be a mistake when wrong route of the administration of the medicine might have chosen. Sometimes the overdose of the insulin might have been given by some patient who has used a syringe of U40 instead of U100. Overdose of the methotrexate or any other medication can be given for any disease might have been occurring. But whenever these kinds of the mistakes occurring on the medical person or medical health provider, this becomes the big issue always, and he has to face the grievous consequences, while this does not happen with the other professionals. So let's take the basic roots. Art, which is called care, has the three important C's: collaboration, communication, and care. Probably this collaboration is also lost among we physicians. Because of that, we face the severe consequences of our small mistakes. Whenever we do small mistakes, they are taken up, they are highlighted, they are brought up by many of the society people, may it be media, may it be press persons, may it be lawyers, may it be judges, may it be politicians. Every time whenever the politicians comes to our forum, they always, you should be more careful, you should be doing surveys, you should not be running behind the money, and so many other kind of the preaching we had to receive. The biggest drawback for this is that we are having a lack of collaboration. We are not helping each other, we are not coming together while any person is facing any crisis. Then communication. A lot of things has been talked about the communication. We are working on this also. Even MCI has also, NMC has also added this thing in the medical curriculum now. How can we improve the communication? Communication between patient to doctor, patient to doctor and patient's relatives, but the very important communication which is still lacking, that is doctor and doctor. We meet in the weekend CMEs, we talk about the science, but we never ask and we never talk about the professional issues which we are facing in our day-to-day. Many a times it happens, if some doctor is facing some problem, he doesn't discuss with the colleague. He thinks that if I will discuss with my colleague, probably my colleague will think that he doesn't know even this thing. Although he might have been facing the similar kind of a problem in his also. So communication is the key. And importance of the effective communication among healthcare professionals is very much needed. It's not only the communication I am talking about, which should be between patient and doctor, which should be between patient relatives and doctor, but it should be between doctor and other healthcare professionals. Because this can only bring the good quality of the patient care, safety of the patient, organized medical record management, reduces the casualties and team satisfaction and efficiency. And whenever this poor communication is there between healthcare professionals and patient, we see the consequences in the form of the incorrect recommendations, which may lead to poor patient experience, which may give to wrong diagnosis and wrong prescription, and finally the irregular follow-up. Patient stops coming to you, or he probably does not come back to even any clinician. Many of the times I have seen patient comes to me and he says that for last 1 year I have not gone to any doctor because I thought that probably no one can treat my diabetes. Why? Because he was not finding the consensus among various physicians with whom he is visiting. He was not finding they are on the same page, he was not finding they are on the same line. But terming up the right way can be achieved through the four important things. One is the determining care objectives, construct the care plans, identify the risk and outcomes, and conduct the treatment. And all four things can be achieved by the teamwork. And team should not only be the people, those who are working in your hospital or working in your clinic, but that team should also be of your own colleagues who are working in different clinics, in different hospitals, but they always should be together as a team whenever a crisis or a problem arising with one person. That way, only we can solve multiple problems which are coming from the admission to the discharge of the patient, like physician's plan, patient safety issue, even doctor's health issues, expected outcomes, whether they are coming up or not, what are the plans of the adverse risk, and what are the discharge advices there. Many a times it has been seen that doctors are not even worrying of their own health while taking care of their patient. I know that United Nations has given the resolution in 2016 that all hospitals and all clinics should stop using the mercury sphygmomanometers because it is injurious for the health of the healthcare workers. But still I see whenever I can see that primary health care center, whenever I visit to primary health care center or anywhere, we see that doctors are having the strong trust on the mercury sphygmomanometer instead of the computerized one, instead of the oscillometric one. So as far as we talk about the primary health care in India, the foundation is on the four things. One is the prevention, another is the promotion, cure, whether it can cure or not, curative, and then rehabilitative. The most important things what should remain at the primary health care is the prevention and rehabilitation. Of course, you may go to the super specialist or sub-specialist for the promotion or curative. Cure is a very big thing, may not be achieved with the various diseases. But if you can have your focus on primary healthcare, what is happening in our country. We are focused on the development of the super specialty only. We are focused on the development of the super specialist hospital. We are focused on the development of the more of the cath labs, more of the highly specialized centers, more of the kidney transplantations and more of the dialysis machines. But if we can focus on the primary health care, probably we will not be needing this much of the highly specialty center, we will not be needing this much of the cath lab, this much of the dialysis machines, because patient may be stopped much earlier before going into the complication. So prevention is not from the disease, but prevention from the complication is also very much important, and that should always be tried. Cure, whether it will come or not, is a thing which may come or may not be there. But rehabilitation, even we are not telling our primary healthcare workers and primary healthcare physicians how to rehabilitate the person who is coming after the from the tertiary center. We have seen a lot of patients are going for even their rehabilitative therapies to again and again to the tertiary care centers instead of getting that from the primary healthcare center. So shift to primary healthcare is very much important. And our focus should be shifted there so that more and more primary health care can be stronger. Osler's methods of the medicine has said and has focused, and he believed that all medical students should be taught at the bedside instead of having their heads permanently buried in the books. But nowadays what is happening? We can see our medical students, we can see our kids, those who are reading or those who are studying in the medical college, they are mugging up the books continuously, and they are not really going to the bedside. And COVID has also increased this problem, because in the COVID times, we ourselves stopped our kids to go near the bedside. It is much more important to know what sort of the patient has a disease than what sort of the disease a patient has. But it is important we should make it learned and make it understood to our forthcoming generation of the medical graduates. So whenever we do the physical examination, it is a vehicle for teaching diagnostic thinking. But many of the time this art is going abolished nowadays. Just I'm finishing it. Gathering information by history taking and physical examination is a very important part of medical teaching and any diagnostic procedure. Next, you should know and you should learn of your medical undergraduates that how to interpret whatever information they have gathered by taking the history and physical examination. I still remember when I was the postgraduate, our head of department was not accepting any bedhead ticket or any case file of the patient in which we have not added any page for the history taking. So if we have not added any page or 2 page for the history taking, it was not accepted. So these kinds of the things has to be developed in our forthcoming generation. Forming a differential diagnosis from the gathering information of history and post-physical examination and interpretation, whatever has come up, and finally deciding what else you can look for out of the diagnosis, whatever you are getting of these information. Many times we have seen whatever the diagnosis comes earlier, when the workup is complete, that completely changes. So remediation comes only when all the process are coming up gradually in each and every individual, and it should be a process of learning from teachers, medical students, as well as postgraduates. So turning the vision into reality, we can lead to the value-based healthcare, and solution will come through all these principles being followed. So whenever the behavior is unaffected by conflict, then only we can have a better care of the patients, which includes the process, the competent care system, positive user experience, quality care to the patient, and patient may feel that he is getting the quality care. He may have the confidence in the system as well as with economic benefit. On the other hand, all the objectives can be achieved if we can handle the issue of the population. Population is disturbing all our plannings, all our policies, whatever being made. Governance, of course, the policy makers, system of the insurance, health sectors, non-health sectors are also playing an important role on making the foundations of the better health care, while the accessibility of and organization of the care is the important issue, which is a conjoint efforts of all these 4 or 5 work fronts which are making the foundation of the good health care. So basics to be kept handy always. Whenever we have the health issues, we must be aware of the rising health issues, how can it be moved on with the patient security and best safety guidelines, and followed by the how many targets can be achieved and how the technology can hold up it and how it can be taken care by the current computer, and legal and political shift should also be taken. So rise of the empath, ACP India chapter is doing and trying its best on its values to develop the high value care initiatives and developing the medical ethics and professionalism, and it is very much important to be started at our own API level also, so that we can make more and more better undergraduates and postgraduates. The lessons of this talk and this lectures could be developing rapport with the patient, students, and colleagues, careful observations and applications of the clinical methods to develop a working diagnosis, and treatment based on the emerging scientific evidence should be followed and should be developed, and publishing the findings for a wider audience is an important issue. We are also weak in the publishing. Whatever we see in our clinic, probably we may not be so much confident that we don't publish that. And because of what our data is also poor, at the same time, our colleagues are also deprived the information what we are learning and we should share with them. The concept of a patient-centered care, learn to study patient, not cases, individuals, not disease. So one of the very much important duty of the physician is to educate the masses not to take medicine. How can it be done? Once you will be involved in them, how to keep cleanliness, how to keep them free from the disease, how can you do the prevention of the disease. So behavior which is unaffected by the conflict, the practice of medicine is an art, not a trade, a calling, not a business, a calling in which your heart will be exercised equally with your head. Thank you very much for the kind listening.
Thank you, sir, for an excellent talk. And in the interest of time, we don't keep any questions. Anyone, any doubt, can discuss with sir during lunchtime.
I think this is more of the introspection than to ask questions.
Yes, thank you, sir. The organizers, please come. Sir, please. Sir, moment please.
Hello. Now I call Dr. Krishna Sisadri is invited to give his talk, please. He will be talking on exogenous Cushing's disease. He is working as senior consultant in endocrinology and diabetes at Apollo Hospital, Chennai, India. And he has been awarded by Endocrine Society for the year 2009, Sam GPS Moses Oration by the Research Society in 2014, and Research and Publications Award, a Pride on Thyroid Research. So I request Dr. Krishna Sisadri sir to give his valuable talk. Sir, please.
Thank you very much. Thank you, Jayant, for this opportunity. You know, my interest in the history of Odisha is very large, and largely because of the invasion of the Cholas into Kalinga in many years, and how that was repaid by a very iconic statue that still exists in Puri. It is called the Kanchi Ganapati. It's because of the invasion of name loses it. So into Kanchi, and then took away the Kanchi princess, King Purushottam Deva, and beautiful history. So with that, and I'm hoping to spend the next 2 days, and did I tell you I love Odia food, and also to tell you that Rasgulla in Orissa tastes much better. I won't say this in Bengal. So with this, let's talk about exogenous glucocorticoid excess. I have no conflicts of interest. I'm going to get some of our patients. There's a 55-year-old man who had ankle pain, was on glucocorticoid for 15 years, has leg pain. His physical exams showed acanthosis, obesity. He had horizontal striae. Somebody had stopped the medication, and the cortisol on 6/9/21 was 1.09 micrograms per deciliter. So here is someone who had the consequences of cortisol excess, which is a Cushingoid syndrome, and then leading to adrenal insufficiency, which is actually the greater problem that we don't recognize, right? And so here's a patient that we had to treat. I'll talk about it. I just cut and paste from our own EMR. These are regular patients. So since the first synthetic glucocorticoid was introduced in the 1940s, and very interestingly, I'll talk about it, one of the first persons who took it was a man who changed the history of the world, John F. Kennedy. But most of these are very similar, and they all cause adverse events. So every medical student knows these, that include the Cushingoid appearance, the weight gain, the hyperglycemia, the cataracts, the exophthalmos, the cardiovascular outcomes. Most of us do not understand that glucocorticoids also have cognitive dysfunction. Cushing's disease itself is known to have cognitive dysfunction that does not go away with pituitary surgery. Similarly, long-term glucocorticoid use does cause cognitive dysfunction that we don't talk about it. Remember, of course, then steroid psychosis is one of the things that happens. I'm not going to spend too much time on this. Most of you have seen the things. I will move on to look at how this works. Traditionally, this is the approach to Cushing syndrome. You have a clinical suspicion, you have a screening test, you have confirmatory tests, you have a test for ACTH dependency, and then you try to localize. This is one of the examples of using of what happened. This is Pott's disease. This is John F. Kennedy, of the spine. And then he was given cortisone acetate as an injection from Switzerland. Interestingly, in the 1960 elections, that was the first time it was televised, and Nixon was winning the elections by a margin, but then cortisone acetate was shipped from Switzerland. And John F. Kennedy took steroids and went to the television debate. And those of who saw the television debate then realized that here is a winner. And I'll tell you that cortisone, its good parts, won a presidency. However, it causes a lot of problems. One of the interesting things about cortisone acetate is if you use it, you know that it would use it because it would cause nodules in the ear. But the modern steroids are not like that. You don't get the Kennedy syndrome, right? So when you think of Cushing's syndrome, you really want to do a 1 milligram dex suppression. I'm not going into Cushing's disease, so 1 milligram of dexamethasone at night, 8 milligrams in the morning. If it's more than 1.8, it's Cushing's syndrome. Remember that these could be for other things. When you have, in the olden days, a lot of assays could pick up all these synthetic steroids as cortisol. Today's assays are much better, so you're not going to see this, you're going to see suppression. So don't depend on the dex suppression, use your clinical suspicion. Ask a deep history, and I will tell you that history should not include just oral medications or IV medications, but inhaled steroids and topical drugs, especially skin, and I'll show you the potency of some of these drugs. And I would also tell you also ophthalmic eye drops. People use steroid ophthalmic eye drops for years and we don't think about it. But a good history, as Anuj was talking about, back to the basics, it is William Osler who said, hark, O physician, the patient is telling you the diagnosis, which means that the history is a diagnosis, the tests is immaterial in this particular condition. So just to tell you this cross-reactivity, so some of the synthetic steroids can show up as steroids, but nowadays most of them are not, right? If you find you can do a 24-hour urinary free cortisol, again, remember, a history should allow you not to do this. If you've come this far, an ACTH level that is suppressed will tell you that this is exogenous steroids or adrenal. If you do a CT scan, the adrenal will be atrophic or normal depending on the duration of steroids. My suggestion to you is, you don't have to do this. Get a history. So very rarely, and in 1 to 2% of the population, they will be taking steroids surreptitiously and you will not get the history. This is for those kind of patients, and if you suspect it, you could do a steroid assay using LCMS, right? A caution, I'm a big fan of Ayurveda, but there are a lot of Ayurvedic physicians and Siddha physicians, in Tamil Nadu Siddha is big, who would mix steroids with the drugs to get the benefit. And many of the time, one of the questions I have learned to ask over a period of time is, besides asking all the other drugs, what is the over-the-counter drug, what are the drugs that other doctors are giving you, ask people, are you taking an Ayurvedic drug or a complementary medicine drug? Simply because many of these have steroids in them, right? So just to tell you that if you look at an ACTH stimulation test, which is 250 micrograms of cosyntropin, give it, 1 hour later, you get half an hour and 1 hour later, you can get a steroid sample. And if it is less than 20, it means that there is ACTH HPA suppression. If you look at this, patients who are currently taking steroids, there is a 35% incidence of HPA suppression, meaning if you're taking steroids now, your hypothalamo-pituitary adrenal axis is suppressed. You are in many ways adrenally insufficient besides being this. Second, if you've taken steroids in the past, and it can be up to 1 year, it can be even longer, there is a good chance about 12 to 15% of patients will have HPA axis suppression. So the longer consequence for us to remember is that even after the steroid goes away, its effects in terms of suppressing the adrenal stays on. While it is the highest with the oral drug, I want you to know that the inhaled route and the topical route, the intranasal route and the ophthalmic route also cause HPA suppression. This is sort of telling you the potency of steroids. I always remember 1,425 or 1,525. That is 1 milligram of dexamethasone equals to 4 to 5 milligrams of prednisone and prednisolone and 20 to 25 milligrams of hydrocortisone and cortisone. This is the potency, correct? Now, our dermatology colleagues are far more efficient. They have humongous number of steroids. Of these, the top 3 are something very, very important for us. For example, this is clobetasol propionate, right? And then the second group, which is the difluoroalazone diacetate, and the third one, which contains triamcinolone acetonide. These 3 groups are very, very potent. They are very anti-inflammatory and therefore very, very HPA suppressive, right? And many times patients use it as face creams, skin creams, and you would not know, you would find that their skin has thinned out, that some of them are using it to de-darken themselves, to become melanin impaired. But what is really happening is that their HPA is getting suppressed. This is an example of a patient from I just did a search of our last 3 years about, I looked at about 10,000 patients that we have the last 3 years. I was able to find HPA suppression only as, I do problem list, I actually HPA suppression, only 10 of the patients referred to me. But I can tell you that means this is a pandemic that we are missing. Because the amount of steroids that is being used in the community is huge. And in an endocrinologist practice, if only 10 patients are being calculated as HPA suppression, it means that either I'm not seeing them, but it's quite possible that many of us are missing it. So here's a child who has asthma since childhood, has been steroid inhalers, occasionally goes into the hospital to take steroid injections for asthma. And you will notice that he also has HPA suppression. His cortisol was 0.8 when we measured it. So clearly, this is a person who was taking fluticasone and combination of beclomethasone and what is Seroflow and Serotide. So that is what this person had. So with inhaled steroids, if your dose is more than 400 micrograms per day of beclomethasone or 500 micrograms per day of fluticasone, then there is a 50 to 60% incidence of HPA suppression. So when we start, how do you prevent this? You start thinking about it. But is it the same in everyone? It's variable. It's quite possible that it's a variation in the way that the drug is metabolized. But the one thing that we know is, irrespective of the drug that we use, the greater the potency, the higher the dose, the more it is likely to cause HPA suppression. So in many of these patients, the HPA is suppressed, and you really want to be putting them back on a physiological replacement of glucocorticoids. What I do, I use hydrocortisone, which is now freely available, and the general dose is, you really don't need an adrenal suppressive protective dose. You just need a pituitary protective dose, which is around 12 micrograms per kilogram body weight. I use about 10 milligrams of hydrocortisone in the morning, and 5 and 5 in the afternoon and evening, and then slowly take it off and taper it down. But we'll talk about it in a moment. But the most important thing is to, how do you prevent this? The first question when you want to start a steroid is to ask, is it needed? Second, are there alternatives? In rheumatology, both of these are present. In dermatology, am I really the answer is to always combine, for anything you combine an antifungal and an anti-inflammatory. Is it really required? Are there alternatives? Second, when can I take it off? What is the shortest duration can I use it? Can I use the lowest dose that is required? Second, is this potency, do I want to be known as the most famous doctor and use the highest potency? Or be a safe doctor and just use the right potency? Okay, I need to use a higher potency. How quickly can I get it down to a lower potency, right? So these are the strategies that we really need to do when we think about this. And keeping this, I know this sounds silly, but if you want to, I'll send it to you as a screenshot and keep it in your desks, because it makes sense. Every time you want to prescribe, think about it. Is it required? Is there an alternative? What is the lowest dose I can use? What is the lowest potency I can use? Can I switch it to a lower potency as quickly as I can? And what should I think about as complications? What about glucocorticoid taper? Everyone thinks that alternate day glucocorticoids is great. There's no data to support it. Second, taper based on the anti-inflammatory and not in terms of adrenal, meaning a lot of times when you taper, what happens? The disease flares up. So if you have to use it, you have to use it, and we have to protect the patient. But if you don't need the steroid, quickly taper. and bring it down to the physiological dose. And I will tell you the physiological dose is only about 12 micrograms per kilogram body weight. It will work out about 20 milligrams of hydrocortisone per day. You don't need the 30 milligrams, right? And then put stress coverage. From then on, you lower it slowly. If you want to, go by 2.5 milligrams down and stop it. Some of us who believe in the olden way of doing it, we bring it down slowly to 10 milligrams and then measure cortisol. Stop the drug for a day, measure the cortisol. If it is more than 10, bring it down further. If it is less than 10, leave it on that dose till you can do it again. And I can tell you there are some patients of mine, some of them who have adrenal adenomas, who are still on 10 or 12 milligrams of hydrocortisone for almost 5 to 6 years. What about stress? So remember that a lot of times we use too much in stress also. The normal basal secretion of cortisol is 8 to 10. During minor surgery, it goes up to 50. For example, hernia. And then greater surgical stress is only about 75 to 100 milligrams per day. Only in trauma and major sepsis is 200 to 500 milligrams per day. So clearly, you need to think in someone who has previous history of glucocorticoid exposure, does this patient require stress? One, it's not required in any dose less than 3 weeks. If you're only giving a morning prednisolone dose of less than 5 milligrams for any duration, or if you're giving alternate prednisolone for any duration, or more than 20 milligrams of, what is required? If somebody has taken 20 milligrams of prednisolone or equivalent for more than 3 weeks, or if they clinically appear to be Cushing's. Can I take a minute more? In the intermediate dope, you could either use the medication or you could measure cortisol levels or an ACTH stimulation. I don't do ACTH stimulations. What do you do? For surgeries, minor procedures under local anesthesia, you really don't need extra supplementation. This is a change from the olden days. Second, for moderate stress, use 50 milligrams of hydrocortisone just before the procedure and 25 milligrams every 8 hours for 24 hours and then stop or resume the usual dose. For major surgical stress, 100 milligrams for induction and 50 milligrams every 8 hours for 24 hours. So it's no longer that high dose steroids that we used in the past. This patient, before I conclude, one of the important things that people forget is osteoporosis. This patient has used glucocorticoids for 30 years, looks very Cushingoid, osteoporotic. Think about it. One, the dose, there's an increase in risk for with as low as 2.5 to 7.5 milligrams of prednisolone. Fractures can occur in 38 to 50% of users. Start using DEXAs and the FRAX score. I don't have time today, but we can talk about it another day. Remember that in patients who you anticipate giving steroids, make sure you calculate their fracture risk and based on that, start using therapy. In this particular patient, I believe in teriparatide as an important use. He couldn't afford it. We used a single dose of zoledronic acid. But that's another talk for another day. But don't forget osteoporosis. To summarize, exogenous glucocorticoids is the most common cause of Cushing syndrome. But I want you to remember that exogenous glucocorticoids is the most common cause of adrenal insufficiency in the world. Prudent glucocorticoid use is critical in preventing this pandemic. Thank you for your patience. Really appreciate this.
Thank you, sir, for your kind and brilliant speech. We are mesmerized by your speech. So, as there is short of time, I request the audience to get their doubts clarified or discussion with you during lunch hours. Thank you, sir.
Thank you.
Please wait for the momentum.
Now I close the session.
So I can go now? Okay.
Thank you, esteemed dignitaries, for your enlightening speech. I would request the chairpersons to proceed to the memento podium for felicitation. Moving on to the next session, I would like to request Dr. Sam Sundar sir to kindly adorn the stage for conducting the next session. The chairpersons for the following session will be Dr. CBK Mahanti sir, Pro Vice Chancellor, KIT University, Bhubaneswar; Dr. Purnachandra Das sir, Professor and HOD of Medicine, SCB Medical College, Cuttack; and Dr. Samir Sahu sir, Professor and Head of Department of Medicine, IMS and SAM Hospital, Bhubaneswar.
Good afternoon. Now this is a very important session because this is the presidential oration, API presidential address. So we'll be listening to our President, Dr. Sam Sundar, and he has chosen a topic which is very, it has been a neglected tropical disease, very rarely discussed and very rarely experienced also. So in our ODISHA, I think there is very less number of patients are there in this. We have hardly come across, but this is an important disease because many times it's not diagnosed and not discussed, and patient die. We are in a confused state. I request my co-chairman to introduce the speaker.
Okay. Thank you, sir. Very good afternoon to everyone. And actually, it doesn't need any introduction, but to complete the protocol. So, he is Dr. Sam Sundar, the Distinguished Professor of Medicine, IMS, BHU, Varanasi. He is the current President of Association of Physicians of India. He has 50 awards to his credit, and he has a chapter in the Bible of Medicine, that is Harrison's Principle of Medicine, from 18th to the current 21st edition, and that is, of course, leishmaniasis. He has also a chapter in Davidson's Principle of and Practice of Medicine from 20th to the current edition. And his research grants in several international projects have been huge 70 crores, 636 publications with a very high H index, that is 99, and a whopping citation of more than 39,000. And above all, he's a very good human being. I had a chance to interact with him. He was the MCI assessor once to our college. Welcome, sir. We love to hear you.
Thank you. First of all, I really grateful. I am grateful to Dr. Panda, the lovely and dynamic member of our governing body of national governing body, and the organizing team for the lovely reception and hospitality and the invitation. I've been working on visceral leishmaniasis for more than 30 years. So I thought that I'll just tell you the story that we could develop in this disease. This is a girl where you can see that the large spleen is trying to come out of the abdomen, is so huge. And the fever and splenomegaly are the hallmark of this disease, also known as Kala-Azar. Usually, there can be hepatomegaly, in advanced cases, pancytopenia, and bleeding manifestations, and jaundice. Now, diagnosis is classical diagnosis by parasite demonstration, but by parasite demonstration is not possible in smaller places, and even then, even if you do it, it is expensive, and it cannot be done very quickly. It takes few days to diagnose the disease, So patient keeps on wandering from one place to other. This is just a process of splenic aspiration being done. This is the parasite mastigotes you can see here inside the macrophage, large number of hundreds of macrophage. Then an antigen was discovered by Steve Reed, who is a good friend of mine in Seattle, RK39. This is 39 amino acid antigen, and it is coded in the kinesin region of, conserved in the kinesin region of mastigotes of L. donovani and L. infantum. So rapid strip tests were developed for this because in ELISA, plate ELISA, it was found that it has very high sensitivity and specificity. So results were available in 10 minutes. These are the strips you can see on the right hand side. There are two lines, one test line, one control line, and these three patients were positive and these two were negative. So we did a study with 127 patients, and you can see that the sensitivity was 100%. This was the first study in the world. And then the specificity was also very good, 98%. So this method actually gave us a tool where you can make the diagnosis in 10 minutes rather than several days. PCR has been used now recently. We have also the capacity to do PCR and qPCR. But again, the cost of equipment, reagents, skilled worker, etc., and continuous electricity, they limit the use of PCR in peripheral health facilities. Now coming on to treatment, my favorite topic. Treatment historically has been dependent upon pentavalent antimony compounds like sodium stibogluconate, but they are associated with very high incidence of toxicities, serious toxicities also, and the death can be more than 5%. In 70s, there was several reports of that some patients are not responding to these doses. So first study was done where you can see that 600 milligram, maximum 10 milligram per kilo was given for total of 20 days. Cure rate was 96%. And I just bring it down to the current studies between 1997 to 2004, where you can see that the cure rate has gone down to 35%. So 65% patients were not responding to antimolars. As here you can see that the disease was fatal in 15 patients, almost 7%, and the cure rate, as I told you, 35%. So the National Expert Committee in 2000 decided that we have to stop the use of antimony in these areas and use amphotericin B. Amphotericin B is it's a pollen antibiotic and used as about 1 milligram per kilo every other day intravenous infusions. You have to give 15 to 20 infusions every other day. It can have serious toxicities like hypokalemia, refractory hypokalemia, myocarditis, nephrotoxicity, and sometimes deaths also. But the good point about amphotericin B is that the high cure rate of 96%. This is just a picture from our wards where you can see everybody is receiving amphotericin B infusions from child to adult. So the problem was that this use of amphotericin B was restricted to the hospitals only, and the patient has to be in the hospital for 4 to 6 weeks. That meant that if you have 50 beds, you can treat 50 patients only in a month. And we used to have OPD where we got, in a week, we used to get 50 to 70 patients. So it was very difficult to turn away these patients. And it could not be implemented again at the periphery health facilities. Then came another drug, oral drug, miltefosine. And this has an excellent anti-leishmanial activity. And then we did a pilot dose escalating study for VL, for Kaladar in 1997, and we found that 100 to 150 milligram would cure more than 93% of patients. Then we did 3 phase 2 studies, and including 2 in children, and we found out that in adults, the dose of 100 milligram, those weighing more than 25 kilo, is 97%. Then we did a phase 3 trial, which led to the registration of this drug, first registration in the world of this drug for leishmaniasis. And here you can see that the cure rate is 94% with miltefosine and 96% with the amphotericin B classical. It was a control arm. And so you can see that it has a very high and comparable efficacy with amphotericin B deoxycholate. So we concluded that in these doses, the amphotericin B for 4 weeks would cure most of the patients. It had GI side effects like vomiting in 40%, diarrhea in 20%, and it was potentially teratogenic, so cannot be used in pregnant patients or those female with childbearing age group who do not want contraception for about 5 months. Then in 2005, Kalajar elimination program was launched in India, Nepal, and Bangladesh. And in 2005, the miltefosine was the prime drug which was selected because of the ease of use, and it was an oral drug, could be used anywhere. It had good advantage, great oral advantage, easy to use in the program, but again, 1 month of treatment, potentially teratogenic, sometimes adverse events, and long half-life. So all these were demerits of this drug. Then we went on to another drug, peramomycin, which is a aminoglycoside, and in several phase 2 studies, it was found that this drug cures more than 93%, and this was studied by Dr. Jha and Dr. Thakur in 1998. The big point, positive point was that it is produced in India. It is the cheapest anti-leishmanial drug. Unfortunately, it could not, the pivotal phase 3 trial could not be done because of the lack of funds, so registration could not be done. Then the Gates Foundation came up and they funded this phase 3 trial, which was again done in 500 patients, roughly 500 patients on peramomycin, and 166 patients on amphotericin B, which was control. Again, the final cure rate was quite high, more than 94%. There was reversible ototoxicity in very small number of patients, no nephrotoxicity, and it was quite affordable. Peramomycin was approved on the basis of this study in 2007. Then came another wonderful drug known as liposomal amphotericin B, and this lipid formulation is the most exciting development in this treatment of leishmaniasis. It was possible to give high doses in a small period of time. In a single dose, you could give very high dose, zero toxicity, very less toxicity. But the problem was, biggest problem was that it was very expensive. $200 would be the cost of 50 milligram of the drug. We did a study where this was done at 4 centers. We found that at dose as low as 3.75 milligram would cure 89% patients. So very effective, and in small doses also. Then the safety was so good. You can see that with amphotericin B, almost everybody had reaction. With Ambisome, 71% had reaction. They were very mild and was easily managed. Then we thought that now we have multiple drugs, why not combine them? Because we stopped using Ambisome because of its high cost. So we started multi-drug therapy trials. And this was the only way you could protect the new drugs. Again, duration was short, compliance was better, and less chances of development of drug resistance. So we did this study, phase 2 study, where we treated about more than 225 patients in 5 groups. Ambisome 5 milligram single dose was combined with miltefosine in various duration, and one dose had, one arm had ambisome in 3.75 milligram per kilo only with 14 days. And what you can see here, that the cure rate was really very high, more than 95% in all the combination arm. Then again, we went on to do another trial with multiple drugs, which was done in 2011 or 2009-10 actually, and it was more than 600 patients were treated, and they were treated with either amphotericin B alone as a control, or 5 milligram of liposomal amphotericin with miltefosine 7 days, or paramomycin for 10 days, or miltefosine and paramomycin each for 10 days. And the cure rate again, I have never seen such high cure rates with both per protocol and intention to treat analysis. More than 98% patients were cured. Then actually we have seen that the small doses of the ambisome or liposomal amphotericin B would cure more than 90% of the patients. So we wanted to use a single dose in this. This drug could be given in single dose up to 10 milligram, 15 milligram even. The compliance was very good, and it was very convenient to do, and objective was to determine the safety of and efficacy of the single dose of ambisome or liposomal amphotericin B. This was the first study that we did in late 80s and early 90s, where we showed that single dose of 5 milligram of ambisome would cure 91% patients, and if we gave 7.5 milligram, again, it was a multi-center trial in more than 200 patients, only 90% patient could be cured. So it was very clear that more than 5 to 7.5 milligram would produce a cure rate of 90%. We were not satisfied, but because of the high cost, we had to stop the work on this single dose. In 2007, the Gilead Sciences, which is the manufacturer of ambisome, it reduced the price of the drug to 8% of its original price, $16 for 50 milligram. And then it made more sense to do these development of this ambisome. So we picked a higher dose of ambisome to find out a cure rate which is much higher than 90%, because 90% was the lower limit of, lowest limit of expectation from these drugs. So we picked a higher dose of ambisome, 10 milligram. We gave 10 milligram per kilo in a single dose to conventional 1 month of amphotericin B deoxycholate, and the results were again fantastic. As you can see here, the definitive cure rate with single dose of liposomal amphotericin B was 95.7%. With amphotericin B, it was 96.3%. It was very comparable, no difference. And then this drug, we concluded that this drug was not, this dose was not inferior to amphotericin B classical, no safety concern, compliance is guaranteed, and patient will have to be in hospital instead of 1 month to 1.5 months for only 1 day, or may not be hospitalized. He comes in the morning, diagnosed, given the drug, and go in the evening or next day. So it was very fantastic. And this paper, which was published in New England Journal, was really path changer, game changer, I should say. And the Gilead Sciences, then inspired by our results, donated 10 lakh of these ambisome 50 milligram vials through WHO for free to low and middle income countries. So in 2013, it was the elimination program. After looking at the demerits of miltefosine, it was introduced as in the program as single dose liposomal amphotericin in both India, Nepal, and Bangladesh. And what was the impact? You can see the impact. There was a drastic decline in the number of cases. And now in this year, we had only about 850 cases in the whole of country, which was fantastic. From several 100,000 cases, as you can see this graph, where you can see that there are tall towers, hundreds of thousands, these 77,000 in 92, you can easily multiply them by 5 or 8 because there was under-reporting. And then, of course, it went on with amphotericin B, then again with miltefosine, not much decrease in the incidence. But introduction of single dose of liposomal amphotericin B really made a big change and brought down the disease to a very low level. And we are now achieved the elimination target, and hopefully we'll be able to eliminate the disease. So, to summarize, what has changed in these few years or few decades? Now you can diagnose Kala-Azar or visceral leishmaniasis in 10 minutes instead of few days or weeks. Miltefosine was the first oral compound which was developed by us, and it was the first time registered in India, and then it is now being used worldwide in various forms of leishmaniasis, in all forms of leishmaniasis. Single-dose ambisome became the drug of choice, treatment of choice, as I told you, and this treatment was preferred, first preference for WHO also as for South Asia. This disease occurs in 3 continents, Asia, Africa, and South America. It has different sensitivity to the drugs. Ambisome is very effective in South Asia, in our continent, as compared to other 2. Its use in Kala-Azar elimination program really led to achieve the elimination goal. And as I told you, we hope to eliminate this disease. Thank you for your kind attention.
Thank you, sir, for your very elaborate and vivid description about the Kala-Azar, because since it is not so common in our state, we have less experience in this disease. But as you have shown projected, you have dealt with a vast number of cases and you have done research in that. We are lucky and we are lucky enough to listen from you. I think this is a presidential oration. There should not be any questions and doubts. If you have any doubt, can discuss afterward. Thank you, sir. Memento, please.
Lights.
Thank you so much, sir, for throwing light into this grey zone of ours. I would request the chairpersons to proceed to the memento podium for felicitation. Coming to the next session,
I welcome our esteemed chairperson, Professor Dr. Jayant Kumar Panda, SCB Medical College, to the podium, and Professor Dr. Surendranath Swai, Professor of Medicine, Senior Visiting Consultant, Amiri Hospital, Bhubaneswar, to please come to the podium. This is Professor Dr. R.K. Parida Memorial Gold Medal Oration.
Welcome all. Actually, this is an excitement that in API Odisha we have introduced this oration. Professor R.K. Parida is the person who started Odisha API long back, 42 years back. He had the vision. He organized a national API at Kotak. That was in 1982. And in 1980, the API Odisha state chapter was formed at Berhampur, MKCG Medical College. So after 42 years of the formation, we thought that we'll start Professor R.K. Parida oration, and I must thank the family. They have come forward in the memory of Professor Parida, and the first Professor R.K. Parida oration was bestowed upon Professor Siddharth Das, who happens to be a national and international reputed physician with basic works in many fields. Not only that, his personal connection with Professor Parida was different. So with this, I invite Professor Das on stage, and as all of you know, he is Senior Consultant Medicine and Diabetes, formerly head PG Department of Medicine and Dean and Principal SCV Medical College, and he is a Founder Fellow of International College of Clinical Nutrition, RSSDI, Diabetes India, Fellow Indian College of Physicians, Uttar Pradesh Diabetes Foundation, Patron of Research Society for the Study of Diabetes in India, and honored by many honors with recipient of 22 national orations and 170 guest and update lecturers delivered, more than 150 publications in the peer-reviewed journals, 48 chapters in the textbook and the monograph, and the member of editorial board of several journals. And at present, he is a patron of National RSSDI, guiding the diabetes research and the activities all throughout the country. I request Professor Das to say a few words about Professor Parida, and after that we'll have family members. We have Mr. Sandeep Parida, son of Professor Parida here. So they'll take 2 minutes to share, and we'll go to the oration proper. Professor Das.
Chairman, State Chapter of API, Professor Jayant Panda, Dr. Surendra Kumar Swai, esteemed chairperson of this prestigious oration. I'm very much thankful to the Odisha chapter of API for entrusting on me the first Professor R.K. Parida Memorial Oration. Well, I'm experienced in delivering orations, but this is a landmark oration in my life. It's a red letter day in my life when I'm delivering an oration about my own teacher, named by my own teacher, who was my teacher as an undergraduate student, as a finalist student. He was my examiner as an undergraduate examination. He was head of the department when I was a postgraduate student. He was postgraduate examiner for me, the chairman of the department. To start, I offer my obeisance. Guru Brahma, Guru Vishnu, Guru Deva Maheshwara, Guru Sakshat Varam Brahma, Tasmai Sri Guru Namaha. Professor Rajkishore Parida started, if you look at his educational career, when Odisha was not separated from Bihar, it was a Odisha-Bihar combined state. We didn't have a university in Odisha. So all the degrees were affiliated with Patna University. In 1936, we got separated from Bihar on the basis of language. Odia language is a separate language. And then in 1944, Utkal University was instituted, so also this medical college in the year 1994. So Professor Parida did his matriculation and ICSE from Patna University. He is the only person from this state and very from this country who was educated in 3 continents. He did his MBBS from this medical college, which was then called as Odisha Medical College, and subsequently named as Ramchandra Vancha Medical College. He did his residency in the United States of America in University of Illinois, Chicago, 3 years residency, and got his master's science in medicine from there. Then he came to UK, did his DTMNH in London, and MRCP in Edinburgh, which subsequently became FRCP Edinburgh. So he's a rare academician who was studied in 3 continents of the world, starting from India to the United States. As a member of the faculty and administrator, Professor Parida was registered to Associate Professor in Medicine at SC Medical College, Cuttack. He was a founder associate professor, founder professor, and founder superintendent of MKCG Medical College, Barampur, started in 1961, and he joined that in 63, and he was the founder there. 70 onwards, till February 84, he was professor and head of medicine at SC Medical College, superintendent of SC Medical College, and also principal of SC Medical College when he was promoted as a director of medical education and training in 84. He was postgraduate and undergraduate examiner to several universities of the country. He was advisor to the Union Public Service Commission, Odisha Public Service Commission, Reserve Bank of India, State Bank of India, Fertilizer Corporation of India. Academic membership with Medical Council, he was member of Medical Council of India, member Senate, Utkal University, Barampur University, and Sambalpur University, all the 3 universities which is affiliated medical colleges, member Syndicate Utkal University, and life member IMA, API, Indian Association of Advancement of Medical Education. His role in API, he was a life member of API, he was a founder member and main architect in the formation of the Odisha State Chapter of API in 1980. He was organizing secretary of the 83rd Joint Annual Conference of API in 1983, January 83. You can see, I could not get this copy of the souvenir, but I had preserved the abstract book, and you see the abstract book was printed in Cuttack then. It was in 1983, and this was the podium as an organizing secretary. He was welcoming the delegates. He was president state chapter from 84 to 85. Professor Parida, besides being a brilliant student, was an ace sports person in his students' days. He was a good athlete. Reorganized the Department of Medicine and Medical Super Specialty in DMET, Odisha. Encouraged research in the field of tropical medicine and clinical nutrition. Socially very active in various philanthropic organizations. He was member of the Lions Club while at Barampur. And when he came to Cuttack, he became member of the Rotary Club and subsequently president of the main Rotary Club of Cuttack. He was a soft-spoken, ever smiling, a caring grandson to his grandparents. Even when he was professor head, his grandfather was surviving. So there is a photo, I think his son must be remembering the 4 generations together. And a loving head of the family, disciplined yet affectionate teacher and guide to undergraduates and postgraduates. He was not harsh. He never used hard words. He never expressed his annoyance, but his words were enough to make us understand that what he likes, what he doesn't like, what we should be doing, what we should not be doing. His smile speaks both ways. So it was, I think Dr. Surendra Swami must be remembering. Surendra Swami, and he was 1 year senior to me in the medicine PG. So all of those who have been postgraduate students, then we know the different ranges of his smile and then catch the hints that where he is happy or annoyed in the seminar, of course. Impartial examiner, leader, visionary, and a very amicable person in social life. Professor Arik Karpadia is irreplaceable in our fraternity. And that the API State Chapter has decided to install an oration in his name is definitely the due honor and respect shown this great legendary physician from Odisha.
Thank you, sir, for those words about Professor Parida. Actually, it's an honor to him, and it's a privilege for us to continue this oration year after year with the learned resource persons from all throughout the country. I now request Mr. Shandip Parida to come on stage and join a oration felicitation of Professor Das.
Sandip is his youngest son. He is an ace advocate in practicing in Odisha High Court. Asu. Take the lap, okay? Antone nahi bidesh padi.
Brief talk about this oration.
Good afternoon to all distinguished guests, and I'm privileged for this opportunity given by Mr. Jayant Panda and Dr. Siddharth Das, and I'm grateful to all distinguished doctors and youngsters for this oration, and this opportunity is bestowed upon me. And as you know that I'm not in this profession, but still I am so privileged to be here amongst all distinguished doctors. And my father, as Dr. Siddharth Das has already given enough introduction and about his career, I don't have to say anything more, add to that. Only thing I'd add is about something about his integrity. Just 1 minute I would like to say that even I was very interested in to study medicine, but unfortunately in 1984 I took the examination, but I could not clear, though my father was the convener of that year. But you know, as convener, he has access to the questions, the final question papers. Still, I could not clear. So for that, you know, the integrity of my father, and rest, Dr. Siddharth Das has explained enough, and I don't have to repeat anything more. And my elder brother happens to be a doctor, but he's not here and out of station. Otherwise, it would have definitely be very nice to have been here. And I'm very thankful to all the distinguished guests and doctors and youngsters for this opportunity to be present amongst all of you. And thank you so much for the opportunity.
Thank you, sir. Thank you for that gesture for most respected Professor Parida. Now we'll move on to oration, and I request Professor Schwein to introduce the topic.
I think because paucity of time, let me straight go to the topic of the oration. Well, I chose this topic.
The topic is proteinuric to non-proteinuric nephropathy in diabetes mellitus, a paradigm shift. Previously, it was there for the end-stage renal disease, the CKD, diabetic kidney disease. Proteinuria is an absolute clinical hallmark. Now there is a paradigm shift to non-proteinuric nephropathy. In type 1 diabetes 20% and type 2 diabetes 40%, now going into proteinuric to non-proteinuric diabetic nephropathy. So about that, Professor Siddharth Das, who is a very close friend of mine, he will speak about the paradigm shift from proteinuric to non-proteinuric nephropathy. Dr. Das.
Thank you, Chairman, sir. Hope I'm audible. Diabetes mellitus and nephropathy. Diabetes is a pervasive cause of end-stage renal disease in the Western population and a major contributor to the CKD epidemic worldwide. Nephropathy affects 20 to 30% of type 2 diabetics to the Western studies. Advanced renal disease attributable to diabetic disease accounts for 44% in USA and 30% in Europe. The most important thing, that epidemiological surveys unequivocally showed that reduced eGFR is more common among diabetic patients than in non-diabetic subjects, but also revealed that a large number of such patients will never show levels of proteinuria above the traditional definition of overt nephropathy, that is more than 500 milligram per gram of urine during their life course. Now, diabetic nephropathy in India, early works were done way back in 1975 to 78 under the aegis of WHO.
And they had taken albuminuria more than 500 milligram and serum creatinine more than 1.5. It was a multinational study where Delhi was one of the centers, and they found if you take the age group into consideration, as the duration of diabetes increases from 0 to 6 years to more than 14 years, the prevalence of nephropathy went on increasing from 9.3% to 23% in males and 4.2% in females to 13.6% in females. Another study was done in AIMS New Delhi, which analyzed mortality amongst diabetics, and you can see the death due to renal cause was 22.7%, 28.2%, and 40.2%. And then Medical Council also, Indian ICMR also showed that nephropathy was seen in 15.4% males and 13.9% of females. Now coming to the following the same methods, ICMR conducted a study in 9 centers in India between 1980 to 85 to 90, and they saw that diabetic nephropathy was present in 12.2% of males and 5.3% newly diagnosed type 2 diabetics. Now coming to the third bullet, pioneering epidemiological work done by the Indian Kidney Registry, it established under the aegis of Indian Society of Nephrology, have shown that diabetes mellitus is the cause of CKD in 31.2%. So if you take 100 patients with CKD, 1/3 were because of type 2 diabetes mellitus. Thus, it is immensely clear that increase in life expectancy, the burden of nephropathy in diabetics has exponentially increased. Well, this study was done in our own center when I was in service, and the main work was done by Dr. H.R. Vaidya. I think he is here very much. He wished me in the morning. Is he here? I think he was in the morning here. It is his work. And what we found, that 41% of patients had vascular complications, 54% had infection, 31.3% had CVD, 11.3% had CAD, 44% infection, and 16.6% has NFLD. But if you look at the nephropathy, strong association of age, duration of diabetes, serum triglycerides, serum cholesterol with LDL-C was with nephropathy, but only duration of diabetes was strongly associated with nephropathy and neuropathy. And 18.6% died due to diabetes-related complications. This is a very original book. This is the original book by Eric Mungenschen, who had classified or rather graded nephropathy from grade 0 to grade 4. And in his own publication way back in 1994, Eric Mungenschen has mentioned that if you look at type 1 diabetes, then called as IDDM, if you lack hyperfiltration, microalbuminuria, clinical proteinuria, the relationship and structural damage was well related to microalbuminuria and clinical proteinuria. Why I am showing this slide is, I want to draw the attention of the learned audience that microalbuminuria and proteinuria as a marker of nephropathy is well established in type 1 diabetes or IDDM. In the same book, when you go to the chapter of albuminuria and renal disease in an IDDM patient, the same textbook, published in 1994, if you look at the line highlighted with the yellow, the implication of microalbuminuria differ in several respects between the two types of diabetes. So microalbuminuria in type 2 diabetics is non-sine qua non of diabetic nephropathy as against in type 1 diabetes. Now looking at the diabetic nephron, what happens here? If you look at the point 1, if you find there is hyperglycemia, there is high blood glucose, amino acids, low sodium delivery, and so there is dilatation of the afferent vessels. As you go down to the descending loop of Henle, you have increase in sodium chloride, reabsorption, and glucose reabsorption. And as you go from the ascending loop of Henle, there is decreased distal delivery of sodium chloride. And if you go to the collecting tubules, you find there is vasoconstriction of the efferent vessels. And this is why what happens, there is vasodilatation of the afferent and vasoconstriction of the efferent is a classical mechanism of untreated diabetic nephron. Now, proteinuria, diabetic kidney disease 1, in an epidemiological study comparing secular trends in the prevalence of diabetic kidney disease in the USA across 3 time windows, 1988 to 94, 1999 to 2004, 2005 to 8, the prevalence of diabetic kidney disease defined as diabetes with albuminuria reduced GFR or both increased over time from 2.2% to 2.8%. Overall kidney CKD increased from 14.9 to 17.7%, whereas albuminuria tended to decrease. So this was started being observed way back almost 2 decades ago, that diabetic kidney disease, albuminuria as a marker, has started decreasing. Observation of the same database extended up to 2014 substantially confirmed that prevalence of albuminuria decreased progressively over time from 20.8% to 15.9%. In contrast, the prevalence of reduced eGFR increased from 9.2 to 14.1. So here is a discordance between increase in the prevalence of diabetic nephropathy and microalbuminuria in the urine. If you look at the effect of glycemic control on proteinuria in diabetic population groups, this is known to all of you, just a revision slide. If you look at the DCCT, EDIC DCCT, UKPDS, Advance and Accord, with tight glycemic control from 9.1 to 7.3, reduced micro and oval proteinuria. Renoprotective efficacy persisted, microalbuminuria risk reduced in 45%. HbA1c from 7.9 to 7 in case of UKPDS reduced risk reduction in microalbuminuria. And this is what shows that with good glycemic control, microalbuminuria in diabetics get reduced. The Chennai urban population epidemiological study showed that over proteinuria only 2.2%, whereas microalbuminuria was 26.9%. This is a landmark study by Dr. Mohan and his group, the Chennai urban rural epidemiological study, or the CURE study. The Chinnampati study also showed that diabetic nephropathy was quite high. Bikaner and North Delhi studies showed the prevalence of diabetic nephropathy was high. And Cindy, the study, the multi-center clinic based study published by the Diabetes India, showed that newly detected diabetics nephropathy was seen in 13.15% if you take microalbuminuria as the marker. Now, if you look at microalbuminuria in the Indian perspective, if you look at type 1 diabetes and then type 2 diabetics, if you look at the type 1 diabetes study from Mumbai by Dr. Patel, Dr. Metras and others, type 1 diabetes, microalbuminuria is a marker of progression of diabetic nephropathy. If you look at the study again by Dr. Patel in type 2 diabetes, a matter of generalized vascular endothelial dysfunction. So microalbuminuria in type 2 diabetics is an indicator of a different disease than only nephropathy. In Katakal study, we also saw as you control the blood glucose level over the period from entry to 2 years longitudinal follow-up, the urinary album's excretion also were decreased from 2.8 to 280 to 90, 190 to 80. Well, this is a historic slide. You can see Professor Parida, who has invited a research workshop on experimental failure assays. He is heading the team. Professor Akulananda Sadangi, Professor Aran Ratha, and he is an overseas faculty whose name I could not recollect. It is a very important slide for this institution. Now, coming to the paradigm shift from proteinuria to non-proteinuria, this much of knowledge which I have gathered from the net and what studies we have done in our centers across the country, we are now focusing that there is a shift from albuminuria to non-proteinuria as a diagnostic tool for diabetic kidney disease. Historical trends showing improvements in glycemic control over the time in large database, as I have showed the EDIC study, the DCTT, UKPDS, Accord, etc. In glycemic control of the time in large database and the widespread use of antagonist of renin-angiotensin system. Because what I saw in the pathogenesis, there is dilatation of the afferent arterioles and there is vasoconstriction of the efferent arterioles in the glomeruli. And by giving these drugs, there is again, we take care of the efferent arterioles, so the vasoconstriction of the efferent arterioles are taken care of, and this has caused decrease in the prevalence of glomerular lesion and allowed the emergence of other types of renal lesions affecting the interstitium and vasculature. Cause progressive renal damage without triggering proteinuria or producing just mild to moderate increase in the levels of biomarkers. As alluded to before, the paradigm that proteinuria is a necessary step in the course of CKD associated with type 2 diabetes causing renal dysfunction and progression to end-stage kidney disease has been reframed. Microalbuminuria in type 2 diabetes patients found to be a marker of generalized vascular endothelial dysfunction. Studies by Agarwal et al. From AIIMS New Delhi showed that 17.5% newly diagnosed diabetics with microalbuminuria had coexistent hypertension. Now look at this cartoon. The two different phenotypes of proteinuria and macro and macroalbuminuria and albuminuria. If you look at the GFR,
those who are normoalbuminuric, the decrease in GFRs was much earlier than those who had microalbuminuria and frank proteinuria. Thus, those who have microalbuminuria, they take a longer time than those who have normoalbuminuria. So there is a paradigm shift from the middle and the extreme left, extreme right to the left, that we have to consider diabetic kidney disease even if they are normoalbuminuric. Now, DKD, proteinuria to normoproteinuria, International Diabetes Federation and the International Society of Nephrology included 30,000 type 2 diabetic patients from 33 countries, found that the overall prevalence of micro and macroalbuminuria was 51, 39 and 10% respectively, with wide racial difference. So those having normoalbuminuria, 51%. The absence of proteinuria, a reduced GFR, is observed in about 1 diabetic patients out of 5, 20% have normoalbuminuria and diabetic kidney disease. Proteinuria cannot be considered as a marker of diabetic nephropathy, tout quote. Rather, proteinuria in diabetes has to be seen as an indicator of glomerular lesions in diabetic patients with CKD. Proteinuria is a distinguished feature of glomerulopathy, of glomerulonephritis. If the glomerular pathology has been taken care of by giving the ACE inhibitors and ARBs, naturally the glomerular markers will disappear. But nephropathy due to interstitial disease and due to other vascular diseases will not disappear. Type 2 diabetes, non-proteinuric DKD is more frequent than proteinuric DKD. Coming to the last bullet, substantial research efforts are still needed to develop treatment strategies that may help the vast majority of CKD patients who eventually develop end-stage kidney disease by mechanisms, pathways other than proteinuria. So risk factors for proteinuric to non-proteinuric, risk factors that might trigger a progressive decline in the glomerular filtration in the absence of proteinuria, co-associated hypertension, obesity. I think Dr. Ramanathan Iyer is very much here, and he was insisting on insulin resistance, and the mechanism here is insulin resistance. High serum triglyceride levels, they are pro-inflammatory. Glomerular hyperfiltration and alteration that is not confined to diabetes mellitus being commonly seen also as an early stage of hypertension. Now, if you look at this cartoon, sorry if it's not well visible, if you look at hypertension, it causes tubulointerstitial inflammation. If you look at obesity and overweight alterations, serum high triglycerides, they induce insulin resistance leading to alteration in adipokinins and secondary pro-inflammatory changes. So inflammation has come in instead of only proteinuria as the main mechanism behind diabetic nephropathy. So we did a study way back with Dr. Chandrakant, who did his DM in medical oncology and is a senior oncologist in Apollo, Calcutta. So he did his thesis, studies of markers of atherosclerosis, including insulin resistance in patients with chronic renal disease. If you look at the decrease in creatinine clearance, and if you look at the carotid intima medial thickness, as the carotid intima medial thickness increases, you can find there's decrease in creatinine clearance. Similarly, as the HOMA IR increases, there's a decrease in creatinine clearance. So, comparison of various parameters between the three groups, non-diabetic CKD, diabetic CKD, and healthy controls revealed that insulin resistance, beta cell dysfunction, dyslipidemia, C-reactive protein, uric acid, and carotid intima medial thickness were significantly higher among CKD patients than controls. Further, there was a greater degree of insulin resistance and beta cell dysfunction in diabetics CKD than non-diabetics as expected. Now, reabsorption of albumin escaped from the glomerular filtrate by the tubulin, megalin complex and renal tubular cells, cause activation of reactive oxygen species, enhancement of the nuclear factor kappa B activation, and upregulates endothelin 1, transforming TGF beta and other pro-inflammatory cytokines. Now, looking at this, if you look at the glomerulus, the markers are definitely microalbumin. If you look at the interstitium, you find these are the markers. If you look at proximal tubule disease, these are the markers. Loop of Honley, these are the markers. Collecting duct, these are the markers. Distal tubule, these are the markers. So time has come not only to concentrate on microalbuminuria, but try to find out the prevalence of these markers in patients with type 2 diabetes. So just to tell in a nutshell, for glomerulus, we looked for albumin alpha, beta microglobulin. For interstitium, we have to look alpha 1 antitrypsin, TGF beta 1. Proximal tubules, KIM1, loop of Henle osteopontin, distal tubule osteopontin, and collecting the copontin. Besides, evaluation and levels and status of expression of nuclear factor kappa B can reflect regarding activity of cytokine cascade. So this was again done in this institution, and this was done by Dr. Sonalika Behra. She was one of my last postgraduates when I was in service. Hope Sonalika is here, has she come? She is prosecuting her DM in not nephrology, in neurology. She was here yesterday. Okay, so this is what we found is, if you look at the healthy controls, type 2 diabetics without nephropathy and type 2 diabetes with nephropathy, if you look at the union albumin creatinine ratio, you look at the urine and monocyte chemotactic factor, TNF alpha, all were higher in the diabetic nephropathy group, even compared to the diabetic without nephropathy. And if you look at the genotype frequency of nuclear factor kappa B polymorphism, in healthy controls, it was mostly deletion. If you look at type 2 diabetes, it was more of insertion. And if you look at diabetic nephropathy, it was again more of insertion. All these studies were done in this campus. This campus has a wonderful biotechnology laboratory, I think. Professor Panda will agree with me. It must have improved since I have left. Well, this was last picnic prior to my VR from service, and this young lady with a yellow ring round her face is Dr. Sonalika. Hope he was here, and a guide was Dr. Bijan Patnaik, who is now a professor in which medical college? Bijan? BRM. Now, epilogue. Paradigm shift is in understanding diabetic kidney disease. Accumulating data suggests that proportion of CKD patients without proteinuria are substantial. In a survey made by a framework of Third National Health and Nutrition Examination Survey, as many as 37% of patients with GFR less than 30 had no albuminuria. Among patients with type 2 diabetes with GFR less than 60 were normal albuminuria. Glomerulonephritis are most often proteinuric disease, but with the vanishing prevalence of glomerular disease, we find less and less albuminuric patients. The incidence of end-stage kidney disease due to glomerulonephritis plateaued in 1990s and since then has declined steadily. Markers of interstitial involvement leading to a non-proteinuric diabetic kidney disease has to be evaluated at an early stage. More exhaustive genetic study in different population groups will guide us for the future. Well, with this publication of Sonalika, I got an invitation from Frontiers of Nephrology to guest edit a special issue on renal disease in diabetics in this part of the world. This was a gift given to me by my student. Thanks to her, my better half, for being my constant companion in all trials, tribulations, and triumphs. Thank you all.
Thank you, sir. That was a very important, very innovative presentation, because the first thing comes to a physician's mind when he thinks of nephropathy is proteinuria, as Professor Sai has already told. And you have opened the eye that you can have non-proteinuric nephropathy. As a customary, we don't keep any questions in the oration. Please give a big hand to Professor Das for this very informative, educative, a paradigm shift oration which should come to your practice every time. I request the volunteers to get the mementos, and I request...
I again thank ODISHA chapter, ODISHA branch of API for giving me this rare of the rarest opportunity to deliver the first Professor R.K. Parida Memorial Oration. I'm overwhelmed. Thank you.
Thank you, sir.
Thank you.
Thank you. So it's a time to give memento. I invite Professor Dalai, he's here. He wants to give a book written by him to Professor Das. So Professor Dalai, please join on stage.
Professor Dalai claims he's distantly related to Professor Parida. If my memory hasn't failed.
Because he was my postgraduate guy in 1980s. When we are doing the lipoprotein profile, he had many patients and they are great that he was. my mentor, Professor Pichetas, to please come over dash to
Sargandhi,
present this
Sargandhi. No, please, please, please. Please. No, no, person asun, person asun. Person asun. ଆପଣଙ୍କର ସେ ଲିପିଡ଼ରେ ବାହାରିଥିଲା ଆର୍ଟିକଲ ଆଇ ସୋଡ୍ ଦ୍ୟାଟ୍ ପିକ୍ଚର ରୁହନ୍ତୁ ରୁହନ୍ତୁ ବଡ଼ ସାର୍ ଆସୁଛନ୍ତି ଜ୍ୟେଷ୍ଠ ଭ୍ରାତା ଆସୁଛନ୍ତି ଆମେ ଏଠି ହେଇଯାଉ ବହିଟା ଲୁଚି ଯାଉଛି Hope this is a complimentary copy for me.
Yes.
Thank you.
This is part 1 and part 2.
Can I have 2 words about Professor Parida? He was his pet student.
State conference. In fact, I can tell you he was like my godfather. I was his undergraduate student, and when I got gold medal in undergraduate medicine, he called me and told me that you do post-graduation in medicine. After my internship, I went to Delhi for 1 year for do residency, then I come back, joined in service for 1 year, and in the first postgraduate examination I was selected as a postgraduate student at Cuttack. And by the time I got relieved from Berhampur Medical College and joined at Cuttack, Professor Parida has already put my name in his unit. That he called me and told that you will work as a postgraduate in my unit. And the paper that I presented out of my thesis, first paper, it was very difficult at that time go to conferences and present papers. And he pioneered through some source that how I will go and present that paper in the conference. So, in fact, he has helped me. He has worked as a godfather for me throughout my career. And when he was here as a principal, as a DMET, whatever he is, he has always very, very sympathetic towards me, and I still remember his words. And Professor Dali, in fact, was his relative. He was also doing post-graduation at that time. When he wrote that medicine book and told, I think I told him that you are the genuine legacy of Professor Parida, because he was a doyen in medicine, and you have done something very good for him. So on this day, my hope that Professor Parida's oration was initiated, and Professor Das has given that oration. In fact, he has worked a lot on diabetes. It was a very nice thing, and it was a very pleasant day. And on this day, I am very happy that this oration was instituted, and this will continue. I thank the organizers for giving me a chance to tell you a few words about Professor Parida here.
Thank you, sir. So this is a Pujya Puja, as a respecting our forefathers, people who have started medicine and inspired so many people. And I'm very happy that personalities like Professor Prasanna Das, Professor Siddharth Das, and Professor R.K. Dalai, and many senior physicians who are the teacher of teachers are groomed up by Professor Parida. So it was a good starting, and will continue every year. I thank everyone for the attention, and we'll move on to the next session. We have a very interesting session on CPC. You know, every one of you like clinico-pathological conference, which is mind-boggling, gives a lot of query to your mind, and stepwise, if you move, your clinical exercise gives you some learnings which is helpful in your clinical practice. So without any break, we have our Department of Rheumatology here, led by Professor Bidyut Das. We have Dr. Sharith, Dr. Shamya. So I ask the anchors to invite them and start the CPC. Please stay back for the most interesting session of the conference.
As Professor Dr. Jayant Panda told, this is one of the most interesting session of the day, clinico-pathology case discussion. And the moderator for the session is Professor Dr. Vidyut Das. And I think nobody wants to listen about his introduction. Even Professor Dr. Das does not like his introduction. He is such an enigmatic and charismatic person. I personally feel he is my guru, my mentor, my patron. Now I invite Professor Dr. Vidyut Das to the podium. And the speaker is Dr. Soumyaranjan Tripathi, Assistant Professor Clinical Immunology and Department of Rheumatology. Dr. Sarit Sekhar Patnaik, Assistant Professor Clinical Immunology and Department of Rheumatology. Dr. Vijay Kumar Das, Assistant Professor Department of Cardiology. Dr. Shanti Bhushan Das, Assistant Professor Department of Radio Diagnosis. Please come to the podium, sir.
So I invite Shanti and Bijay on stage. Please come. Yeah, you can come here. Yeah.
My apologies for the simple reason that this is called a CPC, but unfortunately we don't do autopsies in this hospital, so we can't do a classical CPC. So what we normally do is present a very difficult case, which has lots of twists and turns, both clinically, and a lot of investigations have been done. At the end, we'll see the result, how interesting it can be. With me are two of my colleagues, Drs. Soumyaranjan Tripathi, Assistant Professor, and Dr. Sarit Sekhar, Assistant Professor of Rheumatology and Clinical Immunology. We have two consultants who are associated with this case, Dr. Vijay Das, who is the Assistant Professor of Cardiology, and Dr. Shanti Bhushan Das, who is the Assistant Professor of Radiology. So, time is very short. I know this is not the right time to do a CPC because of the lunch break. I request Soumya to start the proceedings.
Thank you, sir. Respected co-presenters, all my teachers in the front seat, and all seniors and colleagues. We'll present before you the challenging story of a young lady who is just 25 years female homemaker from Kalahandi, and the total duration of illness was 3 years, and she presented to us 3 months back. So the story before reaching SAB. In September of 2019, during the routine antenatal checkup, the lady was found to have severe anemia. Although the anemia was not worked up, she was given 5 pints of blood transfusion. Mind, 5 pints of blood transfusion. And despite this 5 pints of blood transfusion in September 2019, in October, just 1 month later, she again required 5 pints of blood transfusion. So we have 10 pints of blood transfusion in 2 months, without any documented history of any bleeding or jaundice. In November 2019, because of this recurrent anemia, she visited a private medical college in Bhubaneswar, where during evaluation, these were the documents that we could trace. She had a hemoglobin of 6.2, microcytic hypochromic anemia, TLC count was normal of 5080, neutrophil lymphocyte ratios were okay, platelet counts were just below 1.39 lakhs. They had done a ferritin, B12 which were normal, bilirubin was normal, liver functions were normal. They had screened the ultrasound and they had found that there is an ectopic kidney in the left iliac fossa and the spleen was mildly enlarged. Ultrasound wise it was 13 centimeters. They had done an electrophoresis to rule out congenital hemolytic anemia which was normal. They had done a bone marrow study which showed mild hypercellular marrow with erythroid hyperplasia, myeloid hyperplasia and increased reticuloendothelial activity and few hemophagocytes. They had also done an ANA out of curiosity and which showed multiple autoantibodies in the form of SSA, which we also know by the name of Rho, histone 2+, dsDNA was 1+, and pCNA was 1+. During this admission in the private medical college, she again required 8 pints of blood transfusion and they had made a clinical diagnosis of SLE, although the other florid manifestations of SLE was not present. They had initiated her on prednisolone of 10 milligrams, hydroxychloroquine 200, and other hematinics were also given. So moving on with the timeline, in February 2020, she delivered a child, but during delivery, she again required 4 pints of blood transfusion. And after this delivery, she noticed that the abdominal distension did not resolve completely. She continued on prednisolone 20 milligrams and hydroxychloroquine. She did not visit any medical center for further medical evaluation, and after around 1 year, she stopped her hydroxychloroquine and continued only on prednisolone. Now in the month of September 2022, 3 months back, she reported to Kalahandi District Headquarters Hospital, again with complaints of pedal edema, dyspnea on exertion, and again here she was given 2 points of blood transfusion, and after the transfusion, her pedal edema and dyspnea partially resolved, and she was referred to us. So when she came to us, her only 2 chief complaints were abdominal distension, generalized weakness, and fatigue on exertion. When we took a detailed history, we found that this abdominal distension was there for 2.5 years or 2.5 years, and it had insidiously started along with that postpartum period, and it had not dramatically increased in size. There was pedal edema over the last 3 weeks, which had partially improved, as mentioned in the previous slide. There was no reduction in urine output, no bowel complaints, no history of malar rash, oral ulcers, photosensitivity, chest pains, seizures, no history of any DVT or any history of past history of gangrene. In the past history, we tried to document, but from history we were unable to document any history of jaundice, malarias, difficulty in cross-matching blood or transfusion reactions. She had attained her menarche at 12 years of age. She was having regular normal flow 3 to 5 days per month, and she was amenorrhea for only last 2 months. Obstetric history, 1 female child, there was no history of any abortions. In the family, there was no consanguinity, neither there was any documented history of hemolytic anemia. On examination, the BMI was 18.3, she had pallor, bilateral pitting pedal edema. There was no icterus, cyanosis, clubbing or thyromegaly, but she had a raised JVP with prominent A and very prominent V wave. There was non-scarring alopecia, Cushingoid facies was present, and she also had features of tinea corporis and pink stria over her lower abdomen. Vitals, pulse was 86 per minute with no abnormalities. The blood pressure was 110/70, respiratory rate was 16, and the temperature was 98.6. GI system examination, the abdomen was distended, there were no dilated veins, umbilicus was everted, the skin there was stria marks, all quadrants were moving equally, and horneal orifices were free. In palpation, the liver was palpable 2 centimeters below costal margin. It was firm, non-tender, smooth surface, rounded margin. The spleen was 10 centimeters below costal margin. Again, firm, non-tender, smooth surface, rounded margin. Splenic notch was felt, and it moved with respiration. In percussion, the tympanic note was percussed. The flanks were normal, and there was no shifting dullness. Liver span was 15 centimeters. In auscultation, there was normal bowel sounds, no bruit or splenic rub. In cardiovascular examination, the apex was localized in the 5th intercostal space at the mid-clavicular line, no special character. Thrill, palpable, no palpable P2. The first and second heart sounds were normal, but we could also hear a S3. A grade 3 soft blowing pan-systolic murmur, which was best heard in the tricuspid area, and a rough rumbling mid-diastolic murmur also heard in the tricuspid area. There were no murmurs in the aortic or knee aortic areas. Respiratory and neurological examinations were normal. To summarize what we learned from the history and examination, we have a patient who has recurrent anemia requiring multiple blood transfusions in a young lady. She presented with abdominal distension and fatigue. This distension was for 2.5 years. There was evidence of pallor, pedal edema, non-scarring alopecia, hepatomegaly with a massive spleen without ascites. JVP was raised. There was pan-systolic murmur and a mid-diastolic murmur, which we thought to be tricuspid regurgitation, and a queried tricuspid stenosis versus a flow mid-diastolic murmur. And we have a background of Hessely and steroid-induced Cushingoid features. At this point of time, we would like to know the opinion of the House, how they would analyze this case at this point of time.
2.5 years history, multiple transfusions, no definite history suggestive of lupus. Basically, she had anemia, bilateral pedal edema, big spleen, almost 10 centimeters to 11 centimeters. And there was evidence of tricuspid stenosis oblique tricuspid regurgitation. That's what we found when the patient presented to us. Any opinion regarding the case? Sir, please, can you take the mic, please? Is there a mic? Is it called? Yeah, please.
Sir, history around 3 years, sir.
2.5 years, yeah.
So, recurrent anemia. background history, possibly SLE, and there is evidence of right heart failure, and possibly because of severe mitral regurgitation, tricuspid regurgitation, and there is a big spleen. Big spleen, we have to find out the cause. There is no history of, sir, any autoimmune hemolytic anemia?
No, the investigation that at the private medical college did not reveal evidence of autoimmune hemolytic anemia. And they didn't do an ANA also. No ANA was done, C3, C4 was not done. They just did an ANA profile.
Then we have to see
of something, left atrial myxoma or endocarditis.
Big spleen, you mean left atrial infective endocarditis?
Because your splenomegaly is there, infective endocarditis is one possibility.
Tricuspid stenosis, cause of tricuspid stenosis and regurgitation with infective endocarditis in the tricuspid valve and 10 centimeter spleen. No fever.
No fever.
Sir, because she is having huge splenomegaly, and perhaps he belongs to Kalahandi. So perhaps he is having a TSS earlier, and over that there is recurrent anemia, and with so much amount of blood transfusion that in the background of TSS, perhaps he is having autoimmune hemolytic anemia, for which he is receiving so much of blood transfusion.
And tricuspid?
And tricuspid, perhaps that is a complication of some connective tissue disease related to autoimmune hemolytic anemia.
We can proceed.
Maybe carcinoid.
So you have two possibilities: carcinoid syndrome.
There is another possibility.
With tropical splenomegaly syndrome. Okay.
There is another possibility. The recurrent anemia may be due to the splenomegaly syndrome itself.
Hypersplenism.
Hypersplenism. That is the cause of anemia repeatedly. As per the initial discussion, there could be autoimmune problem.
No, only anemia in hypersplenism. All other lineages are normal.
So it has to be thoroughly.
There are two major problems. One is a tricuspid valve and a big spleen. And now she has evidence of right heart failure. So we have three. We have to combine all three and give a diagnosis. Okay, we'll proceed and see.
Can it be sickle cell thalassemia with primary pulmonary hypertension?
There is no pulmonary arterial hypertension. P2 was not allowed.
And sir,
There's
we
no
had done
pastel left.
electrophoresis, which was normal.
Electrophoresis was done, which is normal. They have ruled out hemolytic anemia, congenital hemolytic anemia.
Then it can be autoimmune hemolytic anemia.
We'll see what comes out. So what we thought and how we treated this patient. Yeah, Soumya.
Thank you, sir. And we have heard the opinion of the house. We also had very much confused state, but still we made a provisional diagnosis of SLE with flare. There was this evidence of endocarditis. We thought it is a tricuspid stenosis with tricuspid regurgitation affecting the tricuspid valve. There was evidence of myocarditis in the form of S3 and right heart failure.
Let the slide come, Soumya. The slide is not being projected.
Slides to be projected? Yes, now we have. So we thought it is SLE with flare, endocarditis because we had this tricuspid stenosis regurgitation, we thought it could be inflammation of the tricuspid valve. Myocarditis, we had features of LVF in the form of S3, right heart failure in the form of raised JVP, TSTR, hepatomegaly. So we thought it could be congestive cardiac failure. As rightly pointed out, hemolytic anemia was there in our background, and like Sarita ma'am said, she is from Kalahandi, so we also thought it could be tropical splenomegaly syndrome. And a big spleen without ascites, we thought if she had this EHPVO, or it could be a complication of some thrombosis in the prehepatic portal vein. So with this provisional diagnosis, we worked up, we found that she had low hemoglobin 8.3, the TLC was normal, neutrophil lymphocytes, there was mild neutrophilia, absolute lymphocyte count was 738 and less than 1000 is lymphopenia, MCV was 101, MCH, MCHC were normal, platelets was 60,000, DCT, ICT, markers of autoimmune hemolytic anemia were negative. but the reticulocyte count was 4%. We corrected for the hemoglobin and it was still 2.6. So reticulocyte count was elevated, LDH was elevated, so there was some hemolysis. Ferritin was normal, B12 was normal. Again we reconfirmed with the electrophoresis, it turned out to be negative. So congenital hemolytic anemias were ruled out. In a peripheral smear, there was evidence of decreased RBCs, mild anisopoikilocytosis, mild hypochromia, teardrop cells, macro and microcytes both were seen. The routine KFT, LFT, they were normal. Fasting postprandial blood sugars were normal. In protein albumin, protein was normal, but the albumin was slightly on the lower side, 2.7. Lipid profile was again normal. Urine routine microscopy showed 3+ albumin, and when we did a 24-hour urine protein, there was around nephrotic range proteinuria, 3.395 milligram per day, and there was no active sediments in the form of RBCs or pus cells. The procalcitonin was negative, CRP was 48.2, viral markers were negative, coagulation parameters PT, INR, APDT was normal. Ultrasound confirmed hepatosplenomegaly, that liver was 15 centimeters and spleen was a massive one, 21 centimeters. The left ectopic malrotated kidney had been documented earlier also, but the splenoportal axis Doppler was again normal. We did a upper GI endoscopy, there was no varices, and like for tropical splenomegaly, we thought of doing MPICT, malarial antigen, they were negative. At this point of time, we would like to know about echocardiography, like all of you would be looking forwards.
I request Dr. Bijay Das, Assistant Professor Cardiology, to enlighten us about echocardiography.
Play only. Play only. Support the play button should be paribo.
You can go to the next, if it's not running, let him start. Yeah. You continue with that. The previous one.
Good afternoon to all my respected teachers and my dear friends. I am Dr. B.K. Das, Assistant Professor Cardiology in this institution, and this is the interesting case with this background which is described by Dr. Soumya with a clinical scenario of SLE. This case was referred to us for echocardiographic evaluation. And this is what we saw in echocardiography. There is a oscillating mass attaching the tricuspid valve. You see here, I want to clear this picture. You see, this is the back. This is the left atrium, this one is the left ventricle, this is the right ventricle, and this is the right atrium. And this is the tricuspid valve you see here. This is the tricuspid valve, and where in this tricuspid valve there is a large mass attaching to the both of the septal leaflet and the anterior leaflet of the tricuspid valve. Next you see here there is a regurgitant jet from the RV to the LV. This is tricuspid regurgitation, severe tricuspid regurgitation. The jet area is around 13 centimeters square. I want to see whether there is MR or not. I put the color Doppler here. There is no MR, and there is no involvement of the mitral valve here. We saw the parasternal long axis view. Similarly, this is the LV, this is the LA, this is the aorta. Aorta is also, the valve is not involved. Aortic valve is not involved. And there is some degree of enlargement of the right ventricle. This one is the right ventricle. And you see, the IVS is not moving what is normally to be moved. There is some degree of hypokinesia here. Pressure. The short axis view of the LV, here you see there is no movement, there is regional wall motion abnormalities in the LAD territory. Similarly, we put a cursor in the right ventricular tricuspid annulus, and this indicates the tricuspid plane annular tapse, systolic excursion, and this comes out to be 12 mm, which is very much abnormal. The normal value is more than 16 mm. So there is RB dysfunction. This indicates RB dysfunction also. Here you see there is some linear line echo-lucent area, and that indicates pericardial effusion. So some degree of involvement of the pericardium as pericarditis. So in this background, clinical background, we suggest this patient is having a rare involvement of the tricuspid valve, sparing the mitral valve and the aortic valve. So we suspect this is a case of Liebman-Sachs endocarditis, because it may be infective endocarditis, but this is not infective endocarditis. This is non-infective, non-bacterial merantic endocarditis with this background, because this vegetation, involvement of the vegetation to the both sides of the valve, tricuspid valve, is characteristic of Liebman-Sachs endocarditis. And the movement of the vegetation with the valve indicates this is the involvement of the endocarditis involvement because of the merantic endocarditis. It may not be infective endocarditis with this background. So our diagnosis, echocardiographic diagnosis is this is a merantic, non-infective, thrombotic endocarditis, may be due to SLE.
Wait.
Splenomegaly, that is different. That
No,
cardiac failure is there. There is, sir, here the involvement is most of the pericardium and endocardium, myocardium, everything is there. Pericarditis is there, myocarditis is there. It is because of the myocarditis. RB dysfunction is there, RB failure is there, LB failure is there, every failure is there. So myocarditis, endocarditis, pericarditis, everything is there in this case. So with this background, this may be the case of, sir, madam. Madam, it is, no, that is not, it is because of the magnetic, due to SLE, madam. The vegetation is because of the non-infective, non-bacterial endocarditis. And the involvement of the regional motion wall abnormalities is because of myocarditis. This is two different issues. Which one? That indicates LV dysfunction. Yes, that is because of the myocarditis.
So
That shows
basically,
is myocarditis.
so Vijay, basically patient has pancreatitis
Yeah, pancreatitis.
and he has got RV dilatation, global hyperkinesia
Dilatation,
and dysfunction.
LV is
Okay.
involved.
Thank you very much. You think it is a rare Liebman-Sachs endocarditis affecting the tricuspid
Sir, it is
valve.
very, very rare.
And
Without involving the mitral valve and aortic valve, the isolated tricuspid valve involvement in
Very, very
SLE
rare.
or in infective endocarditis also.
Very, very
It
rare.
is very, 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 very rare.
Okay, thank you very much. Now we can proceed with the case.
Thank you, sir.
So we have come to one diagnosis of the cardiac problem that we faced. So now we know it's a Liebman-Sachs endocarditis, and that too on the right side, tricuspid valve, extremely rare. I was studying the literature, it's very, very rare. Most commonly it is found in the mitral valve and aortic valve. So that is where this case has a twist. Next.
Thank you so much, sir. Now that we had the cardiologist opinion of a vegetation, no matter how much anybody says that it is Liebman-Sachs endocarditis, every physician will be aware of the infective endocarditis, and nobody will stamp it without a blood culture. We had sent a blood culture report, which I'll show you in 2 slides. We did an autoimmune workup because SLE was always there in the background. We did a ANA Hep2 for the first time, and it was 3+ homogeneous, which is very characteristic for lupus. The ENA profile was the same as they had obtained 1 year back. C3 and C4 both were low, complements were low, indicate there is an immune complex pathology going on in the background. And we did a APLA profile because we had been suggested Liebman-Sachs endocarditis, and we know that in addition to SLE, if you have an antiphospholipid antibody, the chances of having Liebman-Sachs endocarditis goes up from 5% to 30%. So our APLA profile showed anti-beta-2 glycoprotein was raised in high titers. Against a cutoff of 20, it was 95. Anticardiolipin lupus anticoagulant was negative. And over the next 3 days, we got 2 sets of blood cultures which had been sent, and both turned out to be sterile. Now that once we have documented that blood cultures are sterile, serum procalcitonin was negative, we have a vegetation, and we have antiphospholipid antibody in high titers. So the suspicion was more or less in going into SLE and Liebman-Sachs. So our final diagnosis was SLE. We had evidence of alopecia, endocarditis, Liebman-Sachs, myocarditis, pericarditis. We had found nephritis in the form of proteinuria in the range of 3.5 grams. We had immunocytopenia. We had documented lymphopenia, thrombocytopenia. Again, thrombocytopenia can be contributed by antiphospholipids. We had evidence of hemolytic anemia, but we did not have evidence of DCT and ICT positive. And this large spleen could be a part of EHPVO with a splenic vein thrombosis, which might explain, but splenoportal axis was Doppler, so this aspect we have put a query mark, and it is open to everybody's conjecture. With this, initially when the patient had presented to us, we had features, so we had started with Primacort, Lasix for failure, and hydroxychloroquine. After vegetation, we had empirically started ceftriaxone till blood culture reports were available. After negative procal sterile blood cultures and confirming Liebman-Sachs endocarditis, nephritis, and a persistent myocarditis which was not responding to simple Primacort, we gave methylprednisolone 3 pulse doses, started on anticoagulants with LMWH followed by warfarin, and we gave the first dose of cyclophosphamide, which was anyway indicated for nephritis, and the protocol is called NIH protocol, and the first dose was given. The patient improved and discharged on prednisolone 60 milligrams, that is 1 milligram per kg body weight, 300 milligrams of hydroxychloroquine, warfarin 3 milligrams, calcium vitamin D supplementations, diuretics, and because we had given high dose of steroids and cyclophosphamide, we put her on PCP prophylaxis, that is pneumocystis carinii, Bactrim DS alternate day. But the story was still not over. To take you forward with the story,
Thank you. Now, you can come back. The story, yes, sir. So can you speak in the mic?
Up to this, if when I look, Limb-and-sex endocarditis, yes, everybody will agree. All lupus markers were there, it was SLE. And probably Sarita, what was proposing, the patient has come from that area. Could it be a tropical splenomegaly syndrome? Over and above has developed subsequently SLE, limb-and-sex endocarditis, and the anemia, thrombocytopenia that is occurring. Could it be a hypersplenism? Can you account for that?
Sir, true. We kept that in the mind, in the
Because
background.
Splenic vein thrombosis we couldn't detect. So,
So-
alternate possibility in addition to that, over
Yeah.
and above.
So basically, we wanted to explain everything in one diagnosis. We got APLA positive, antiphospholipid antibody. If it is positive, thrombosis is in almost 40% in the what is called the splanchnic circulation, which includes mesenteric vein, portal vein, and splenic vein. Besides the Budd-Chiari. Since there was no ascites and all, we ruled out Budd-Chiari. Ultrasound also did not show Budd-Chiari, and the Doppler did not show. But you can have negative. You have to confirm it by doing a CT angio, which we could not do because the patient was very sick. So we wanted to exclude tropical splenomegaly syndrome. So we did a RT-PCR in the ICMR to exclude malarial presence of malaria parasite. And we also wanted to look at IgM, anti-malarial IgM. We ruled out autoimmune because the Coombs test was negative. Negative. But we insisted on hemolytic anemia because the retic count was high, LDH was high, and there was some evidence of hemolysis in the peripheral. Negative. So that's why. That was a differential diagnosis which we kept. Yeah. So the patient, this young patient, very young girl, had gone through a lot of problem. This was not the end of the problem. We discharged, and then what happened? Dr. Sarit Patnaik, our assistant professor, will follow it up. Slide, please.
Good afternoon, everyone. So, as the case is ongoing, so after we discharged her, she came back after 2 weeks to us. This time she came with fever, which was present for the last 3 days. It was intermittent, associated with odynophagia. She had cough with expectoration, and her dyspnea had worsened to a level of she was unable to walk to the toilet on her own. She was off steroids for the last 2 days in view of odynophagia. On examination, she had tachycardia, tachypnea. She had a saturation of 85 on room air. Her blood pressure was 100/60. She was febrile. She had oral thrush, and she had few ecchymotic patches which were present in both upper limb and lower limbs. She had pitting pedaledema, which was present on the last admission also. Coming to the systemic examination, cardiovascular examination was more or less the same. She had a raised JVP with the prominent V wave, and there was no parasternal lift. She had an extra sound in the form of S3, and she had a pansystolic murmur and a mid-diastolic murmur which were present in the tricuspid area. In the respiratory system examination, she had decreased breath sound over the right infrascapular and infra-axillary areas, and she had coarse crepitations in the same distribution. Surprisingly, her spleen, which was about 10 centimeter at the last admission and which was discussed so many times now, that had completely disappeared. It was just palpable this time, and other systemic examination was normal. So what were we thinking? So there was, for this time, it was not a difficult diagnosis. We had pulsed her with methylpred, given her cyclophosphamide because she had very aggressive lupus, and now she had come back with a pneumonia, and she had oral candidiasis. So these are just the fallout of the immunosuppression we used. Her investigations, now they showed a neutrophilic leukocytosis. Thrombocytopenia was still persistent, and her blood sugars shot up to 453, and her CRP and procal, which are markers of infection, were very high. So with this background, we thought of a possibility of pneumonia, and the possible etiology was first thought to be bacterial because of high procal and neutrophilic leukocytosis. But considering the endemicity of tuberculosis in our country and considering her oral candidiasis, we kept a possibility of tuberculosis and fungal as well. So with this, we went ahead and gave her insulin, which was titrated as per her blood glucose. We gave hydrocortisone at a dose of 150 milligrams per day, and we continued her with hydroxychloroquine. Fluconazole and clotrimazole mouth paint were used for her oral thrush, and we gave her a empiric regimen of meropenem and teicoplanin clarithromycin for her pneumonia. Warfarin was continued.
Fine. Now, I request the radiologist, Dr. Santi Bhushan, to continue the story forward.
Good afternoon, everyone. Coming to the radiological findings of the case, bedside X-ray chest done on 9th of November. It shows few ill-defined cavities, as you can mark. One cavity in the right mid-lung zone with a air-filled cavity with wall with opacity in the periphery, and another ill-defined cavity also in the left lower lung zone. And bilateral CP angles are clear. Cardiac shadow is within normal limits. HSCT scan of the patient. These are the axial long window images, selected axial long window images. You can see multiple irregular thick-walled cavities in bilateral lower lobes. You can see there are multiple irregular thick-walled cavities in bilateral lower lobes. One is also in the left lower lobe, and also a few in the one in the lingula. There are also some associated centilobular nodules and train ball pattern. You can see these are some centilobular nodules with train ball pattern in the associated lung fields. Here are some magnified selected images, again showing the multiple irregular thick-walled cavities and centilobular nodules with train ball pattern. These are coronal images depicting same findings. Again, some thin-walled cysts, lung cysts in the apical segments of bilateral upper lobes, but no evidence of any other ground glass attenuations or any consolidations. Mediastinal window shows apparently normal, no evidence of any mediastinal lymphadenopathy, no evidence of any pleural effusion. So with these findings, there is a highly suggestive of reactivation pulmonary tuberculosis.
Yeah, Sarit can take over. What happened subsequently?
So we had a patient of lupus who had multiple complications in the form of cardiac involvement, nephritis, and for which we had given her pulse doses of steroids and cyclophosphamide, following which she has come back with infection. And now, as we saw in the couple of slides, that she has cavitary lesions in both mid zones and lower zones, and they were all thick-walled, and there was tree bud appearance, so highly suggestive of tuberculosis as per the radiologist. Then we did a sputum for both bacterial, fungal, and tubercular cultures. So sputum was negative for MTB, both AFB and CBNAT, both of them were negative. Bacterial culture grew Klebsiella, which was sensitive to the given antibiotics, and fungal culture was negative. With this, we took a pulmonary opinion, who were again of the same opinion that it is clinically it looks more like tuberculosis, although the sputum was negative. They were rightfully saying that to go ahead with a bronchoalveolar lavage, but considering the general condition of the patient, that was not possible. So keeping tuberculosis in mind, and with the sputum report of Klebsiella, we gave antibiotics as per sensitivity. Fluconazole was continued and ATT was initiated. Although pneumocystis is a rare complication, and this sort of a picture is rare in pneumocystis, but it was still a possibility. So considering her general condition, as she was very sick, so we gave her all sorts of cover for her infection, and we switched warfarin to LMWH. So with this, over the next 7 days, the patient's dyspnea improved. She did not have any further fever. Her thrush had settled, and with insulin titration, her blood glucose was in the range of 180 to 220 over the last.
So two interesting observations here. The spleen, which was we were discussing about TSS, it disappeared. after taking low molecular heparin. So we stick to the diagnosis of APLA-induced thrombotic, most likely in this Planck circulation. This is evidence that, no, it's Planck, I told Planck circulation. And APLA, this is the common circulation where you can get multiple thrombotic, and she had very high titers of APLA. And the evidence that it is not TSS because it regressed within 15 days. And the second thing that came, of course, we know once we give methylprednisolone and cyclosamide, infection is very, very common. To prove what is that infection, we had a problem. Klebsiella, of course, we cultured. TB, we could not, but because of multiple cavities and other things, we covered up based on the opinion of the pulmonary medicine and radiologist. Next.
So it was not over. So after 11th, on the 11th day of admission, that is the current admission, she had headache, which was holocranial. It was more in the morning, associated with recurrent episodes of vomiting. Her vitals were stable. CNS examination was unremarkable. She had normal reacting pupils and bilateral plantar were flexor. There was no focal deficit. Other systems were as before. So on a background of lupus, and now we had pneumonia bar tuberculosis, now we have this headache. So what are the possibilities that you can consider?
Now the discussion is open for the House for opinion about now, as far as we've come. Yeah.
Can it be immune reconstitution syndrome because perhaps he is having some brain focus and it is aggravated?
Immune reconstitution system presenting with headache?
IRS because she is on
Antitubercular.
Yeah, then that some meningeal focus they get
This happened,
and having headache.
No, there was no meningeal sign. There was no neurological examination, no, except severe headache, holocranial headache. There was no meningeal sign and no neurological deficit. So iris is, we didn't think about iris. Okay. Anybody else has any opinion? No meningeal sign. No meningeal sign and no neurological deficit.
Hello, sir. Am I audible?
CNS lupus, cortical venous sinus thrombosis.
I've seen a case similar of SLE in Army Hospital R&R. What we find that it was a fungal focus. We had multiple lesions of fungal abscesses in the brain. And second case, it can be a tubercular abscess in the brain or a different type of tuberculoma, or it can be toxoplasmosis also. One should have.
Fine, thank you.
And third thing, what I feel, instead of the induction we have given plus the steroid, we could have given MMF. If we would have given MMF, then that would have been a better suggestion.
Yeah, good idea, but MMF, you know, acts very slowly, it takes 1 month time, and considering the condition of the patient, we thought cyclosamide is a better option. MMF was definitely an alternative. And I accept, sometimes we thought of infection in the brain because of tuberculosis, fungal, as you said. Yes, both of them we have kept in mind. Any other suggestions? Okay, proceed.
So we also thought of the same
slide, please.
Sorry, the slide. Yes. So we also thought of the same possibilities, considering that she had a tubercular focus in the lung. CNS tuberculosis was the first possibility because of her background of lupus and APLA, cortical venous sinus thrombosis, and as rightfully someone said, that brain abscess was also considered. And besides, SLE related causes like benign intracranial hypertension and lupus headache were considered as possibilities. We did a re-evaluation again. So this time her fundoscopy showed retinal hemorrhages in the left eye. We did it to look at her papilledema, but there was no papilledema. So there was some retinal hemorrhages which was suggestive of retinal vasculitis. Her CBC was grossly normal with normal INR, and her sodium was on the lower side, potassium was normal. Now over to Dr. Santi for the next part of the NCCT brain.
NCCT brain shows very thin acute subtentorial subdural hemorrhage. You can see there is acute subtentorial subdural hemorrhage, and the bilateral lateral ventricles and third ventricle and even the fourth ventricle to some extent are mildly dilated, some periventricular CSF seepage. So these features are also suggestive of mild extraventricular obstructive hydrocephalus or communicating hydrocephalus, in addition to the subtentorial subdural hemorrhage. No evidence of any parenchymal lesion or other parenchymal lesions, no abscess, no evidence of any white matter edema to suggest any tuberculoma. Sinuses, sagittal sinuses also looks normal, though it's not a contrast study, but no definite history of any sagittal sinus thrombosis or any venous impact.
Fine. So basically we saw hemorrhage and we didn't know the cause for hemorrhage.
We had switched to LMW.
We have
The
switched to
patient
LMW.
was on anticoagulation.
Yeah.
That is a subdural, sir.
Subdural,
It's
it's
a
not
subdural.
subarachnoid.
It's a subtentorial subdural, sir. It is a subdural, sir. It is not subarachnoid.
Okay, proceed. Next.
So we also thought that probably it was a iatrogenic hemorrhage, but we were giving only prophylactic doses of low molecular weight heparin. And anyway, we had stopped that. We continued her on antibiotics and ATT. 3% was given for her SHIAD. And we gave her anti-edema measures like mannitol and dexamethasone. Levetiracetam was added as a prophylactic anti-epileptic. And further, her headache settled. There was no further episodes of vomiting. And after 5 days, we did a repeat CT, which showed decreasing hydrocephalus, and the subdural hemorrhage also started resolving. She was claustrophobic, and hence MRI could not be done. And this was her last echo. So if we remember the echo which Dr. Vijay had shown, as we can see here, the vegetation is still very much present, but the size of the vegetation has reduced over these 40 days, and other parameters remaining the same. Her myocardial function has improved compared to what it was prior. So finally, this was a diagnosis. She has SLE with secondary APLA. She definitely had endocarditis in the form of Liebman-Sachs. She had myocarditis with congestive failure. She had nephritis. She had retinal vasculitis. She had immunocytopenias in the form of lymphopenia and thrombocytopenia, hemolytic anemia, and extrahepatic portal vein obstruction. And we thought because at baseline she did not have diabetes, and that came only after treatment, so it was probably steroid induced. Her HbA1c was also normal. She had pulmonary tuberculosis with a secondary Klebsiella infection and subdural hematoma, which was probably anticoagulation induced with oral candidiasis. Thank you.
Any opinion? This is the final. So patient is still alive.
Yes.
And we have stabilized her despite so many problems. And she's a young girl, so we have gone this far. Hopefully she'll survive. Any other comments or any other observations from the... Please take the mic.
Sir, levetiracetam or anti-epileptic drug can only be given in hemorrhages if there is a history of seizure. Otherwise, no, as per the neurological recommendations currently.
Yeah, you're right. Any other comment? So, I think the time is also up. I hope you enjoyed the CPC, the presentation. It was a very unusual case, and it has really taxed us to keep her alive. Thank you very much for a patient hearing. I hope some lessons were learned from this CPC. Thank you very much. I must thank my postdoctoral students, Dr. Vinay and Dr. Mansa, for helping us in gathering all this information and for managing the patient. I must also thank Dr. Vijay for his comments as a cardiologist and Dr. Santibhushan for the radiological comment. Thank you very much.
Thank you, sir, for discussing such a challenging case with us. Now I would like to invite to the dais Professor Dr. Jayant Kumar Panda in order to felicitate Professor Dr. Vidyut Kumar Das.
As Professor Dr. Jain sir is absent, Professor Dr. Manojan Behra has felicitated Professor Dr. Vidyut Kumar Das. Thank you, sir.
All other chairperson in the podium. Take their movement. All other. Memento. All other.
I request all other chairpersons of the previous session to proceed to the felicitation podium. For our next session, which is a mixed session, I would like to invite the chairpersons on stage. Dr. Namita Mahapatra, Professor and HOD, Department of Medicine, PGI MER and Capital Hospital, Bhubaneswar. Dr. Sarita Behra, Associate Professor in Department of Medicine, Bhimabhoi Medical College, Balangir. And Dr. Niharanjan Mahanti, Assistant Professor, Department of Medicine, SCB Medical College, Cuttack.
So good afternoon, everybody. So we come to another session, and now the first topic of this session is an interesting one. It is the reality of precision in medicine in diabetes 2022. Now, what is precision medicine? Precision medicine is an emerging approach to treatment and prevention of any disease, taking into account the individual variability in the genes, in the lifestyle and the environment. So earlier, till recently, the one size medicine fits all, it was going on, but now any individual patient, when we see the genetic part, the genotype, the phenotype, all these are taken into account, and individualized therapy is being given. As a result, the patients are much benefited and they're happy, and the control of diabetes also, any disease. And here, in diabetes, the precision medicine has become a reality in the treatment of monogenic diabetes, that is especially the maturity onset diabetes in the young, and also the neonatal diabetes. So to throw light on this topic, we have Dr. N.K. Singh, who is a Director, Diabetes and Heart Research Center, Dhanbad. He is a Chairman of RSSDI, Jharkhand from 2019 to 22. He is an Executive Member, National RSSDI. He has edited the Million Book of Medicine and Associate Editor of Postgraduate Medicine 2021. And he has over 35 national and international publications to his credit. So I invite Dr. N.K. Singh to proceed with his talk.
Hello. Yeah, this is. Good afternoon. Thank you very much, chairpersons, for so much of the nice words. Huge appreciation to Dr. Panda, our friend, giving this opportunity to come this place. I think from the 20 minutes, I have to finish in 16 minutes, so I a bit hurry. The reality of precision medicine in diabetes. So let us see what is this. Do you agree that medicine is not science, but an art empowered by science? So this disclosure, this was not the day, but I will skip this slide. Hippocrates told that it is more important to know what sort of person has a disease than to know what sort of disease a person has. And this is what very, very relevant when you say about the, if I just think about the diabetes, my first exposure was with my father, way back in 1974. And that time I remember that only this Benedict solution was, we used to do this in our home, but I don't think that these days many of our colleagues or many of our patients are doing this. So, from that part of time, today in 2022, things have so many changed. And believe me, that our treatment today is 80% waste. Why I am saying so? Despite the extensive epidemiological and physiological characterization of the diabetes and many other disciplines also, we have fallen short of categorizing the risk factors. We don't know about the triggering events in real sense and elucidating pathophysiological pathways, outlining prognostic course, selecting effective therapies, and predicting complications. So specific patients continue to represent diagnostic challenges, and our approach to therapy continues to be based on population averages. But this is not the thing which we should do. And in diabetes, you see there is a collision between a genetic predisposition and an affluent environment. So we need a more systemic approach to learn how this interaction leads to disease. And the genetic information may not be stable. These days, you are well aware that epigenetic process is also going on. So Einstein once suggested that to keep doing the same thing and expect different results is the definition of insanity. In the world of diabetes, we seem to be guilty of this by failing to appreciate that new ways of delivering care are necessary if you want to make progress, and that is what the precision medicine is. Just wonder, why does one person end up requiring insulin treatment within 3 years of diagnosis, and another phenotypically similar person not progress to insulin for more than 15 years? You are seeing in our clinical practice day to day. Why does one person develop diabetic retinopathy and another not, despite both having 20 years of good glycemic control? And a considerable percentage of variability in patient response or outcome is intrinsic to the individual, and this way will not be apparent in their phenotype. And so later on, the many studies start appearing, like FIND eye study, which showed us a broad sense of heritability for diabetic retinopathy around 27%, and has been recently reported heritability for the glycemic response to metformin at 34%, and this is how this precision medicine comes in our clinical practice. So current pharmacological treatment of diabetes is largely a logarithmic. So from this part, you ask me what is the definition of the precision medicine, although new definitions has appeared in the Diabetology Act 2022, I prefer this, that precision medicine is defined as a modern approach which combines traditional clinical phenotypic information, so you are not omitting the history and the physical examination, with molecular profiling of the disease in a particular individual gleaned from data about genetic predisposition to disease, biomarker information about disease prognostic, and drug response to create rich pattern that can predict risk and responses in a very precise way. So crossroad is now being crossed with living in the midst of the revolution of big data today, spanning from the population to the individuals. Today's medicine and research is involved within an unprecedented world full of data. So from this new taxonomy, we have accurate diagnosis, targeted treatment, and improved health outcomes. So diabetes data pool is going. These days in diabetes, we are thinking about a phenotypic strategy utilizing clinical variables such as autoantibodies, BMI, and HbA1c, and other things. So we are going to do a phenotypic and genetic classification of the disease. That is important. Just see this example of this very mind-boggling study that they took only 6 clinical variables with the presence of the guide antibody, age, BMI, HbA1c at diagnosis, HOMA-2B and HOMA-IR, and using only these variables, the individuals with newly diagnosed diabetes, maybe you can cluster it into 5 types. You are well aware about the SAD, SAD, MOD, and MUD. I will not go in details, but what is the utility of knowing this? From the very beginning, you can have some genetic diabetes subtypes, and you need to know these clusters because this traditional classification is not working at all. The type 2 diabetes primarily affects adults. It is increasingly being diagnosed in children, making it more challenging these days, you know. So even we have lots of Indian data coming, like Velgen, Ahmedabad from Gujarat and Western India, Phenomenality from the Dibrugarh, Assam, and Northeast India. So these clusters, and this showed us recently that the subgroups of patients with young onset type 2 diabetes in India reveal insulin deficiency, not insulin resistance. It is the insulin deficiency as a major driver. Shown the different percentage you can see. Knowing this, that we can predict the great tragedy of complications by knowing all these things. You see here, if it is, I will just come forward here, that in Velgen, this data, nephropathy and retinopathy were more prevalent in SID compared to the MOD, while the latter had highest prevalence of neuropathy. So if you know these clusters, you can do like this. If there is insulin deficiency, a straightforward go for initiation of insulin and look for retinopathy and nephropathy because it is more occurring in those subsets. In the insulin-resistant cases, you look for the nephropathy and NFLD and target the insulin resistance. In the same way, the MOD and MUD group, you can do far more common than the other clusters. They have mild disease and better prognosis. So by knowing all these things, things change it totally. The differences between the precision medicine and personalized medicine. So let us paint a picture of precision medicine. I will just show you that the best example is the monogenic diabetes, as chairpersons are telling, that maturity onset diabetes in the young Modi, the neonatal diabetes, and the CHA, that is the congenital hyperinsulinemia, hypoglycemia. So you know in the Modi, how it changes the whole perspective of your treatment. The traditional criteria of, and this day in India, so many data is available from the CMC, Vellore and other parts, and lots of things have been, this is how this looks like, this genetic mapping, and I am a great fan of this doing in the real subsets of patients. These have been all from the Indian data. So this gentleman, I think the godfather of this neonatal diabetes research and the precision medicine, Professor Andrew, I met once to him that he told that 93% of patients with monogenic diabetes are not recognized. They are misdiagnosed and having type 1 or type 2 diabetes receiving the wrong treatment. So this is what is happening in our day-to-day practice. Because if you know the monogenic diabetes, you categorize it with which gene is problematic, then accordingly of the clinical features, treatment is you see here. Somewhere you need only high dose sulfonylurea. Some place you need insulin. Some place you need only low dose sulfonylurea. So it totally changes. And see the poster girl of the monogenic diabetes, that is the Lily. So she took insulin for got the insulin, developed diabetes at the age of 6 months after birth, was diagnosed as type 1 diabetes, taking insulin, and when all research was available to her, then she was found to having a defect in the genetic problem, and then insulin was stopped and started the sulfonylurea. Everybody is aware about that. So this made a huge impact in US, and a Lilly law was made there. In the same way, in this factory of the Canadian family, you can see 4 generations. When this child got diabetes and tested for genetic mapping was done, found to having a monogenic diabetes. Then his grandfather was taking insulin for few years and was on insulin. Then they were also tested and found that it was only a genetic problem. And again, all the insulin was stopped and sulfonylurea started. So this is how the impact is going on. Apart from that, I have got 3 or 4 minutes. I'm not going details, but in type 2 diabetes, it is unlikely that difference in treatment will be as marked as monogenic diabetes. But even in unexplored area of type 2 diabetes, precision medicine has witnessing impact. And that's I want to tell you. That you see here that even in the pharmacogenetics of the diabetes, many times you start metformin. Some people do not tolerate. What is the reason? The reason is here. That is the precision medicine. You know the MRS, the methylation risk score, tells you that this all problem with the OCT1 and OCT3. So most focus has been on the role of genetic variation of OCT. And it has been established that 8% of Europeans who carry this OCT variants are likely to develop severe metformin intolerance. In the same way, this also with the sulfonylurea. That is primarily inactivated by the liver, by the cytochrome. And this Goddard study has clearly established that the 6% of the population with loss of function of this CYP2C9 are 3.4 times more likely to achieve a target less than 7%. So again, here also there is role. In the same way, there is something with the glitazones. I don't have time to tell you, but there is also with the GLP-1RA. Some people are responding, some people are not responding, and the all problem is with this genetic problem. Now you have got the EMR data in your clinic. You see simply compiling the EMR data, this shows that obese females respond better to this pioglitazone and non-obese males respond better to sulfonylurea. Thus you can conclude it. So it is in your clinic itself, you can see. And then the other part is VIP therapeutics. What is done in the VIP therapeutics? Multiple data sources are available to the treatment of diabetes, ranging from genotype and the medical reports to CGM. These data are structured in different time scales from static to rapidly changing every few months, and the VIP is an analytical technique that allows the complex data to be converted into actionable personnel. So with a huge pool of data, you can just extract what is going, keeping your data with your patient, you can take the decision what to do. Today, last 2 minutes, I will tell you the digital bridge is there today with medicine, technology, data, and patients. But remember that technology versus humanity is one of the last moral maps we will get as humanity enters the Jurassic Park of big technology. So now the precision clinic in diabetes is on the way. Lots of things are happening. Futuristic diabetes clinics, a marriage between human and technology is bound to occur. And Remember that just you can do the genetic mapping. It is usually not a thing like that you will send your blood to the Chennai or some other place. In your clinic itself, within 10 to 15 minutes, technology is coming up that you can just map the genetic things and you can decide. So concluding my talk, after 60 years of stagnation, we are witnessing the dawning of a new era full of enlightenment and pharmacological management of diabetes. In this era, choice of therapy is based on actual clinical outcomes, your risk and benefits, rather than the surrogate biochemical markers. Although precision medicine, criticism is widely rampant, and today we are at crossroad, it is gradually penetrating in clinical practice. It is a new horizon in the diabetes athletes. So it is now possible to test all genes involved in monogenic diabetes in a single gene panel, both quickly and efficiently, and within a decade it is going to be possible. From the MODI, neonatal, and the type 2 diabetes, it is happening. So my last point is to apply whatever precision way possible in your clinic for the right treatment to right patient, thus avoid the complications and secure future. Just so this, which was showed by the ADA president 2-3 years back at the ADA conference, this is a disclosure for all of us. We do not know what causes type 1 diabetes. Number 2, we do not know what causes type 2 diabetes. And number 3, embarrassingly, we do not even know how many types of diabetes there are and cannot classify hyperglycemic intensity. So thank you very much. Thank you.
Thank you, sir, for your clear and elaborate talk. I think you have made it clear, the precision medicine, and that's really helpful to the patients. There's a smile on the patient's face. But the problem is only now, I think, the cost of this to know the genomics of a person. But otherwise, this is definitely going to be a very useful mode of treatment for all of us physicians, and the patients will benefit. Any questions from the audience?
Yeah, just regarding cost, I would want to inform that if you write a letter to that is Mohan Clinic at Chennai, and if you just request him, they do it free. Many centers are doing free if a request from a doctor goes there. So that time I was able to diagnose 2 cases by sending just to Dr. Mohan, and that was done free. So this is happening.
Thank you, sir. So any questions from the audience? Sir is there to clear your doubts. So we go to the next topic.
Thank you, sir, for an elaborate speech. I would like the chairperson to come and give the memento and the medallion to Dr. Singh.
So for the next session, that is ECG changes in supraventricular arrhythmia, I would like to invite Dr. Deepi Khaitan. Dr. Deepi Khaitan, he is the senior consultant in medicine, Gaya, Bihar. He is the national president of Clinical Cardiology and Diabetes Society of India. He from 2020-21. He is the Dean-elect ICCMD CCDSI 22-23 current and life member of IMA, API, RSSDI, HSI and CCDSI. There are 74 articles written by him on the different aspects of ECG to his credit, and he is the writer of 30 e-books on ECG review. and he is going to throw light on the ECG changes in the supraventricular arrhythmia, the thing for which most patients, besides coming to physician or cardiologist, they usually come to neurologist, because most of the time they suffer from head drilling and they think perhaps it is something related to head, and they go to neurologist. So I request Dr. Khaitan to start the topic, please.
Thanks. With regards to chairpersons and dear colleagues, from the very outset, I would like to give my regards and thanks to this organizing committee, especially Dr. Jayant Panda, to relate this topic to me. My topic of today is of supraventricular arrhythmias, which consists of tachycardia and bradycardia both, because it is inclusive of the SA node, atrium, and AV node. But I would like to focus myself on supraventricular tachycardia itself only, due to paucity of time. Supraventricular tachycardia originating from atrial or AV nodal tissue or both for the initiation and maintenance of the tachycardia are known as SVT. This can be divided broadly into two parts. Number one, arising from atrial tissue, atrial fibrillation, atrial flutter, focal atrial tachycardia. Number two, requiring AV node junction for pre-perpetuation and perpetuation, AVNRT and AVRT and AT. Paroxysmal supraventricular tachycardia will include AVNRT, AVRT, and focal AT. Just in brief, you see this sketch. It will include the entire talk of myself. SA node giving rise to sinus P node leading to sinus tachycardia. Sinus nodal tachycardia is very difficult to diagnose on ECG. It is only the point of EP study you can diagnose this condition. Atria non-sinus means other than the SA node, but in the atria, it is atrial fibrillation, multifocal atrial mate, focal AT or atrial fibrillation, plus minus varying degree of the AV block. AV nodal tissue, 4 variants. Number one, the AVNRT. Sometimes your AV node is consisting of the two types of the pathway, slow pathway and the rapid pathway, in 10 to 35% of the cases. That's why there is a genesis of the circle there. And this genesis of circle is responsible for the upward propagation of the atrial impulses and also towards the ventricles. So there is a genesis of the dual pathway, and the P wave gets inverted in the inferior leads with QRS post short RP interval. That means after the QRS interval part, the P wave would be inscribed in the inverted form. There is the AVRT, atrioventricular reentry tachycardia, orthodromic. Orthodromic means it is passing through the AVN, his Purkinje system, and then to the ventricles, and then to the SSI pathway to the atria, echo-reflex. So this pathway is lengthy one pathway. That's why RP interval will be somewhat more compared to the AVNRT. Here it may be more than 100 or sometimes even somewhat slightly less, more than 70 milliseconds. So AVRT antidromic. Antidromic means it is passing through the AVSC pathway first, then returning to the atrium through the AVN, his Purkinje system. That's why, since it's passing through the AVNRT, this SS pathway, the bizarreness of the impulses will be there. I would explain it later on with that of the EC part. This non-reentrant junctional tachycardia arising from the junction load directed the impulse from both the pathway upwards in the atria, towards the atria, and towards the ventricle downwards. Again to explain. This AV conduction block may be there in the form, in the cases of the especially atrial fibrillation, atrial flutter, and the focal AT. And the bundle branches may show the aberrancy, either mainly the RBB aberrancy. T wave may remain inverted as a memory T wave sign. Sinus, what is a sinus P wave? If there is a P wave delivered before every QRS complex with a sinus morphology, This is termed as sinus P wave, as illustrated below. This green part is showing the morphology part, a smooth rounded appearance of the top, plus P amplitude would be either less than or equivalent to 2.5 millimeter in case of with the limb leads, and with the chest leads, especially V1, it should be either less than 1.5 millimeter or equivalent. Then we can say this is the P amplitude of normal existence. Easily seen in the inferior leads and the V1. Here the the P axis is the 0 degree to plus 75 degree. It means the range would be in anywhere maybe, depending on the axis, it may be positive in the AVL, it may be positive in 1, 2, AVR and elytrium. Because the AVR lead is just opposite part, opposite to these leads, the negative P will be inscribed there. Positive to all chest leads except V2, except V1 where it may be sometimes biphasic as well. Just a run short, a very rapid run, non-sinus P wave. Atrial fibrillation, chaotic, multiple rings of the atrial fibrillation waves, mainly over the left atrium, nearby the pulmonary veins, informing the irregularity, very small, usually below than 1.5 millimeter in height, amplitudes. Atrial flutter, ring out. The impulse revolves about the ring. In the case of the cabo type isthmus over the right atrium, if towards the AV node, it will be positive wave, away from negative wave. So it is showing this sawtooth appearance. Atrial tachycardia means other than SA node. Atria is the site of this atrial impulse formation. That's why there is a fixed point, say nearby the low atrial AV node. It may show the negative sorts of the impulse there. The MATE, multifocal atrial tachycardia. Usually multiple automatic atrial genetic points from point of view of the impulse formation may be there, but on ECG at least must be 3 such discrete forms of the P waves irregularly to diagnose this condition, especially met with the respiratory disorders. Here PR interval, RR interval, PP interval, all might vary from each other. That's the important point. Post QRS, एक तीतर पहले, एक तीतर बाद. One something here, something there. So there are two sorts of things. Post QRS P. If normally P comes before the QRS, but if P comes after the QRS, especially in the inverted form, we should suspect it to be something different. It may occur in the typical AVNRT, slow fast pathway. Inverted P waves is seen at the end of QRS in inferior leads, and either the entire complex may be hidden with the QRS complex, or sometimes pseudo S at the end of the S wave may be formed, and the pseudo R pattern in the lead V1, nowadays V3R, is also important in this consideration. In atypical AVNRT, fast slow pathway with RP interval less than 70 millimeter, short RP pathway. Usually you may also measure it by the less than 50% of the RI interval. It may be called the short RP pathway. In orthotomic pathway, due to the delayed arrival of the echoatrial activity, inverted P wave is inscribed on the later half of the ST segment with RP interval more than 100 milliseconds, long RP tachycardia, more than 50% of the RR interval. Here, I am showing the AVNRT. Sometimes I already told you 10 to 35, 25% cases or even 30% cases may show the admixture of the slow pathway and the rapid pathway forming a sort of the circle. So one point goes up, one point goes towards the ventricle through the pathway, and there is a inscription of the P in negative after the QRS pathway. In the case of the AVRT orthotomic, the pathway passing through the AV node first, then to the ventricle and again to the atria. So it is again the somewhat longer time because the pathway is somewhat longer compared to the AV node within. That's why it is long RP tachycardia. It may be more than, say, more than 70, but in practice I have seen more than 100 milliseconds required to define this condition. Below is the both diagrams. AV and RT first, slow, and the rapid this RP pathway, shorter pathway and the longer pathway both have been discussed on either side. Pre-excitation atrial fibrillation. If through the SSA node, if atrial fibrillation, which is more chances to have developed in the case of the pre-excitation pathway, that may pass through the SSA pathway directly, then the ventricular and then the reverse pathway. So ventricular pathway passing may create some sort of bizarre appearance of the ventricular complexes, bizarre appearance. So it is the rate is very high. Usually say just of the rough remember, it is around about 200. It is around about 200. And in that condition, you can diagnose the condition to the pre-excitation atrial fibrillation. Irregularity, quite irregular in spacing and timing both. Junctional tachycardia. This the permanent JRT, junctional reciprocal tachycardia is very rare one. So not to discuss in so details, only I can say that it is a rare one. It is having the long RP tachycardia pattern. And this junctional ectopic is also having the rare variety, but sometimes it is encountered in the ischemic heart diseases. Again, the SPU pathway from above and downwards is the short RP, short of the tachycardia. One has to be differentiated by the history. SVT algorithm, narrow complex QRS, less than 120 milliseconds, tachycardia more than 100 admissions per minute, irregular, variable RA interval, atrial fibrillation, atrial flutter, or at focal atrial tachycardia with varying AV conduction. Multifocal AT, that is the mate, already explained. Regular tachycardia on the next diagram. It may be regular RA interval. If regular RA interval, then the with sinus P wave, then the sinus tachycardia, physiological sinus tachycardia, inappropriate sinus tachycardia, as the name implies, it is inappropriate to the condition of induction of the sinus tachycardia, tachycardia itself. Postural orthotromic tachycardia means if the patient sits supine, is in supine posture, suddenly stands up, there is initiation of tachycardia. Static tachycardia. Sinus reintermittent tachycardia, we can't explain it on the ECG, we can't record it. With non-sinus P wave, QRS, the most example, the short RP internal tachycardia is the typical AV. Other orthodomic AV at times, ST or focal AT with first degree AV block, junctional tachycardia might be responsible. Otherwise, long RP tachycardia is the most common, is the orthodomic AV with low conduction pathway. Otherwise, the things at typical AV at times, and even the focal AT may be responsible. PQRST sequences may be in the form of the focal AT, inverted P in inferior leads with lower size. It may be observed that from focal nearby the AV node. Junctional tachycardia, junctional jet is very not so commonly. I am leaving that part. Concluding remark will be that supraventricular tachycardia with sinus P oblique non-sinus P without inversion in inferior leads points towards the initiation and maintenance of the arrhythmia from the atrial tissue. Very important point. Tachycardia with inverted P in the inferior leads either before or after QRS points towards the development of the AV junctional tissue for the initiation and the maintenance of the SVT. This SVT is a neurocomplex tachycardia provided there is no aberrancy in the bundle branches associated secondary ST and T changes. These are the points, just in brief. With these sorts of the things, I just remain my thanks to all of you for patient sharing, and so sorry for being fast due to the positive time.
Thank you, sir. I know this is a very difficult to digest within this 20 seconds, all these things, but because of paucity of time, we are not taking any questions now. I know there are so many questions can be discussed with sir in the flow. And to felicitate sir, I request Professor P. Kasinath Padhiyari sir, Chairman Scientific Committee, to the dais to felicitate Dr. Khaitan sir. Sir, please come.
Our next topic is on vitamin D3. It's a hope or a hype because Lord, in our clinical practice today, if you see any prescription, be it a clinician or an endocrinologist or a cardiologist, everywhere you see a vitamin D3. So to talk on this, I invite Professor Dr. Ketan K. Mehta, who is the President, Indian Medical Association, Mumbai West. He is the Honorary General Secretary, ISC, Indian Society of Electrocardiology. He is the Organizing Secretary in APICON 2020-22. He is the President of AAME from 2017 to 2022. He is the Editorial Board Member in JAPI and Journal of Medical Nutrition and Nutraceuticals. He is a Principal Investigator for various clinical trials, so the TIPS 3, HOPE 3, TIPS, MARS, TIPS K, etc. Now it's over to Professor Dr. Ketan Mehta.
Thank you, sir. Respected chairpersons and audience, even after a busy day, I'm sure all of you are here and we'll have something different talk. I would like to thank my dear friend, Professor Dr. Jayanta Panda, for inviting me over here, an absolute dynamic person whom you have seen since yesterday. Friends, I'm going to talk about vitamin D, hope or hype. A lot has been talked about vitamin D in last 1 decade. And we know that it was already been a domain of orthopedic surgeon who used to prescribe vitamin D and write. And then we have seen that there is a role beyond it. So, does it really form into a clinical practice or no? Or does it have a real implication on it? Let's look into it. But before I talk in, I would remind me a good quote from Alvin Toffler, who states that the illiterate of the 21st century will not be those who cannot read and write, but those who cannot learn, unlearn and relearn. And that's so much true when we talk about vitamin D. Vitamin D deficiency, we know it's a worldwide issue which has come up, and 30 to 50% of world's population is having these issues, irrespective of ethnicity, irrespective of the locality, irrespective of the age group. That is what it is. All of you are well versed with the vitamin D levels about it. It is divided into deficiency, insufficiency, sufficiency and toxicity levels. And if you do randomly of yours, anyone, most of us would come either in a deficiency or insufficiency stat, which has been found. And there has been an inverse association which has been found between serum 25-hydroxy vitamin D levels and risk of cardiovascular disease which is there. Specifically, low vitamin D levels have been linked to increased risk of cardiovascular events. So that is what we are going to see over here. So when we talk about the risk of cardiovascular events and vitamin D, there are various factors or components which play a very major pivotal role, because vitamin D has a role in terms of whether we talk of oxidative stress, whether we talk of endothelial dysfunction, RAS activation, myocardial fibrosis, cardiac hypertrophy, even in diabetes, we will discuss that, hypertension. So it has a role. So when we talk about vitamin D, it has really a pleiotropic role. How does it act? So there is a definite pathophysiologic pathways through which vitamin D has a role in cardiovascular diseases. So when we talk about, it comes of causing occlusive arterial disease in terms of increased incidence of aortic aneurysms and peripheral arterial disease, by increasing the arterial stiffness in terms of deficiencies there. So overall, through inflammatory pathway, there is an increased chance of atherosclerosis, and which will attribute to the coronary vascular disease. Now this picture shows the overview of vitamin D receptor mediated various endocrine actions of 1,25-dihydroxy vitamin D and arterial wall and cardiac cells. So it has an effect on endothelial cells, smooth muscle cells, cardiomyocytes, dendritic cells, T cells and macrophage. Cannot go into the details, but overall, each has a significant role in terms of maintaining the homeostasis, oxidative stress, and otherwise the deficient levels can lead to progression of atherosclerosis. Now there are anti-hypertensive properties of vitamin D. Do we have really known about it? So vitamin D suppresses the RAS system, which is known. It has a renoprotective effect. It has a direct effect on endothelial cells and calcium metabolism. It can cause inhibition of growth of vascular smooth muscle cells, and of course the prevention of secondary hyperparathyroidism. So you can see that definitely it has a role in hypertension also. What about the clinical evidence? Yes, there are papers on it. So there is a paper which shows the role of vitamin D supplementation in hypertension. So it is shown that the people who were receiving vitamin D has got definitely reduction in the blood pressure, which has been found. Then there are data which also shows the prevalence of cardiovascular disease or risk factors in those who have a low levels of serum vitamin D levels. So there are papers published on that also, which has been found. This is our own data from Indian Heart Journal, which also shows the clinical evidence for vitamin D in myocardial infarction. So there is an independent association of severe vitamin D deficiency as a risk factor for acute myocardial infarction in Indians, which has been found. What about dyslipidemia? Again, it has a significant role. It inhibits 3-hydroxy-3-methyl-glutaryl coenzyme A reductase. So it is like expression of HMG or expression which has been controlled by vitamin D. So like how you have got a HMG coenzyme A reductase inhibitors like statins, which has a role, and here by reducing the expression of the receptors, you can have a lipid lowering effect which has been found. So it can reduce the cholesterol levels. So clinical evidence, yes, because everything we talk about the evidence. So there is a clinical evidence which shows that effect of vitamin D supplementation on serum lipid profiles. And this is the systematic review and meta-analysis which shows that supplementation will have a beneficial effect in reducing the total cholesterol, LDL cholesterol, and triglyceride levels also. What about heart failure? Yes, there is a clinical evidence effect of vitamin D on cardiac function in patients with chronic heart failure. It reduces the end diastolic and end systolic diameters, and of course the supplementation causes significant improvement in left ventricular function and reduced chances of hospitalization. There has been a beautiful article which shows that this vitamin D, is it like a final chapter which we can have it. So that means it has a role in heart failure also. We just heard about the supraventricular arrhythmias. Vitamin D has a role in rhythm abnormalities also, and this is the mechanisms. Predominantly it's anti-inflammatory and antioxidant properties which can have a role in rhythm abnormalities also. There is a paper on clinical evidence or vitamin D role in cardiac arrhythmias, that plasma levels of vitamin D on post-operative atrial fibrillation in a patient undergoing isolated CABG. So again, there is a data on that. Statin-induced myalgia, again, a very common issue which we know about it, but here one thing which is very interesting, those who have a vitamin D deficiency, they are more likely to come up with this statin-induced myopathy, and the chances of statin side effects are reduced once the vitamin D levels are being normalized. Talking about vitamin D in diabetes, of course, similarly, vitamin D deficiency has a link in diabetic population also. There are various mechanisms. If you talk about the type 1 diabetes, it's autoimmune destruction of pancreatic beta cells. And if you talk about type 2 diabetes, it is again impaired insulin sensitivity and glucose metabolism and systemic inflammation, which has a role. So it has a role over there. So there are different pathophysiologic mechanisms by which this vitamin D and insulin resistance are interlinked. Now, it's not only just in diabetes, but it's various complications. There is an effect of vitamin D on diabetic peripheral neuropathy, because vitamin D has a neuroprotective effect as it regulates the neurotrophin levels also. So there is an effect. There is a data on diabetic nephropathy also. There is again a randomized cross-sectional trial where it has been shown that use of vitamin D3 for 12 weeks in patients with diabetic nephropathy had shown a significant reduction in urinary albumin level also. So overall, if you see, there is a various pleiotropic effects of vitamin D, and there is a potential importance in diabetic patients. So it is definitely even for prevention of various complications. So this is the summary of the effect of vitamin D supplementation on various tissues and organs. So if you look at right from pancreas, fatty acids, skeletal muscles, kidneys, nervous system, skin, and you have a reduction in A1C and effect on the retina also. So you have a significant benefit also. Pre-diabetes, yes, the adequate levels of vitamin D will prevent or delay for those subset of patients who are pre-diabetics going into diabetic state also. So this is what the data which shows. Coming to the last aspect, that vitamin D as an immunomodulator, which we know that vitamin D has effect on the adaptive immune system. It inhibits that, and it has an effect on innate immune system. It strengthens that. So you have an immune regulatory effect which is there with vitamin D also. So vitamin D, if you see, has got endocrine, paracrine, and intracrine functions are there, acting at various levels also. Now when you check the vitamin D levels, so 25 hydroxy D levels versus 125 dihydroxy D3 level, question always remains which one to see. So serum 25 hydroxy D is the barometer for vitamin D status, that is either whether it is deficient, sufficient, or intoxicated, which is there. Now when we talk about vitamin D deficiency and chronic diseases, there has been data which shows that supplementation with vitamin D reduces the risk of dengue, herpes virus, hepatitis B and C virus, HIV, influenza, respiratory syncytial virus, and pneumonias also. Vitamin D deficiency in pneumonia patients is associated with increased mortality. Again, this is a immune-mediated mechanisms also. Vitamin D3 and tuberculosis, now it has been found that 100% of TB patients who had vitamin D levels checked were either deficient or insufficient. This was as per the data also. And probability of getting TB is reduced by 60% when just 1000 IU per day of vitamin D which was given. You know, once upon a time, all of you know that tuberculosis was treated with sunshine, and that means vitamin D has definitely a role in treatment of tuberculosis. In the current time, you know, the theme for the conference is the post-COVID, obviously, role of vitamin D in COVID-19. So there is a large evidence which is there, and all of us have treated COVID-19 patients with vitamin D supplementation. Tell me a single person who have not given vitamin D. So can vitamin D supplementation be an approach in the treatment of SARS-CoV-2 infections? Yes, there are various data on that. I would not go into the detail about it. There is an association between low average levels of vitamin D and high numbers of COVID-19 cases and mortality rates among 20 European countries. So there is a huge data on that. Now, how do we give it? Of course, you have got a functionalized nano-carrier way by which you deliver the vitamin D, because it will improve the bioavailability, improve the stability of vitamin D3. It is a uniform and accurate dosing, and of course the least variation which is count. So that is aquasol technology which definitely matters. So it definitely matters how you deliver vitamin D. Those all of you are well versed with. So ladies and gentlemen, the take home message over here, that if you want to have a target the serum level of vitamin D to somewhere near 50 nanogram per ml, because you know even the lab said 20 to 30, that is for maintaining a good bone health. And if you want a good metabolic health, achieve at a higher level, that is 50 nanogram per ml. Vitamin D is deficiency is associated with increased cardiovascular risk, increased risk of blood vessel wall calcification, atheroma formation, increased atherosclerosis. And vitamin D has a role in terms of whether hypertension, diabetes, dyslipidemia. So over in metabolic syndrome, you can have a significant role. I would end with the words from Professor Tadeusz Beliński, who states that this is a very inexpensive solution to repair the cardiovascular system. We don't have to develop a new drug. We already have it. There is a quote from Dr. Robert Mendelssohn that until doctors acknowledge the presence of an inborn intelligence that runs the body and better understand its way, they will continue to work against its efforts to restore and maintain health. because Isaac Newton's word, what we know is a drop, what we don't know is an ocean. That is so much true. Thank you so much for your patient hearing. I hope I have finished in time. Thank you.
Thank you, Dr. Mehta, with a very good presentation. I know there is a lot of questions on this very common topic, but due to paucity of time, I can't allow. So now I request Professor Dr. K.N. Podhiyari to felicitate Dr. Mehta.
Next, I would like to request the Honorable Chairman to proceed to the memento podium, please. For our next session, which is a mixed session, I would like to invite the chairpersons on stage. Dr. Bijay Kumar Mishra, Consultant Physician, Diabetologist and Cardiologist, Bhubaneswar. Dr. Pareshnath Mahanti. Dr. Ayaz Khan Kar, Associate Professor of Medicine, PRM Medical College, Baripada. And Dr. K.N. Podhiyari, sir, Professor of Medicine, Chairman Scientific Committee, Associations of Physicians of India, ODISHA Chapter 2022.
Good afternoon, friends. Please come. This is a session on diabetes, and this session is pioneering the upstream approach in diabetic management with the oral semaglutide. All of us, we know that in recent years, the GLP-1 receptor agonist and SGLT2 have come to the forefront in the guidelines of diabetic management. And out of this, GLP-1 receptor, which covers almost 6 out of the 8 ominous octet in the pathogenesis of hyperglycemia, and has become one of the sought after molecules, but it was available in injectable form, was not very much acceptable. So now it is available as oral preparation, oral semaglutide, because this was one of the difficult research. The peptide was not stable in gastric juice. So this has become stable, and this is one of the very innovative research. And that Professor Abhay Sahu, who is known to everybody, and he is the professor and head of the Department of Endocrinology and Metabolism at the Institute of Medical Science and some Ultimate Hospital, Bhubaneswar. So he is also the Executive Committee member of the Endocrine Society of India and a reviewer of Indian Journal of Endocrine Medicine. He has 5 international and 7 national publications to his credit. It is a pleasure to introduce Professor Sahu. He is one of our very young and talented professors, and one of the well-known speakers everywhere. So Professor Sahu, please.
So before Dr. Sahu starts, I want to interfere that all must know that Dr. Jayant Panda has sacrificed his talk to save time. So I request all my local speakers to save at least 5 times from each slot, because otherwise the organizing committee will be in a very embarrassing situation. So, Dr. Sir, so please.
Yeah. Thank you, sir. Respected chairpersons, my dear friends and colleagues, and especially I am thankful to the whole team, APICON and Joint Pandit sir for giving me this opportunity to present this topic. So, the pioneering the upstream approach in diabetes management with oral semaglutide. Regarding the introduction part of the semaglutide, already sir has given the introduction. So, we will discuss about the burden of the disease, addressing about the sinister synergism in the upstream approach, what is the place of this oral semaglutide in managing weight, particularly in our patients, and we will discuss a case how this semaglutide acts in those patients. So, if you see the burden of diabetes, almost 67% people of diabetes has obesity, and if you see 1 in 10 adults having type 2 diabetes, if you take the overweight, almost 21% is having overweight, and almost another 68% is found to be obese, and every 4 in 10 adults are found to be obese. It's not diabetic, it's the general population. So, the important part is those who are having increase in obesity, there is increased all-cause mortality by almost 7 times. And this thin fat Indians, what this concept is actually, despite of normal BMI, we have actually our central obesity or truncal obesity is significantly high, and this central obesity or truncal obesity plays a critical role for development of different complications in diabetes and diabetic things. So, if you see this sinister synergism, if you see one side there is adiposity and another side is diabetes, and for adiposities, that food, physical activity, safety, that there are certain things like alcohol all plays a critical role, and at the opposite side diabetes, their social environment, all other things actually plays critical role, and in between there are certain factors which also plays or promotes diabetes. Actually, these are sleep disorders, physical inactivity. On top of that, we know that insulin resistance and beta cell function are the 2 important factors for development diabetes, and this actually plays a critical role. And there are certain additional things which also plays a critical role for increase in the body weight, which is actually there are certain medications which can cause weight gain. There are associated neuropathy which can reduce physical activity. Again, so if some people develop hypoglycemia, there occurs defensive snacking. That is one of the important factors for increasing body weight. Again, those having impaired mental health, they are actually having sedentary lifestyle, and that can also lead to increase in the body weight. So, people see the complications due to increase in the body weight. In the one side, people see the cardiovascular complications. There will be coronary disease, peripheral vascular disease, also CVA, and there are a lot of non-cardiovascular diseases, which includes depression, hyperglycemia, hypertriglyceridemia, osteoarthritis, obstructive sleep apnea, GRD, then urinary stress incontinence, and NAS. These are all lot of the complications which directly related to diabetes part. So, in the upstream, there is obesity or adiposity is there. In between, there are certain factors which either it's a consequence or is an effect of this obesity. And again, all those consequences and also this, particularly this obesity or adiposity, all promotes or makes the person prone for development of hyperglycemia or diabetes. And if someone develops diabetes, then there occurs different micro and macrovascular complications. So, what is the importance of this upstream approach? First is there should be a weight centering intervention. So, if you are actually targeting the body weight, if you are reducing the body weight, and simultaneously you are giving benefits of particularly cardiovascular benefit, we are giving benefits of reducing micro and macrovascular complications, probably that is the best thing what we can offer to a type 2 diabetes. So, this not only disrupts the underlying pathophysiology of type 2 diabetes, it also reverses or slows down the disease course in the management. This is the particularly diabetes prevention program. What they have shown, if you are reducing your body weight by 5% or 5 kg reduction in the body weight, there occurs a significant, you see in the left side, what is the incidence of the diabetes for 100 person years from, if you are reducing 5 kg, you see from the incidence is reducing from 15 to reducing to up to 5. So that shows in the DPP program that a reduction of around 5 kg can significantly reduce the number of diabetic population. But the problem is that in this DPP program, actually what they concluded that a sustainable lifestyle or prevention for if someone is going for that type of lifestyle for a quite long period is a difficult, it is quite impossible to sustain such type of lifestyle in long run. Then this is look ahead trial. Look ahead, actually they have divided in the lower side, actually it's not visible properly, but in the lower side that shows if someone is gaining, the first one is gaining more than 2% body weight, the second part is the body weight with gain more than 2% to less than 2% loss, then third one is 2 to 5% loss, fourth one is 5 to 10% loss, fifth one is 10 to 15% loss, and the last one is 15%, more than 15% loss. You see, if someone is having a gaining body weight or the weight loss is less than 2%, probably there is no change in the HbA1c. HbA1c remaining same. But you see the extreme right, where actually a significant drop in the HbA1c, that shows that if someone is losing almost more than 15% of the body weight, that causes significant loss. Not only the fasting plasma glucose, the HbA1c also can cause significant drop due to that part. Again, weight loss and diabetes remission, this is a direct trial which has shown that there is weight loss. This is the first, every quartile in the first bar is the first year odd ratio and the second part is the second year odd ratio. What they found that if you are losing around more than 15% of the 15% or close to 15 kg body weight, probably there is a remission of diabetes or by up to almost 85%. So that shows probably a significant weight loss in the range of 10 to 15 kg that can cause a significant remission, and a lot of people can become non-diabetic, particularly due to this much of weight loss. So if you see the evidence-based approach to weight management, there is lifestyle, diet and behavior is there, where you have dietary therapy, physical activity, behavioral therapy and patient support system is there. For the pharmacotherapy, we have orlistat, we have liraglutide, semaglutide, then also there is a combination of naltrexone and bupropion, and also there is phentermine and topiramate are the drugs. And for the surgery, of course, we have the different types of bariatric surgery which plays a critical role for reduction in the body weight. So what are the unmet needs in the weight loss therapies? There should be a sustainable weight loss, then the quality of weight loss. So whether you are losing fat or losing muscle, that is also important part should be taken care of. And what is the effect of concomitant anti-diabetic drugs, what you are using. So this is, that is a molecule that can address all those things. So this is the GLP-1 receptor agonist, which provides, it can not only reduces the HbA1c fasting postprandial, it can minimize the hypoglycemia, there occurs reduction in the weight, CV benefits, there occurs a tolerable side effects, and also it is approved for wide variety of the patients. So what is the proposed mechanism? Normally this semaglutide, specifically this oral semaglutide, they induces a secondary neuron response in the posterior brain, either directly stimulating the GRPL receptors in the area of prostrema and posterior brain projections, or indirectly through actually this area of prostrema, nucleus tractus solitarius and posterior brain pathway, and that actually induces some sort of satiety, early satiety. So that is one of the biggest or one of the mechanism which is actually attributed to this, specifically to the all GLP-1 receptor agonists and specifically semaglutide. So what are the changes in the body weight? If you will see the first two, the which oral semaglutide versus placebo, the weight loss is around 2.7 to 2.8 kg. But you see the first one and second one and third one, the out of 2.7 kg, in the second, the fat mass loss is 2.6 kg and the lean body mass loss is only 100 gram. So that means whatever the weight loss is there, it is due to loss of fat. There is no lean body mass loss. And so it is the fat mass that is most interestingly lost with oral semaglutide. And the most another important part is this body weight loss was most likely cause a reduction in the energy intake, since actually this resting metabolic rate did not increase with semaglutide. That is one of the important factor. And this reduction in energy intake was observed during and after body weight loss. So not like that, during the phase of semaglutide or once you are using semaglutide for 6 months, even if the effect, that effect is remaining for more than 1 year, 2 years like that. So it's not like that once you are stopping that drug, probably this effect on the metabolism is coming down or it is completely stopped. So this is oral, it has actually more than 24 clinical pharmacology trials, 1 phase 2 trial, 10 phase 3 trials taking almost close to 10,000 people, and the subjected to exposed to oral semaglutide is close to 5,700 people. And this is the pioneer one, which has actually how many people are achieving the target less than 7%. You see with the first one is 3 milligram, 7 milligram versus 14 milligram. So with 14 milligram less than 7%, almost 80% are achieving the target. and a weight loss of around more than 5%, almost 45% is happening with 14 milligram. With 7 milligram, it is 30%. So with the highest dose of semaglutide, there is a weight loss more than 50% is found in 45% patient, whereas almost 80% people are achieving the target HbA1c of less than 7%. Again, this is the primary weight where actually compared between week 26 and 52 around the weight loss and what is happening at 52 weeks. You see at 22 weeks, almost the weight loss proportion of people having weight loss of around more than 5% is 41%, and that is also in 52 weeks, that is further increased to close to 50%. So again, there is a weight loss and that is sustained over a period of time, and the weight loss is more than 5% in almost close to 50% of people with particularly use of semaglutide up to 52 weeks. And this is not only that, what is happening when you are comparing or when you are adding with other drugs, whether this weight loss property is actually maintained or not. You see, this is pioneer 1, 2, 3, 4, except 6, all pioneers, where actually everything is compared. Semaglutide is actually has been compared with all drugs, where actually with 3 milligram, 7 milligram, 40 milligram, with 40 milligram, up to 5% weight loss is actually observed with each trial. So that shows it's not like it is sustainable with even if with other drugs. So again, what is happening to the over period of time? This is the actual pioneer 2, 3, 4, 8. First shows that there is a consistent weight loss and it is found to be sustained even if over a period of time. Again, that is also was clearly shown in these studies. Again, what is happening to weight loss in the background of age? Actually, they have segregated less than 45, 45 to 65, and more than 65. Whether all are actually responding equally or not. Again, this slide has shown all groups, less than 45, 45 to 65, more than 65, in all trials, they have responded equally. Again, this weight loss is actually found in each and every subgroup of patients. So that shows for every different age group also, the pioneer is actually, or semaglutide is actually effective, and it can cause a sustained weight loss even if different age groups. Again, they have to actually, from the body weight point of view, they are actually different body weights. They have 7 different drugs like metformin, metformin sulfonylurea, metformin SGLT2 inhibitors, metformin insulin, and again SGLT2 metformin insulin. All those drugs, when added to sulfonylurea, when added to particularly this semaglutide maintains its property, and this weight loss is also actually achieved even if with the background of any of the drugs has been added to particularly semaglutide. Again, changes in HbA1c, which was the primary endpoint, that actually almost as I have shown in the beginning, that when you are using 14 milligram, more than 80%, close to 80% achieve the target of less than 7, and that has been also shown or found in each pioneer trials. Actually, what I have shown up to 1.5% HbA1c reduction was found when using semaglutide on top of different additional drugs in the background or on presence of additional background diabetes. So this is the ADA 2222 standard guidelines, was clearly shown that if someone is having ACVD risk factors, even if before metformin you can plan to start this either a GLP-1 receptor agonist or a SGLT2 inhibitors, and after that you can plan metformin or any of the drugs, whatever the drugs can be used after that. So that shows probably even if someone is having ACVD risk factors, these are the 2 drugs, a GLP-1 receptor agonist and SGLT2, they have in the hierarchy, they have kept in the higher in these drugs. So let us see this person, HbA1c 8.1, having a family history, particularly mother is diabetic at the age of 46, father is died at 57 years with heart attack, having sedentary lifestyle, and also HbA1c is 8.1, BMI is 30, and body weight is 88, blood pressure is actually for 142/85, and total cholesterol 189, and these are the parameters. So this is actually patient's age is 46, male, and software engineer. And if you see the progression, patient is on metformin and diet, it has patient having multifactorial treatment, but nothing is proved for prevention of the complication because we know metformin is not giving complication point of view. If you see the 3 years later, patient was working and trying to follow healthy diet cells, current metformin and glimepiride, and symptoms of patient is now having symptoms of arthritis like shortness of breath, fatigue over last 6 months, patient is having recurrent hypoglycemia, also weight gain. And now if you see the compared 3 years back, HbA1c was again 8.1 same, patient has gained body weight over last 3 years, blood pressure is almost similar, again lipid profile is almost similar, but patient has gained body weight over last 3 years. So this is the glycemic status over a period of 3 years, patient has from 8.1 gradually, initially it's come down to 7.8, again it has increased to 8.3 in duration of course. So here at 8.3 GLP-1 was started, that GLP-1 receptor agonist was started, and subsequently after 3 years, this HbA1c has come down to 6.8, BMI has significantly reduced from 31 to 28, body weight reduced from 91 to 78, and all the parameters has been stabilized. So if you see this person initial, when patient was on metformin and glimepiride, probably there is limited efficacy, limited complications or limited surveillance for development of the CV complications. But now when you are putting with GLP-1 receptors, probably you are not only reducing the body weight, not only controlling the blood glucose, also it manages the CV risk and prevents further complications. And so for this, it can prevent, also can delay the long-term complications in this person. So this is the upstream approach for the patients. So summarizing my topic, this is the global and national burden of type 2 diabetes is increasing and its complication by inadequate control and multiple comorbidities. Diabetes with high body weights are emerging in this one of the important factors for which adversely leads to patient's outcome. Adopting an upstream approach towards weight management in diabetes can give multiple clinical benefits. There are strategies to weight reduction in this current scope have multiple challenges, especially in patients of type 2 diabetes patients, and GLP-1 receptor agonist having various overreaching benefits beyond HbA1c control in type 2 diabetes, and can be put in a valuable place in the upstream approach of type 2 diabetes. Thank you.
Thank you, Professor Sahu, for your elegant lecture. And all of us, we know that this drug is almost equivalent to bariatric surgery. And weight reduction, how it is helpful, you have demonstrated. Since the paucity of time, no question answer is there, please be here to have the felicitation. Next talk is individualization of insulin therapy, positioning right insulin for diverse patients. And the talk will be none other than Professor J.B. Kanwar. He is also the professor in the Department of Endocrinology and Metabolism at Institute of Medical Sciences and SOMHOS Ultimate Hospital, Bhubaneswar. So he has published 18 articles in peer-reviewed national and international journals, a reviewer of many journals, including Indian Journal in Endocrinology Medicine, past Society of Endocrine Society of ODISHA. So with this, I request Professor Kanwar to go ahead with his lecture.
Thank you, Chairperson, sir. At the outset, I am thankful to John Panda, sir, for inviting me to speak to this crowd. I always feel nostalgic coming to SCV. I did my post-graduation here. I see many of my teachers sitting in front of me. So it's a real good privilege for me speaking in front of my teachers. So my seniors are also sitting here. So today I have been asked to individualize insulin therapy and choosing the right solution for your diverse patients. I am sure the number of people, 100% of the people who are listening to me are all using insulin. That makes my job very easier because you know everything, almost everything about insulin. So I'll keep my presentation very lucid and short. So I'll start with the insulin paradox. What is insulin paradox? In spite of knowing that the insulin is most effective, whatever the blood sugar level, it will reduce the blood sugar level to normal. It doesn't have much side effect. In spite of that, the large number of people, not only in India, but US, everywhere, almost 30% of the people, hardly 30 to 35% of the people achieve target HbA1c with insulin. Why is that? So that is called insulin paradox. If you look at the insulin as a hormone, so if you look at the thyroid hormone deficiency, if you treat with the thyroid supplementation tablet, thyroid becomes normal. If there is adrenal insufficiency, you treat with a steroid, patient becomes normal. But insulin is deficient. And you are treating with insulin, but we are not achieving the glycemic control. That's the insulin paradox. Why this is happening? Because of the inter-individual difference, intra-individual difference, and probably the risk of hypoglycemia or the fear of having hypoglycemia, maybe not choosing correct kind of insulin for a particular patient. So for that we need to individualize these patients to achieve the good glycemic control and minimize the risk of hypoglycemia. So these are the insulin which are all I have summarized. These are the insulin which are available. I will not go through this slide. You know the good analog insulins are available. Even the basal analog insulin like degludec, glargine U300, these are also available. And the lower one I would also point out that the co-formulation, these are not pre-mixed stuff. These are co-formulation, means two biological insulin has been mixed. If you look at the analog, pre-mix analog, let me take Himalog mix or Novo mix, that is the aspart and the proterminated form is the longer form. But in co-formulation, two insulin, that is degludec and aspart has mixed. So that's the new co-formulation being used. And I'll also speak about that. When do you start insulin? When the sugars are very high, fasting 250, postprandial 300, HbA1c more than 9%, or patient is having symptoms of hyperglycemia like weight loss, polyps, like those things, or a patient is having infection, any kind of infection, microbial infection, decay, will start with insulin. Or somebody on 2 or 3 more oral antidiabetic agents, still the sugars are higher, HbA1c is more than 8.8% or more than 8.5%, then you start with insulin. So what is, then you can use with the premix insulin. And the most important time when you should use premix insulin, the Indian setup, when the patients are not that educated as the physician thinks. They come from the village area, they don't understand how to take insulin. If you give a complex regimen, they don't understand. Then in that limited sources, the probably premix insulin are the initiates. And also because of the high carbohydrate intake, we tend to have higher postprandial sugar, so it's better to start with where the carbohydrate intake is more with the premix insulin. When to start with the basal insulin? If the difference between the fasting and postprandial blood sugar is less than 18, and some formula fasting HbA1c more than 20, and the phase of life like pregnancy, children, we should use the basal insulin or basal bolus insulin. And adult in the early stage of disease where patient is on OAD, still the fasting blood sugar is higher, then you can start with the basal insulin. And Indian reality is, you start with the basal insulin when you think the patient is convinced, so that he can, when you start a complex regimen, patient can take that particular kind of regimen, then you start with the basal insulin, let us shift to the basal bolus therapy. And if the patients have some time, and this is the same thing, so I want to repeat these things when to choose for intensification. Somebody is already on insulin, when to choose for the premix insulin or when to go for a basal bolus insulin. If the patient prefers, obviously patient prefers less injection, number of injection less, then you prescribe premix insulin. If patient can okay with the number of insulin more than 2-3 peaks, then you go for the basal bolus insulin. And the patient is elderly, not able to inject, not able to dial properly, not able to know the doses exactly, then it's better to give a premix insulin. So these are some of the ideas. And some recommendation on how to start with insulin. ADA say you start with the basal insulin, but IDF and NICE says you can start with premix and basal insulin. But RSSDI, they have chosen you can start with anything. You can start with a premix insulin, you can start with a basal insulin, you can start with a co-formulation, as I mentioned, IDEC, ASPs. So how to intensify insulin? So if you start with a bolus insulin, you either the one blood sugar is higher, you add a bolus insulin. So that's called the basal plus or basal bolus, or you can use both premix insulin and basal bolus or a insulin co-formulation. So this is the ideal kind of thing, how we can control the blood sugar. You can see the lower gray, not the blue one, the middle gray region, that's a basal hyperglycemia. If you give a basal insulin, that would be controlled. And the red one is postprandial blood sugar level. If you give a prandial insulin before each meal, that would be controlled. So this is the ideal kind of insulin regimen. And now there are lots of trial, which is better. the premix is better or a basal bolus insulin is better. I just would, if there are lots of studies with premix with Lispro mix or Himalog mix or Iglucid mix with basal bolus. I have chosen this because it's a good co-formulation IDEG ASP. This is a co-formulation of degludec and aspart. Degludec is longer acting basal insulin, aspart is a short acting, rapid short acting analog. So when these are compared, you can see similar kind of HbA1c reduction. You are giving 2 times IDEG-ASP as compared to the basal bolus therapy. Is a very good control with the HbA1c, and the likely risk of hypoglycemia, as you can see left lower panel, is much lower with the IDEG-ASP as compared to the basal bolus therapy. But if you just to see, this is a meta-analysis by Dario, published in Endocrine 2006, that says there is no difference with the premix insulin and basal bolus insulin as far as the HbA1c control, insulin dose requirement is concerned. So there is no difference, absolutely. This is a meta-analysis of about 5,200 odd patients, but the only thing is, if they have more likely to have target HbA1c control with the basal bolus insulin. So these are all I have discussed. I will not, because of shortage of time, I will go into that. So I will discuss about few of the clinical scenario. In elderly, I will start with the elderly population. You know, the target of elderly population, you can see it is about less than 8%. You must have seen these slides many of the times, 8 or 8.5. So in elderly population, we should start with a less stringent glycemic goal. We should not over-treatment to achieve a very good glycemic control. And if the patient is already on complex regimen, you should shift it to premix insulin or de-intensify, because to reduce the risk of hypoglycemia. And probably they prefer to be given by the premix insulin pen, where they can dial a proper amount of insulin. If you give a vial, they cannot take the amount of insulin, the syringe, they find it difficult. So it's better to give a premix insulin in a pen. And coming to the postprandial blood sugar, you know, we take lots of carbohydrate, and carbohydrate has this shown, you can see the on left-hand panel that because of the rice-eating countries, there is increased incidence of diabetes. So that is also contributing to the postprandial blood sugar, and our meal pattern obviously has increased postprandial blood sugar. So this is just a case, arbitrary case. This is a 42-year diabetic who works in an office and always feel hypoglycemic during lunchtime. And he obviously, because of the office job, he delays his lunch, and also have nocturnal hypoglycemia and doesn't want to take insulin. So his fasting blood sugar, you can see, is okay. Postprandial blood sugar is much higher, about 300, and just before it is again going down, it is about 80, and in the night it is going to 280. So what do you do? So there we do have 2-3 options. I would not say I'll directly take the name of the insulin. Maybe Mixtard 2218 is a good option, or a Actrapid or Mixtard, or an analog, rapid acting Novorapid, or a premix insulin Novomix is a good option for this patient, or a IDEG-ASP is a good option for this patient. The patient doesn't want to take insulin. So anybody would try? The postprandial blood sugar is high, and pre-lunch it is going down. Krishna, would you try? You only insulin, if you want to use insulin, only insulin. What would be the best regimen for this patient?
So only lunch, I would say after breakfast is going out, so IDEG-ASP will be ideal, low dose of IDEG-ASP.
Yes, I agree with you. IDEG-ASP would be ideal. Actually, ideal would be analog or rapid acting in morning, analog lunchtime is the ideal. But however, patient doesn't want to take the lunchtime insulin, so IDEG-ASP is a good option. And always fasting, postprandial, and are all contributing to the HbA1c. And if you have to address both fasting and postprandial blood sugar and HbA1c for postprandial patient. Now coming to the postprandial, another thing is how to choose a patient with a postprandial hyperglycemia. So this is how the insulin level in regular insulin, that's Actrapid. I'm just taking the name for the benefit of the students. And this is normal pancreas, how the insulin is secreted in the normal pancreas. And the rapid acting insulin, that is Novorapid or Himalog, these are the rapid acting insulin. It's almost similar to how the natural insulin is secreting. And the ultra fast insulin, that is fast. This fast-acting aspirated insulin is almost similar to the regular, it's a natural insulin secretion. So the Fiasp is because of it is acting earlier, so it's better postprandial blood sugar control. And this is a complicated graph. I'll just to say that the take-home message of this study that if you use this fast-acting, ultra-fast-acting aspect of the Fiasp, even after the meal, even after 15 to 20 minutes after meal, almost similar kind of glycemic control you can achieve. This particularly the patient who do not take good amount of food, the patient with CRA, patient may vomit, so it asks the patient to take food, and if the patient tolerate, and you decide whatever the amount of Fiasp you want or fast-acting. In patient with erratic lifestyle, this is about 54-year-old policeman. This is my typical patient. He comes back to home at 11 o'clock, sometimes 1 a.m., sometimes 10 a.m. The blood sugars are uncontrolled. Fasting is 205, postprandial is 236. I want to give basal insulin to this patient. Well, I cannot take basal insulin because I cannot take insulin at 10 a.m. Sometimes I come at 11 a.m., so 11 p.m., sometimes 1 a.m. So what is the option? The option is there's a newer basal insulin. There you can have some flexibility. You can give this Glargine U300 or Degludec at 1 a.m. Well, if the today patient comes at 1 a.m., he can take at 1 a.m. If the patient doesn't come, comes at 11 p.m., the patient can take 11 p.m. So these are the insulin, the newer insulin as good options for this patient. Hospitalized patient, obviously insulin is a preferred in hospitalized patient. I'll just go through this. Okay, the basal bolus and basal bolus are the regimen in hospital patient. It's a big, itself is a big talk for the hospitalized patient menu, but I will not spare some time for this. But basal bolus are commonly used regimen in hospitalized patient. And how do you decide the dose of insulin by the body weight of the patient? If the patient body weight is about 60 kg, you start with a 30 unit of insulin. 50% means 15 unit basal and 15 is with the bolus insulin, and bolus equally divided into 3. Cardiovascular safety has been proven. Devotee trial, like the oral anti-diabetic agent, insulin have also cardiovascular in Degludec. They have Devotee trial which clearly shown, they have compared Degludec with the with the Glargine. They have found the cardiovascular events are not increasing with the Degludec, and there is less risk of hypoglycemia. And sometimes we think the hypoglycemia can also increases the myocardial infarction cardiac event. They have clearly shown that. You can see that this favors Degludec, even if there is risk of hypoglycemia, a number of events are higher as compared to the Glargine. So patients with renal insufficiency, they are more insulin resistant, the requirement of insulin goes down, so there is more risk of hypoglycemia. Degludec have a very good profile in both mild, moderate and severe renal function test, and aspart has also come similar pharmacokinetic in both in mild, moderate and severe renal function patient, even patient undergoing hemodialysis. So I come to my last slide. So timely insulin therapy should be strengthened with due consideration for local realities, cost effectiveness and the social issues, and both insulin initiation and intensification should be done with the consultation, dietary pattern, glycemic parameter and phase of life and presence of comorbidities. So different things are there. You have to decide what kind of insulin you use for a particular patient. Thank you.
Thank you, Dr. Kanwar, for the detailed analysis about how to use and where to use which type of insulin. And now we declare this session to be closed. We all will proceed to the podium to receive the memento.
Moving on to the last session for today, which is a mixed basket. I would like to invite the honorable chairpersons, Dr. K.C. Nanda, Professor and HOD, former Medicine, past Chairman API, ODISHA, Cuttack. Retired Colonel Dr. Shobhitendu Kabi, Professor of Medicine, Bhubaneswar. Professor S.N. Mahapatra, Professor and Head of Departments of Cardiology, Medicine, High-Tech Medical College and Hospital, Rourkela. And Dr. Amitabh Mahanti, Senior Consultant, Department of Medicine, Apollo Hospital, Bhubaneswar.
Good evening, friends. I can see very tired faces, but keep your faces in smiling mode so that the speakers should get some enthusiasm. We have got a very good subject that appeals to acute febrile illness, probably they mean it's a short fever, hyperparaxia in emergency ward, not in ICU or SD. It's a very common subject faced by our emergency duty doctors, and it probably includes a very good clinical examination, good and fast investigations, and probably the patient would be sent to either SDU or ICU. To speak on this very common subject and very important subject, we have got Colonel Datta. I'm in fact amongst two colonels. I'm a former Air Force officer. And Colonel Sambhu Datta, can you have, yes. He served in Armed Forces Medical Services from 92 to 2016 in various capacities, including senior medicine specialist. He in fact served in both Army and Navy. He was the executive officer, second in command, we used to call it 2IC, in many military hospitals. Ex-HOD Medicine, Indian Navy Command Hospital and of Kalyani. It's a very good hospital, if anybody has seen. They are much advanced. At present, he is a chief consultant of internal medicine and intensive care medicine at JM Hospital, Vizag. So, Colonel Dutt, please start your talk.
Hello? Yeah, am I audible? Yeah. Thank you, Chairman, sir, and all the respected chairs, and thank you, Professor Dr. Jayant Panda, who actually met me a few days before when he came for ACP at Vizag, and then we discussed and then we proposed this topic, and I'm really thankful. This discussion actually acute febrile illness in emergency ward, it came to my mind that time instantly when you were talking, and to little bit what I work in that. I work after leaving armed forces. Now I'm working in a charitable hospital. It's a Christian missionary hospital. It is present all over India, many such as St. Anne's Hospital. So, and I was also luckily in charge of the COVID during COVID scenario. Government of Andhra Pradesh has taken over the hospital, and with all the experiences of my 20 odd years in armed forces, where mostly I was a lone physician. So I'll go ahead. Time is limited, so we'll be going a little fast, and so that we can cover up most of it. I'll touch upon most of the topic. So today morning, one respected speaker has already discussed about Sir William Osler. So we all know that fever, famine and war, they are the biggest enemies. But fever is by far the most. None less than Sir Osler told it, and you all know Osler very well. He is the sort of father of the current clinical medicine who started the concept of residents round and bedside examination, and today we had a very elaborate discussion on Osler's way of teaching medicine, and I am a big fan of him also. So now definition of ICU fever is basically whenever it is 101 degree or 38.3 degree. This is by American Critical Care Society, also by IDSA. And even our AIMS guideline, AIMS New Delhi guideline 2019 also says the same, 38.3 degrees centigrade or 101. There has been there has been a recent surge in the patients presenting in emergency department with acute undifferentiated fever, okay, rapidly progressing into multi-organ dysfunction syndrome. Most of my physician friends will actually go with me. This is happening quite often. The patient is deteriorating very fast in ED or casualty or in the ward also, and immediately we are shifting to ICU. Such kind of scenario is very common. So now, how to tackle those problems, we'll go ahead. Now, this is an epidemiology. This is a pan-Indian epidemiology multi-center prospective study. Okay, a great physician from Delhi and NCR. He has recently came in the magazine, Journal of Critical, IGCCM, Indian Critical, this came. So it actually, if you see, dengue is 23%, it is maximum. Then scrub typhus 18.2, meningoencephalitis 9.6, malaria 8.1%, pneumonia 3.1, leptospira 1.5%. However, I being from this state and from this college, in fact, I did my undergraduation. So Odisha still, malaria is high. May not be at this part of, but I practice in Vizag. I see a lot of patients from Koraput and a lot of patients from Bolangir and other places. Still malaria is about, as per the data, 26.9. This is of course a 2014 data. Later on when I searched about Odisha, there are, all my teachers are there, they must be knowing much better statistics than me. But I think now, Government of Odisha in 2016 in a Facebook, Odisha Government Health Ministry has claimed that almost malarial death has reduced to negligible now. And I also support, because we don't see too many malaria cases other than those places which are adjoining to this red zone or border areas or those areas. So now coming to acute febrile illness, basically we have to divide in syndromic approach. So one is undifferentiated fever, one is fever with rash, stroke thrombocytopenia, and fever with ARDS. Okay, and then fever with encephalopathy and fever with multi-organ dysfunction syndrome or MODS. So if you differentiate this way, then approach will be easy. So undifferentiated fever, we know that if it is undifferentiated fever, it can be either malarial or non-malarial. So we do a RDT. If it is malaria, we treat as per the malaria protocol. Everybody knows that. If it is a non-malarial, then you go for either viral or bacteria or parasitic. So accordingly, we'll go. So time is less, so you just can see the table. So we'll go ahead. Now, very important is fever with rash. If patient has got rash and shock, both, then dengue, then toxic shock syndrome, meningoencephalitis, pneumococcal sepsis, hemorrhagic fever, they are usually the most common cause. And rash with conjunctivitis, it may be Kawasaki or it may be measles or it can be toxic shock syndrome. Rash with diarrhea is Vibrio vulni flicus. It is a very common seafood actually, shellfish. It comes through shellfish and seafood contaminated. Gas gangrene, cases of gas gangrene are very common in armed forces actually. Whenever we get bullet injuries or splinter injuries, a lot of gas gangrene happens. In fact, I had recently seen an army Jawan who came to me from Visakhapatnam. Unusual, he got a tetanus toxoid shot in his village by a quack on his lungi in the leaf. And he developed, and finally crepitus was there throughout, and he developed frank this thing. And we had to take our surgical friends, surgical intervention along with the antibacterials. And he went into ARF also. So then rash with bradycardia. This is very common, you must be seeing in dengue ward, a lot of bradycardia cases. Similarly in typhoid fever. Also we will see in scrub typhus. Many times in scrub typhus you see in the ward, heart rate is around 45-50. These are the differential diagnoses. Then rash with bulla, that is in Vibrio vulni flicus, which I discussed, gas gangrene. Then rash with purpura is very important. This is a meningococcal, or it can be sometimes cholesterol emboli. We had a case in the morning discussion also. Then hypersensitivity vasculitis. Rash with adenopathy, very important, infectious mononucleosis, that is Epstein-Barr virus. Okay, or it can be SLE, rubella, or scarlet fever. Rash with splenomegaly, typhoid, or rubella. Okay, dengue is little uncommon. Sometimes we see rash in CV catheter, very important. Nowadays, mostly in casualty setup, we are putting CV catheters. Okay, for hemodynamic monitoring or sometime for urgent dialysis, we put hemodialysis catheter. And after some time, normally here the patient, poor setup, we keep the hemodialysis catheter for a long time. and we get a staph infection. So first thing you will see, around the catheter there will be little bit rash. Or many times after pacemaker patient comes to us, after 2 or 3 weeks, you will see there is some kind of rash around the pacemaker insertion site. So be very cautious. These are very important, these thing clues, and it can be a staph infection. That is catheter related bloodstream or CRBSI. Now fever with ARDS, here very important, if it is a lepto, usually 6th-day syndrome, lepto 6th-day hemoptysis will develop and very rapidly patient will progress. 50% of the patient get into ventilator and death rate is also 50%. Those who require mechanical ventilation, 50% will die. And death within 3 days is very, very common. So lepto is one thing, and it's seen mostly in Bombay, I have seen during my, and Karnataka very common, and even Andaman Nicobar it is very common. Okay. Malaria, 25% adults and 40% children can be affected, okay, with organ dysfunction. And very important sign, when the malaria patient is having tachypnea, then he is probably progressing to dyspnea. That is a bad case. And falciparum dyspnea usually fatal within few hours. So we have to act very fast. Scrub typhus, you will see typical eschar, but getting an eschar may be 30% to 70%. You may not get. In 2/3 cases, you may not get an eschar. Okay, and you will have dry cough, typical pneumonitis, myocarditis, cardiomyopathy, most of the things are there. Okay, encephalitis, and ARDS is 33%. And at some times, scrub typhus become very high. Now also it is going on, at least in Vizag and adjoining areas. Even I saw cases from Bahrampur also came, lot of cases with scrub typhus. And enteric fever, usually complications, pleuropulmonary complications are less, but ARDS is very rare. But if ARDS is there in enteric or typhoid fever, it is fatal usually. Similarly, dengue fever, already we had a detailed discussion by a panel of specialists from AIMS today morning. So acute dyspnea, if it happens, usually patient will proceed to ARDS. So be very careful. So this is a fever with encephalopathy approach. This slide is not very good. This I took from Indian Journal of Critical Care Medicine. Recently it has come. So basically how you proceed, you first check the glucose. If glucose is low, correct the glucose by 25% glucose followed by 5%. Followed by, then you should check the other signs. Okay, whether ICP is raised or not. If ICP is raised, then you can go for anti-ICP measures. Okay. Now, and then you go for all the serological testings. Okay, if you do the serological testing on CSF testing, you will get the diagnosis and go ahead. Otherwise, you have to go for empirical antibiotic and anti-malarials also and antivirals also. And steroids should be used. This is one bedside test actually. Many times in resource poor setting, we cannot send the patient for a CT scan to see ICT raise. So here simply you put an ultrasound probe on the eyeball and you can see the eyeball very clearly. I also keep doing this because we don't have a CT scan in our hospital. So before doing CT, when the doing CT is difficult, you can do this. Just below the eyeball, you see the optic nerve and 3 millimeter you leave. Below that, around the optic nerve disc is there. You can see the arrow. The bigger arrow is optic nerve sheath diameter. If optic nerve sheath diameter is more than 5 millimeter, then ICP rise is almost 94% sensitivity. It is more than 20 millimeter of mercury. So when optic nerve sheath or ONSD is more than 5 millimeter, you can know that patient has got raised ICP. So then your LP, lumbar puncture, will be difficult, or what you can do is guarded lumbar puncture. All residents know guarded lumbar puncture, how to do it. Then what are the red flag signs with acute undifferentiated fever? Red flag sign, a patient is having prostration. These are the patients whom we admit in acute ward or a high dependency unit. Prostration, when patient is not able to sit or walk without support. Temperature, either hyperpyrexia, that is 41.5 or less than 36, or patient is having rigor. Then respiration, if patient has got any tachypnea, respirate more than 22, cyanosis, arterial oxygen less than 92. Okay, we have a simple HAT criteria also, which is there in the critical care journal, that in that also tachypnea is one of the things. So you see patient confused, tachypnea, okay, then you should admit. Then circulation, this is a very good thing, capillary refill. If capillary refill time is more than 3 seconds, your patient is not doing well. Mortality is very high. And altered mental status or meningeal signs. Abdominal pain, very important for dengue patients. Any dengue patient with abdominal pain is called dengue fever with warning symptom. Okay. Then severe conjunctival or Baumer pillar, jaundice on examination of the sclera, petechial or purpuric rash, or any bleeding from nose, gum, venipuncture site, hematemesis and melena. Morning we saw in that dengue presentation, the patient was bleeding, one of the photo. So that is one of the ominous sign. Now history, you have to take very good history. Actually history gives, if you see most of the ID specialist, infectious disease, they give most important history. Today morning also it was discussed in detail. So you have to take the detailed history in almost all organ you should cover along with general examination. Now disease specific clinical profiles with monitoring and proactive care is the key for early diagnosis and salvaging the patient. The best example is detection of the first case of Nipah virus by Dr. Arun and team in Kozhikode in 2018. I had the opportunity to meet this Dr. Arun, who left actually. He was in Payanur when I was posted there. Later on, he shifted to Baby Memorial Hospital in Kozhikode. He and his team was the first detected. In clinically, they had suspicion when they saw the case. And they sent for the viral assay to Mangalore and to Pune, and they got it. And that is why they contained so fast and they could control the Nipah. And he was, I think, got a lot of awards for that. And also, we should, any unusual case, we should also report to the national database so that other physicians will be also aware. And early use of point of contact test. We should be very, you should depend actually point of contact test, because most of the test what we do in ED or ICU or acute ward, it takes 4 to 5 days to get. So those things will not help to salvage the patient. If anything which helps us in point of contact, ultrasound, aggressive resuscitation including ventilation, hemodynamic management, empirical antimicrobials and judicious use of corticosteroids. We had a stormy discussion on corticosteroid today morning in dengue. So those things are actually will help to come out. Some important investigations, ABG is very important, it should be done. Rapid diagnosis test for dengue, morning we discussed typhoid dot test. Here Widal is a problem. Actually Widal we should not, in acute scenario we should not do Widal. Because most of the time actually we see in our hospital periphery or other doctors, MBBS doctors, they keep sending with Widal positive, even with 180 titer and all these things. And this mostly the test done before 1 week. So which is fallacious, and they write in capital bold letter typhoid patient. And patient's relatives, they force us to treat as per typhoid. So that is wrong actually. So better to do typhoid.IgG IgM, which is much better, more sensitive, more specific, and gives result early. And 2 sets of blood culture we should send before starting antibiotic from 2 venipuncture sites as per protocol. And like today morning we are telling leptospira, actually we are also using kit in Vizag. That is a urine mat test we do. Okay, or blood mat test also we can do. Okay, now I'll go little fast because a lot of, and now for your information, there is a true PCR test which is available now, tropical panel, fever panel kit. It can detect almost dengue, chikungunya, plasmodium, rickettsia, salmonella, West Nile, Zika and leptospira also. Very good, it is an Indian test which got award from Ministry of Health, Government of India in 2016. It is, cost is only 3,000 rupees. It is available. Then protocolized treatment is always better. We should go as per Surviving Sepsis Guideline 2021. Now fluid resuscitation. Fluid resuscitation is very important. Nowadays the current therapy is whether you are giving 30 cc kg per kg fluid or you give restrictive fluid, the outcome will be same. So you can go for fluid, and only thing you should see the overall survival is same. Only thing you should, bedside ultrasound is very easy. Just put the ultrasound probe on chest and see the A lines. I'll take sir only 2 minutes to wind up. 1 minute. Okay sir. So either you should see only A lines. A lines, when they put the probe on the chest, these are A lines, these are nothing but your costal, the ribs, reverberation sign, that is normal. When you see B lines, this pulmonary edema, then you can restrict the fluid, you should restrict the fluid. Till that time you should give fluid, okay. And this is, morning we discussed, this is your IVC, in inferior vena cava. This is very simple, just put the probe on the liver side, you can see the IVC. If IVC is dilated, limit your fluid, okay. If IVC is kissing IVC, if the IVC, both IVC are touching each other lips, then you can give aggressive fluid, okay. So this is what I am doing, same thing in a fever case with ascites, ultrasound in my acute ward. So even you should, peritoneal dialysis is one thing we should again start. Actually peritoneal dialysis was there when I was doing post-graduation. Now I think again we should start it, because we can't depend on renal dialysis or CRRT or SLADE, because nephrologist or PD every resident can do. It is very easy, just put a PD catheter and this dialysate solution are easily available. It's a very, very easy procedure and it saves life. Okay. So liver failure, standard steroid therapy, morning we discussed, that is a midway studies done in India by Bhalla et al., which was showing 1 gram of methylprednisolone was life-saving. However, WHO doesn't recommend. But now surviving sepsis 2021 guidelines straightway says for adults with septic shock and ongoing requirement of vasopressor, we must use IV corticosteroids. Acetaminophen, that is paracetamol IV, whether we should use or not. If you use, there is no harm and there is no benefit, but only for distress or pain control you can use it. So doxycycline IV empirical, as suggested by Professor Muruganathan in his book called Approach to Fever, which came recently, we should use. Principal trial in United Kingdom post-COVID, when they released that, they told that doxycycline did not work, but their cases were, I think, 256. Here we have used in lakhs of patients, probably in dengue during COVID epidemic. And most of my physician friends and seniors, they will vouch with me.
Fast.
So doxy helped. So this was my
No,
case actually.
Dr. Datta, please sum up fast.
So now I'm summing up. This is a case of regurgitation, which I used doxy and acute mitral regurgitation. It came in an international journal also, twice. And there are some of the questions for PG, but I think with the time, this is what is Susugamushi triangle? Is it an anatomical area or it is something different? So anybody knows the answer? So this is it is a geographical triangle actually. This part is actually endemic for scrub typhus. So this is a fill in the blanks. Serotypes, which one? This protease actually is used and OX19 is the antigen. And this is the till now not solved biggest medical enigma in Lancet 2022, that is Chamki fever. The actually cause probably most common is scrub typhus, 18.5. Still now nobody knows what actually causes. And sometimes it is also a lychee fruit toxin. This is hemophagocytosis. Macrophage has ingested the other cells. This is also very commonly causes fever with organopathy, means multi-organ failure. So this should also be a DD, hemophagocytic lymphocytosis, HLS. So my 9 commandments is take a good history, including food, drink, travel, animal contact, sexual encounters, local epidemiology, complete detailed physical examination, point of contact, blood, ultrasound, fluid test, very important. Time is life, most critical, fastest and accurate diagnosis. Syndromic management, as I discussed. 7th is aggressive fluid management, early antimicrobial airway support, communication with next of kin, very important, because disease outcome, other things may not be favorable, they will fight with you. Rare diagnosis, rarely correct, may not hold good anymore. Thank you.
Thank you, Colonel Dutt, for finishing in time. Regarding peritoneal dialysis, I can tell my experience. We have used it, we are one of the first hospitals in the whole Eastern Zone. And in malaria, the death rate was 45% with peritoneal dialysis. And it came down to less than 5% with hemodialysis. So hemodialysis is being done in all the district headquarters hospital nowadays.
Yes, sir.
So that's no more a big issue. So now at least people should not go with the idea that peritoneal dialysis should be resorted to. That's a forgotten mode of treatment. Well, thank you very much.
Thanks.
And please give him a big hand because it was a very good subject. No. Baba Thatto, koi devi tamund. Koi devi. Baba Thatto. Okay.
Sure. Sir.
Yeah, melioidosis, actually one slide was there, I did not,
In
because
fact,
Prashant has already today morning this, I think.
In fact, the scope of this subject is so big, and it is hardly anybody can do true justice in this given 15 minutes or 20 minutes. But he has very well covered almost everything, and every approach has been covered. So I think next speaker should be Dr. Bharat Panigrahi, sir. Dr. Thatoi. Okay. Felicitation, we'll go for the felicitation together. Prabhat Thatoi.
Dr. Prabhat Thatoi will be the next speaker. Yes? Okay.
Next speaker, Dr. Arpita Priyadarshini. She is the professor and HOD of physiology at Sri Jagannath Medical College, Puri, working in the field of sleep medicine over last 15 years, has a teaching experience in physiology for over 24 years, 23 years, and she gives discourses in ancient Indian science for over 20 years. In fact, just wanted to highlight that I have been exposed to a sleep lab for over 25 years. When I first went to Apollo Delhi way back in 1996, I saw, and for the first time I realized as a physician, we should complete our history by taking a sleep hygiene history of a patient. How many of you agree with me that more than the diet and the exercise, sleep is important? If you can raise hands. I think sleep is number one, according to me. If you have not taken a good sleep history of your patient, you are not going to give a good treatment to the patient. And in that respect, 20 minutes again, you can't give justice because sleep is a full whole day's session. So polysomnography and what are the different sleep disorders and everything. So anyway, she's going to highlight on how, what kind of a prescription she is going to give. It's all yours.
A very good afternoon to one and all. Thank you, Chairman, for such wonderful introduction to the subject. And with the blessing of Ma Saraswati, I straight go to the topic which has been assigned to me by Professor Jayant Panda, which is very close to my heart. And to the clinician, I have a pledge that sleep is now the most important history every clinician and every common man has also to know about. So the pillars of good health is nutrition, exercise, as rightly said by Chairman, but the next most important is sleep. Well, this is a very important message I would love to give. Mahatma Gandhi fasted for 21 days, but he lived. But the record for not sleeping is 11 days by Randy Gardner, and he died. So that is the difference between fasting and not sleeping. So in nature, it came as a very important slogan for all of us that sleep is of the brain, by the brain, and for the brain. So in fact, sleep is the marker of your brain activity. And the whole body is the beneficiary. So about sleep, we sleep 27 years almost in our lifetime, but we don't think about it. And out of 3 persons you meet, 1 person is surely having a sleep disorder which he doesn't know. So what's a sleeping brain? Is there a condition called sleeping brain? Does a brain sleep? The sleeping brain remains the greatest mystery and a puzzle to neuroscientists. Sleep is not just an absence of wakefulness, but is a state of both quietness and active. The sleeping brain is a human paradox. On one hand, sleep is a period of rest and repose causing energy conservation, brain and body restoration, synaptic plasticity, and memory consolidation. Whatever we are now, it's because of the memory. So it happens during sleep. On the other hand, highly active brain, but in a paralyzed body, that is paradoxical or REM sleep. And during this period, mixed with unfavorable physiological environment does happen during this part in the respiratory, cardiovascular, and gastroesophageal system in susceptible individuals. On the other hand, there will be motor discontrol, unleashing adverse events leading to confusional arousal, sleepwalking, sleep terror, sleep violence, and sexsomnia, and also new neurodegenerative diseases like REM behavioral disorders where the paradox is lost, and hyperexcitable brain genetically determined triggering nocturnal seizure, particularly in NREM stage 2. So this is all about brain, this is all about sleep. Sleep is a two-edged sword. It can heal, it can kill. And most of the healing power we know, but the killing power is also there. So we have to have a proper stage-wide normal sleep throughout our night. So much intricate regulation is there for sleep. As we can see, so many centers. There are centers for sleep induction, centers for sleep wakefulness, and so many neurotransmitters take the game, take the ball. So the neurotransmitters common in sleep are melatonin, serotonin, adenosine, dopamine, orexin, acetylcholine, norepinephrine, and histamine. This is a cocktail. If this cocktail is not happening, you are not having a proper sleep. And a proper sleep means it is seen by hypnogram, and as I show you a polysomnography, as he said about the sleep lab, this is how the sleep lab looks. And from Hans Berger till 1967, the polysomnography started emerging. And we slowly developed how to stage sleep, and this came how to find out the architecture of sleep in the form of a hypnogram. And because of the EEGs, which was by the Hans Berger, these sleep waves, and because of these waves, we could stage sleep along with EOG and EMG, and we found there were stages, there were varieties of stages. And sleep was of two types, NREM and REM. Under NREM, you have 3 stages, and the most important is also the REM sleep, which is 25% of your time, of your sleeping time. And this happens in a cycle 90 to 120 minutes. Every 90 to 120 minutes, this cycle repeats. And it is seen, most of us do not have stage 3 sleep, and that is why the addiction is increasing. If we don't have good, deep sleep, we will be addicted to something or the other. So sleep rhythm is maintained not only by the circadian rhythm, by the light and dark cycle, also by the homeostatic mechanism, which produces adenosine. So your caffeinated beverages stops this homeostatic mechanism, as a result of which the induction sleep is not possible. Now coming to the sleep duration, as per the Academy of Sleep Foundation, we must know at which age how much sleep is required. And it's very important, from the womb till the tomb, we have to be very careful even about the intrauterine sleep of the baby, as well as the elderly people. So you have to ask very important, pertinent question to everyone you meet, whether he's a patient or is a co-traveler or a friend of yours. Did you have a good sleep? Was it restorative? Are you having excessive daytime sleepiness? Are you feeling sleepy between sunrise to sunset? EDS or excessive daytime sleepiness is a marker of sleep-related breathing disorder. And snoring nightly, if you have a sound or a movement, that also shows that you are having some sleep disorder. And how much time you have slept. And it is seen by the ancient and the modern. And it is written in Gita, "O Arjuna, yoga is not for one who eats too much or not at all, nor is it for one who sleeps or keeps awake in excess." So it is seen in modern times, sleeping less than 6.5 hours, more than 9 hours, is associated with 1.7 times mortality. So sleep is crucial. Why aren't we getting the most out of it? And out of all the sleep disorder, insomnia is quite common. Despite recognizing sleep is a critical contributor to overall health, majority of adults, 62%, say they sleep not at all well. So in fact, 3/4 of adults globally experience at least one listed condition, whether it is insomnia, snoring, shift work, sleep disorder, chronic pain, sleep apnea, restless leg syndrome, narcolepsy, and so many. And there are, in International Classification of Sleep Disorder 3, there are 88 varieties of sleep disorders. So what are the challenges of sleep? And this came into our mind when Corona came, because everyone was at home, but still they could not sleep. So coming to why there is sleep disorder, why can't we sleep? We can say it is because of disruption of daily life. How we do not have a proper daily life. We can do anything with our time, we can do anything with ourselves. We do not anchor to time sense. We have lost that time sense, which is related to sunrise and sunset. So new daily schedule, or even lack of schedule, we don't have a schedule. Many of us do not have a schedule. Everything is accommodative. Keeping track of time with no typical anchors, such as arriving at the office, dropping and fetching kids from school, you can do anything, anytime. Stuck at home with low levels of natural light may reduce light-based cues for sleep and wakefulness. Sitting just at home in an air-conditioned room. And sleeping more or oversleeping can also be a cause of disruption of daily life. Excessive screen time, one of its one kind in this era. Little did we know, the way we are not hungry after eating, the same way, if we take a lot of light, there will be no melatonin for induction of sleep. So the screen time, your blue lights, which is emerging from different gadgets, in fact, that is the killer, and that is spoiling the sleep architecture of all and everyone, including plants and animals. So following news on the phone, Zoom meeting with family and colleagues, binge watching television, screen time later in the evening has a negative impact on sleep as it stimulates the brain and keeps it from winding down. The blue light from screen suppresses the production of melatonin that initiates sleep. And I have already talked about, this is more important now, habit disruption and depression. Old age people, they do not keep a habit because of depression, as a result of which there is emotional dysregulation, and this results into depression and low-grade systemic inflammation, and this is the commonest cause for dementia. So Charaka has rightly said, Nindriyatam sukham dukha prashti karya valabalam rishata klivata jnana magyana jivitam nacha. Happiness, misery, nourishment, emaciation, strength, weakness, virility, sterility, knowledge, ignorance, life and death, all these occur depending on the proper or improper sleep. This is Charaka. Charaka, Shruta and Bhagavata. Charaka used to move around India and find out the things around. So he used to move by his feet and he gathered knowledge. And sleep heals. All of us know sleep heals. Sleep loss is associated with increased obesity. We know everything about this, so sleep heals. Sleep problems constitute a global epidemic, and you have many sleep disorders, and how to deal with insomnia, which is very common. And usually what happens, you know you're an insomniac, and your mind is working in night shift. And it's classified according to the insomnia severity index, and you know 0 to 7, it is subclinical. I mean, no insomnia. We have to have an insomnia severity index tool when we are trying to find out how much is the severity of insomnia. But the commonest is that insomnia is diagnosed when there is problem sleeping at least 3 nights per week for more than 3 months. Take it as insomnia and start treating, but how? What is the best treatment of insomnia is catch them early. Catch them early and start with cognitive behavioral therapy for insomnia is the best, which includes stimulus restriction. Don't allow them to sleep in the bed during any other time other than during sleep time. They must not nap. There are so many parts to it, but cognitive behavioral therapy for insomnia is very important, which includes psychoeducation, sleep hygiene counseling, relaxation training, stimulus control, sleep restriction, and cognitive therapy. And short-term benzodiazepines and antihistamines, non-benzodiazepines, melatonin, all of you know, I don't have to talk about it. But the best result, which I have seen with my little whatever experience, is that CBT really helps along with other prescriptions. And everyone is talking, and all these factors, all these methods are working in the GABA receptor. And sleeping pills really do not work much because it has so many problems related to difficulty in concentration, headaches, and so many things, which are the side effects. So, and we know this Heath Ledger, who was an insomniac, and he did not get sleep. So he took an overdose of all this, made a cocktail, and he drank it, and he died. So he's taken as a person who can die because he's not able to control the urge to sleep, yet cannot sleep. And there are so many alternative therapies which is coming up along with nutritional supplement. And one of them is a plant product which has been worked out versus zolpidem versus valerian and passion flower. These are supplements like melatonin, but they'll really work wonders. So the zolpidem versus valerian and passion extracts, the results suggest that effectiveness of valerian and passion flower extracts in alleviating sleep-related problem is comparable to zolpidem while causing minimal adverse effect. Lack of significant daytime sleepiness can be an added advantage. So what are the sleep recipe for one and all? This is my last slide. Set a regular sleep schedule. Create a relaxing environment. It should be cool. Understand your sleep patterns, exercise, disconnect from the bed whenever you don't want it. Put work aside. Watch alcohol and caffeine intake. Honor your circadian rhythm. And that I conclude here, early detection, reminding sleep hygiene to everyone, ensuring cognitive behavioral therapy, adding nutritional sleep promoting supplements, and prescribing. Thank you so much.
Thank you so much, madam. Wonderful talk, wonderful eye-opener, and I think every one of us will go back home much wiser. So we'll hold the felicitation together for the entire group of speakers now.
Now it is my pleasure to introduce the topic of IgG4 related disease. IgG4 related disorders. It's a type of immune disorder which is still rare, but it is no more that much rare. Because we are now learning day by day more and more about the immune disorders, and this IgG4 related disorders, they don't kill the man. They are not that much fatal directly, though indirectly by causing disease or disease to the organs. Ultimately, it may lead to death. But the person who is suffering from this, it is very difficult to diagnose this. This is a very slow, ongoing process of inflammation, and it's a tumor-like pathology will keep developing, and there will be fibrosis, very slow growing, and very slowly progressive fibrosis causing damage to almost each and every organ. And on this, this is a very much upcoming subject, and about this, we have got one of the very, very renowned and very academically very highly placed, highly regarded person, Dr. Bharat Panigrai, who, in spite of not being there in any medical college, has been highly involved in academic activities all through his life, and more so after his retirement from the government job. He is more than a professor, he is more than a teacher, he is as an organizer, as a speaker, he is outstanding, he is known to everybody. Sir has been the president of East Zone Rheumatology Association 2021. Then he has got Colcon Oration Award in 2018, IRA, Guwahati. Former Director and HOD of Medicine Critical Care in Capital Hospital, Bhubaneswar, which is now a postgraduate institute for medical education, and is a chairman, Association of Physicians of India in Odisha chapter 2021, and he has got many more accolades which could be added to his past glory and present glory also. So, not wasting much time, let us hear about this wonderful topic from Dr. Bharat Panigrai.
Thank you, Professor Kavi, for your nice words. So friends, I will be dealing with a subject very uncommonly discussed, but I tell you, the disease is uncommon, but still I feel it remained as underdiagnosed in many cases because it is a multi-specialist disease. It can go to any specialist. That's why unless there is a disease there's at least a needle of suspicion, the patient remains as undiagnosed. So I will be talking about a patient. So this is a patient. You see, he was admitted with a bariatric surgeon in a corporate hospital and was referred to me. He was investigated and evaluated in a tertiary care eye hospital. So this is a multi-speciality approach. So this is a patient, 59-year-old male. He presented with bilateral painless swelling of both parotid, submandibular and lacrimal glands since 2 years. No history of fever, no cough, no polyarthritis, no skin rash, nothing else. And he doesn't have any history of dry eyes or dry mouth, known type 2 diabetes, hypertension for the last 20 years, and on insulin, Rhizodec and Fias, and Silacar and Ruzuvas. And he had got history of lap cholecystomy 3 years back. So on examination, mild pallor, pulse, blood pressure normal, and this respiratory system normal, no CNS deficit, no hepatosplenomegaly, MSK also no abnormality detected. Both parotid, lacrimal and bilateral submandibular glands are enlarged, non-tender. There are few cervical lymph node enlargements also. Ophthalmological examination showed there is bilateral lacrimal gland enlargement. Shimers was both eyes 7 mm and both eyes showing NSAID, that is dacryoadenate, non-specific inflammatory disease of the orbit. Lab investigations, CBC, the hemoglobin, mild anemia, TLC, TPC was normal, ESAs are very highly raised, that is 122 millimeter, CRP was 5.3, LFT, STLT raised, total protein 12.2 gram, albumin 2.8 gram, and globulin was 9.4 gram. Urea creatinine was 2 milligram. Sodium potassium was almost within little sodium is lower side, and urine ACR was also normal, and serum lipase was normal, but amylase was little raised, and HbA1c was just 6.4%. ECG within normal limit, echo was good LV function, and ANA was negative. ENA was also negative for all antibodies. Rheumatoid factor was positive. IgG was very highly raised. IgG4 was also raised. Serum protein electrophoresis showing polyclonal gammopathy. C3, C4 was within normal limit. So this is what the serum protein electrophoresis. You can see this is the albumin globulin factor. This is the gamma globulin that shows the polyclonal gammopathy. Unlike you must have seen this monoclonal gammopathy, but this is polyclonal gammopathy. HRCT thorax, nothing significant. CT head and neck shows enlarged lymph nodes with fatty hilum seen bilaterally, but bilateral parotid and submendular glands are bulky, showing reticular appearance with nodules and cystic areas. Reticular areas of fatty infiltrates are also seen in the bilateral parotid gland. MRA orbit, there is bilateral lacrimal glands are bulky and showing in T1 weighted image hypointensity and intermediate intensity in T2 weighted image. So that suggestive of cyanoadenitis with dacryoadenitis. CCT abdomen, liver normal size, portal veins normal, common diet are normal, and pancreas is diffusely bulky and with partial effacement of lobular contour, there is relative diffuse, poor enhancement at pancreatic phase, more marked in head uncinate facet. So this is all suspicious of autoimmune pancreatitis. Kidneys are again enlarged, enhancing ring-like soft tissue lesion in cases both kidney with maximum thickness 8 mm left and 11 mm right, and there is ill-defined hypodense lesions in cortex bilaterally, likely perinephritic fibrosis, perinephritic infiltration bilaterally, and that suggests nephritis, and there is retroperitoneal lymphadenopathy. So friends, with these clinical features, we went for lacrimal gland biopsy, and you see the histopathological study shows there is a nodular lymphoplasmacytic infiltrate with nodular fibrosis and perivenular sclerosis. No granuloma, no neoplasm identified. Immunohistochemistry, that shows the B cells express CD20 and PAX5, while T cells retain all T cell antigens. So CD2, 3, 4, 5, 8, and they all highlight there is a diffuse plasma cell infiltrate. Significant presence of IgG4 positive cells, almost 94% of plasma cells, they are showing IgG4 positivity. Kappa and lambda, they show positive, that's showing polyclonal gammopathy. Then IgG related, so what is that? What is the IgG related disease? So IgG related disease that represents, that is immune mediated fibro-inflammatory condition with peculiar histopathologic changes that can affect various organs. Up to now, only little is known about the epidemiology around the world. And although it is generally considered a rare condition, but the number of patients with IgG4 related disease is increasing now gradually. So it can affect multiple organs, and common forms of presentation are type 1 autoimmune pancreatitis, IgG4 related sclerosing cholangitis, and major salivary glands enlargement or sclerosing cyanoadenitis. There can be orbital disease, often the proptosis, dacryoadenitis. There can be retroperitoneal fibrosis, and there can be TIN, that is called the tuberointerstitial nephritis. So these are very common presentations, but it can affect also many other organs. So this is one slide showing regarding the immunological pattern. You can see this is the antigen presenting cell, that is the dendritic cell that presents the antigen. So that antigen, this is the NAP T cells, and you know the T cells are differentiated into various patterns. And this is the CD4 CTL. We know all the CTL8T, but this is a peculiarity CTL, that is the upgoing cells, that is called CD4 CTL. So CD4 CTL, that is the story like fibrosis, the cartwheel fibrosis. This is also found. This is supposed to be the, this is not diagnostic because it doesn't happen in lacrimal gland, of course, but it is, if it is there, then you can definitely suspect this is a case of IgG4 related disease. So this is the Japanese comprehensive clinical diagnostic criteria. So clinical examination showing characteristic diffuse localized swelling or masses in single or multiple organs. Hematological examination shows elevated serum IgG4 concentration greater than 135. Histopathological examination shows marked lymphocyte and plasmacytic infiltrations and fibrosis. Infiltration of IgG4 plus plasma cell, that ratio should be more, and greater than 10 IgG4 plus plasma cell, that is also one diagnostic feature. So definite 1 plus 2, 3 is there, then definitely definite diagnosis, probable is 1 plus 3, and possible is 1 plus 2. So this is the Japanese diagnostic criteria. So friend, in our patient, this is a 59-year-old male presenting with bilateral enlargement of parotid, submandibular and lacrimal glands, bilateral dacryoadenitis, that is pancreatic and renal involvement, both serologically and radiologically, and significant rise of IgG as well as IgG4, and SP study showing lymphoplasmacytic infiltration with significant IgG4 staining plasma cells. There is fibrosis, there are perivenular sclerosis. So all the features which I have described in the IgG4 disease are found in our patient. So our diagnosis goes like IgG4 related disease involving both parotid, submandibular and lacrimal glands. Also, there is subclinical AIP, autoimmune pancreatitis type 1, and there is also tubulointerstitial nephritis. So these are the various organs affected, all the mandibular and lacrimal glands, and there is involvement of the pancreas, involvement of the kidney also. So this differential diagnosis, I have only brought two. Sjogren syndromes can be a differential diagnosis, but here you see there is no dry mouth, ANA was negative, ENA was negative, and unlike IgG4, there is a female also in Sjogren's, it is a female predominant. IgG4 serum levels are usually within normalities in Sjogren. HP study is in favor of IgG4 related disease. Lacrimal gland enlargement is usually not found in case of Sjogren's. So there is no evidence of malignancy was also found in our case. So our final diagnosis is this is a case of IgG4 related disease with involvement of also pancreas as well as kidney. So coming to the treatment part, glucocorticoids are the first line agent for remission induction in all patients with active untreated IgG4 related disease. So in these patients, we started with oral glucocorticoid at the rate of 0.6 milligram per kg weight. Very good response within 2 weeks, within 4 weeks. However, taking his other comorbidity conditions like diabetes, hypertension, and subclinical pancreatic and renal involvement, we added mycophenolate. Now the patient is on mycophenolate plus omnacotil 10 milligram. And patient is on treatment since the last 6 months. He is now under our treatment. All the parotid, submandibular and lacrimal gland swellings have reduced to almost normal size. His creatinine has come down to 1.2 milligram now. Pancreatic enzymes are normal, and he is on follow-up, and he is now roaming like a hero. So this is the picture. This is before treatment, and this is after treatment now. Thank you.
Thank you very much, sir. wonderful talk and wonderful timing. The best possible time, I think, today's the person who has taken least time is you. Thank you very much for that. And Sir, Dr. Panda will now have some announcement.
There is a housekeeping announcement. First, I thank Dr. Panigrahi for finishing the session early. And we have the last session of Dr. Thatoi. And we have already, we are waiting in the Hall B for the AGM and election. You know, it's a very important part of the association, annual general body meeting and election. So as soon as sessions are over in this hall, there will be a small felicitation of the guests and the chairpersons, and you proceed to Hall B, and the hall will be prepared for the inaugural function in that time. We'll finish up AGM, and then we'll come back here for the inaugural functions. Thank you.
So I think now Dr. Thatoi has to deliver his talk.
Yes. Everyone is very familiar with that face of Professor Prabhat Thatoi. I have seen him as a student, undergraduate student, PG student, junior teacher. Now he is a professor and HOD. And his topic is use of bempedoic acid in dyslipidemia management. In fact, this dyslipidemia management has come a long way. There is a sea changes in the treatment of this dyslipidemia, starting from the days of those bile acid sequestrants. If anybody has used it, it's a horrible drug. Then came these HMG coenzyme inhibitors called as statins. That's a wonderful drug, only next to, I'll say, next to aspirin. But unlike aspirin, they don't have any, I haven't seen any statin resistance. Intolerance is very less, but we are also seeing ezetimibe, that reverse transcript, which is reducing in case of there is slight failure. But what I feel that statin is an excellent drug. And this bempedoic acid is another one, and evolocumab, anybody has used, that is another very bad drug apart from the cost. Horribly, that many patients they don't tolerate. So to talk about this bempedoic acid in case of statin failure is Prabhat Thatoi. He has publications and awards. He has got, in fact, he prompted me to write papers after I joined from ISWA General Hospital. I had lots of papers before that, but I've got about 66 papers as a first author. But after I started joining this medical college, he's the person who instigated me to write papers. So within 7 years, I published about 12 papers. And he himself has got 42 publications, which are peer-reviewed publications, 10 abstracts, and 3 book chapters. He has got reviewer of too many index journals, 394 citations at this young age. And his index has got a very high index of 8. So Prabhat Thatoi, it's on to you to speak about this bempedoic acid.
Thank you, sir. Respected chairpersons, respected professors, respected delegates, all my dear students. So my topic is use of bempedoic acid in dyslipidemia management. So a lot of my work has been reduced by the brilliant speech by Dr. Raman Puri in today's morning session. I have quoted his paper. Okay. Raman Puri, Management of Dyslipidemia for Prevention of Stroke. In this review article, that is the latest article, 2022 article, few months ago it is published. Here he has pointed out all classes of dyslipidemic patients, risk factors, drugs which are available, how to give these drugs, what are the likely side effects, and what was left recently, that is the bempedoic acid. Why we are serious? Because atherosclerotic cardiovascular disease in India, 50% out of total heart attack patients are below 50 years, and 25% are below 40 years. Prevalence pattern is increasing in youngsters of India, and atherosclerotic CVD burden in India is evolving. Years of life lost due to SCVD is 59%. High rate of myocardial infarction before 40 years are nearly 25%. And in the newspapers, in the TV channels, we are getting this celebrity of age 40 has heart attack, this celebrity of age around 38 heart attack, etc. High prevalence of dyslipidemia, nearly 80% all over India. CVD burden is rising. Non-HDL cholesterol and atherosclerotic risk. The meta-analysis of 62,154 statin-treated patients in 8 trials. These are the trials in kids CV. So without wasting time, I'll go fast. What is LDL and what is non-HDL cholesterol? So in the non-HDL cholesterol, out of total lipid profile, if you minus HDL, these are comes under non-HDL. In non-HDL cholesterol, LDL cholesterol is one important target. So these are the pathophysiological mechanisms which was discussed. This Lipid Association of India recommends non-HDL cholesterol as a co-primary target as important as LDL target. The problem is, over years, guidelines have become more stringent for LDL cholesterol. European Society of Cardiology and Indian Lipid Association, or Lipid Association of India, they have given recently the guideline, the LDL cholesterol goal for very high risk. In 2016, it was 70. Now, in 2019 and 22, it is less than 55. For high-risk patients, it is less than 70. In low-risk, moderate risk, it should be less than 100. And low-risk, it is 115. And with extreme risk patients, today's discussion, it should be around 30 milligram per deciliter. But how this can be achieved? So, patients on high-dose statin fail to achieve these lipid goals. When LDL cholesterol is reduced to 50 milligram deciliter or lower, the risk of CV event is reduced almost half. But even on high dose of statins, more than 40% did not reach an LDL cholesterol of less than 70 milligram per deciliter. So we need another drug. It may be non-statin group. And keeping in mind some of the, what rightly pointed out by our respected chairperson, sir, even some group of persons with high-dose statins, they land in complications, particularly leg pain, myopathies, etc. So, statin doubling high dose has little incremental effect. Even if we double the statin dose to almost 80 milligram atorvastatin, the LDL reduction becomes in 40, whatever we have achieved, another only 6% we can achieve by doubling the dose. Adding ezetimibe, another 15-20% reduction, and PCSK9 inhibitors, which is an injectable formulation, given monthly dose, not easily available. Patients practically not to be practically given by all patients. It has some promising effect. It can reduce 40 to 50%. And niacin 2 gram daily is practically a highly irritating drug. Many persons, many patients, they are not able to tolerate niacin, high doses. With that, only 14% can be achieved. And this bile acid sequestrants adding, which is also another irritating drug, which has reduced 12%. So what we have left is the drug which is recently introduced, that's the bempedoic acid. LDL goals attainment not assigned in Asians. Asians have different vascular risk profiles than Caucasians. South Asians, including Indians, have an excess risk of coronary artery disease beyond the currently known risk factors. 45.3% of Asian patients reported poor adherence to their medications in a public primary clinic in Singapore, this study showed. Out of which 27.6% of Asian study population failed to achieve LDL-C treatment goals despite on statins of the adequate doses. The cardiovascular risk, despite optimal LDL cholesterol reduction with statins, optimum approach to long-term lipid-modifying therapies for severe risk reduction remains uncertain. Absolute risk modulation via lifestyle changes along with LDL cholesterol and non-HDL cholesterol monitoring, out of which the most important thing is lifestyle modifier. We should, before starting treatment, ensure the most important part, lifestyle modification, diet, exercise, etc. The risk in diabetic patients, the meta-analysis of data of 18,686 patients with diabetes, 14 randomized trials of statin therapy, they found 9% proportional reduction in all-cause mortality per 1 millimole per liter, that is almost 38.3 milligram reduction of LDL cholesterol in participants with the diabetes, 13% reduction in those without diabetes. The clinical challenges for statin: statin intolerance with high dose statin or maximal tolerated statin that leads to 5 to 10% population. Residual risk reduction in diabetics with high dose statin, 9 to 10% population. Poor lipid goals achieved with high dose statin, 50% do not achieve lipid goals in the first 2 to 4 weeks of therapy for atherosclerotic cardiovascular cases. What is the option to further lower LDL or non-HDL cholesterol and hsCRP? Non-statin approach, that is ezetimibe, shows modest effect on LDL cholesterol, that is 12% to 7% reduction, and on hsCRP only 10% reduction. What is the option to lower LDL cholesterol for familial hypercholesterolemia? So we have bempedoic acid offers aggressive, comprehensive cardiovascular risk reduction, that is ACL benefits. Due to reduced LDL cholesterol levels for patients with high risk factors, diabetes or atherosclerotic CVD, adding bempedoic acid to statin, there is 24.5 reduction of LDL cholesterol. With ezetimibe plus bempedoic acid without statin, 38% reduction. Moderate dose of statin ezetimibe, 60%. So the three drugs, bempedoic acid, moderate dose of statin, ezetimibe, three drugs can reduce 60% of LDL cholesterol. So bempedoic acid, I'll go fast. For aggressive lipid lowering in atherosclerotic cardiovascular disease, it is a first-class oral ATP citrate lyase small molecule inhibitor that produces cholesterol biosynthesis after activation in hepatic tissues. This is a hepatic tissue, LDL synthesis cycle. It inhibits the enzyme ATP citrate lyase. The oral dose is 180 milligram once daily with elimination half-life of nearly 15 to 24 hours, single dose. Administered 180 milligram orally once daily with or without food. Clinical uses like as an adjunct to diet for adults with heterozygous familial hypercholesterolemia or atherosclerotic CVD who require additional lowering of LDL cholesterol after statin, as adjunct to diet in primary hypercholesterolemia or mixed dyslipidemia, and in persons with statin intolerant cases. In statin intolerant cases, we can reduce the statin dose to 10 to 20 milligram and add bempedoic acid. Lower chance of myopathy compared with statin. Phase 3 completed, marketed in US FDA, EMA. Dual action of cholesterol and metabolic pathways for wiser outcomes in atherosclerotic and diabetic dyslipidemia cases. This is the mechanism of action. In the LDL cholesterol biosynthesis, bempedoic acid is a prodrug converted to active drug. Then it inhibits the ATP citrate lyase enzyme in the hepatocyte that inhibits the formation of acetyl-CoA. Also, adding statin inhibits the HMG-CoA reductase here. So ultimately, the cholesterol formation, LDL cholesterol reduced. So the robust LDL cholesterol lowering with complementary action on hsCRP also. So bempedoic acid, there are 4 trials. Clear lowering via bempedoic acid and HCl inhibiting regimen clinical trials. One is Clear Harmony, Clear Wisdom, Clear Serenity, and Clear Tranquility. All these trials, they found out that Clear trial program showed consistent lipid lowering with bempedoic acid versus placebo. So, statin plus placebo, then statin plus bempedoic acid, that is the extra 16.5 reduction of LDL cholesterol. Then here for hsCRP, there is extra 22.6% reduction of hsCRP. So bempedoic acid offers comprehensive dyslipidemia management in Indian data points. Phase 3 study completed. Bempedoic acid in patients with hypercholesterolemia with high severe risk inadequately controlled by maximal tolerated statin therapy. Adding bempedoic acid, that LDL cholesterol significantly reduced, so also hsCRP significantly reduced here. Effects of bempedoic acid on hsCRP after 12 weeks of treatment. There is significant reduction in both the trials. HSRV on 22.4% reduction, here 32.5% reduction of LDL cholesterol. So this severe risk reduction, efficacy and safety of bempedoic acid for prevention of cardiovascular events and diabetes, a systematic review and meta-analysis that results in 11 trials, including a total number of 4,391 participants. Composite cardiovascular outcome risk reduction by 25%, LDL cholesterol by 22.91% reduction, reduced CRP values by 24.7%, reduction in rates in the new onset or worsening of diabetes by 35%. So I'll go fast. So what CV clear outcome trial, first impression. This is the highlight. Bempedoic acid made primary endpoint of clear CV outcome trial. It statistically significant relative risk reduction in major CV events in patients treated with 180 milligram daily bempedoic acid compared to placebo. So, bempedoic acid with rosuvastatin fixed dose combination, FDC rationality. HSCRP is essential with rise of severe risk. Jupiter study shows rosuvastatin showed a clear link between HSCRP reduction and lowered the reinfection incidence. Absolute risk reduction associated with rosuvastatin within Jupiter study. Reduction in HSCRP with bempedoic acid ranges between 18 to 32% being greater in patients with baseline values. Ezetimibe has minimal effect on HSCRP, only 9% decrease. Bempedoic acid have significant atherosclerotic CVD reducing potential when added to statins. Rosuvastatin and bempedoic acid combination has additive benefits on HSCRP, LDL levels when combined together, reducing the severe risk. So rosuvastatin is the fixed dose combination Galaxy program. I'll go fast. Bempedoic acid with ezetimibe combination are available for very high risk cases. So this is the study ultimately. Unmet need for further LDL cholesterol in Indian despite statin therapy. This is JAPI declaration. Lipid Association of India recommends for use of bempedoic acid. This is the, I have given the review article. The guideline is there. Low risk group, how to start LDL when more than 100, no need of adding bempedoic acid. But those are extreme risk group, which adding, those are having LDL cholesterol more than 150, adding maximum dose of statin, add ezetimibe plus bempedoic acid. So 2020 Lipid Association of India recommends bempedoic acid as an important oral non-statin therapy for LDL cholesterol lowering in established SCVD cases. 22 Lipid Association of India recommends bempedoic acid initiation for LDL cholesterol management in patients presenting with acute coronary syndrome who are not at LDL-C cholesterol despite statins and ezetimibe as per the Lipid Association of India risk stratification. One slide, last slide please. So bempedoic and its combinations, I'll go fast. This summary says high risk coronary artery disease or SCS have high inflammation and endothelial dysfunction for correlation along with dyslipidemia. Bempedoic acid offers ancillary anti-CRP action that cuts the risk of endothelial dysfunction. High intensity statin and usage of inherited risk threat, dose dependent myalgia, etc. will be reduced. Bempedoic acid is useful alternative. Extensive level of evidence including clear harmony, clear wisdom, clear outcome trials have suggested. So CV clear outcome trial met primary endpoint with significant absolute risk reduction in MACE. Thank you very much for your patience here.
Thank you, Professor Prabhat. You covered it extensively. It was a wholesome session. We listened to different types of topics, and I think due to paucity of time, we'll have to push to the different hall for the extraordinary general body meeting, which the chairman has already requested for. So finally, I would like to invite the speakers in order for the felicitation ceremony here. Colonel Datta, is he here? Our first speaker, Colonel Datta.
Okay.
Is there.
All are requested to move to Hall B, that is our old auditorium, for our annual general body meeting and election. And we will have our inauguration of the conference in this hall at 6 p.m. and followed by gala dinner at the Kotak Club of 7:30 p.m. onwards. And the oration of the API chairman is shifted to tomorrow. It is not cancelled, it will be done tomorrow. Thank you all. Tushar.
Very soon, we have our President API, Professor Shyam Sundar with us, who will be our chief guest of the evening. And we have our Dean and Principal, Professor Prashanjit Mohanty, who is our guest of honor. And also, we have a very good felicitation and book release and the agenda, which will finish and go for our dinner at Cuttack Club. So I request all to call your friends who are outside, who are at the cafe counter, or who are at the returning from AGM, and immediately we'll be starting the function. Thank you.
Good evening to all dignitaries and delegates. It gives me immense pleasure to extend my warm welcome to all of you. Today, we commence the 42nd chapter of APICON, a little backstory as to how it all came to be. The Association of Physicians of India, Odisha State Branch, is a professional body of consultant physicians formed in 1980 at Berhampur. Currently, the membership of the association is more than 1,000 and is increasing every year. The vision of a few stalwart physicians of Orissa gave birth to this idea. Continuing the vision, we today host the 42nd chapter with the hope to conduct more CMEs, conferences, and workshops and other educational excuses to meet up with our friends and colleagues from other colleges. We are committed to spread knowledge and wisdom and to carve a genuine inquisitiveness for medicine in the minds of the future generation. This is also a celebration to applaud the achievements of our Nobel laureates, to get valuable insight in the field of medicine, and to inspire young minds to seek knowledge so that we can continue the legacy passed down to us through generation of brilliant minds. Thank you.
Now, I would like to invite the chief guest of this evening, Professor Dr. Shyam Sundar Sir, President API, to grace the dais. clap kare. I'm clap kare. Sir ko boseva. Tali mar.
Now I would like to invite the organizing chairman, Professor Dr. Jayant Kumar Panda sir, to grace the dais.
Now I would like to request.
I would like to request Dr. Jayant Panda sir to felicitate Professor Dr. Shyam Sundar sir.
Now I would like to request the Dean and Principal, Professor Dr. Prasenjit Mohanty sir, the ACB Medical College, Cuttack, to praise and grace the dais.
Now I would like to announce ex-President Professor Dr. Y.P. Manjul would be joining us via the online platform.
Now I would like to request the Chairman Scientific, Professor Dr. K.N. Padhiyari sir, to come to the dais and occupy his designated seat.
Next, I would like to invite Chairman Reception, HOD Professor Dr. Purnachandra Das sir, to grace this dais.
Now I request Honorary Secretary, Assistant Professor Dr. Nehar Ranjan Mohanty sir, to grace the dais.
Next is Organizing Secretary, Assistant Professor Bhagyashree Panda Madam. We'll be starting the session with a welcome song. And I would request Professor Dr. Jayant Kumar Panda sir to felicitate Professor Dr. Shyam Sundar sir. I would like to request Professor Dr. Jayant Kumar Panda sir to felicitate our Dean Professor Dr. Prasenjit Mohanty sir. Next, we would like to felicitate Dr. Kashinath Parihari sir, Chairman Scientific API. We would like to felicitate Chairman Reception, HOD Professor Dr. Purnachandra Das sir. We'll be starting the session with a welcome song.
जननी वन्दे उत्कल जननी वन्दे उत्कल जननी चारुहासमयी जननी 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 वन्दे उत्कल जननी भूत पयोधि विभूत शरीर तारक मानस शोभित धीर सुप्रकटि विपुल शिखर समीर जननी 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 वन्दे उत्कल जननी सुन्दर मन्दिर मण्डित देश चारुकला बढी शोभित वेश पुण्यतीर्थ जय पूर्ण प्रदेश जननी 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 वन्दे उत्कल जननी कविकुल मौळि सुनन्दन वन्द्य भुवन विघोषित कीर्ति अनिन्द्य धन्ये पुण्ये क्षीर शरण्ये जननी 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 वन्दे उत्कल जननी वन्दे उत्कल जननी वन्दे उत्कल जननी
Now I request Professor Dr. Jayant Kumar Panda sir to present the welcome address to our audience.
Good evening, everyone. I welcome our guests, Professor Shyam Sundar, Professor Prashanjit Mohanty, and Dr. Y.P. Munjal online. I also invite our Chairman Reception, Professor P.C. Das, and Chairman Scientific, Professor K.N. Podhyari. We have with us our Honorary Secretary, Dr. Nihar Mohanty, and also Dr. Bhagyashree. And it's a pleasure, so many people in the audience. We have to be felicitated Professor P.K. Das and Dr. Balram Panigrahi. We have Professor Siddharth Das, many professors and head of the department, and guests, delegates, and the API office bearers from all over the state. We at SCB decided, after the conference was assigned to us in the last GB meeting, we decided that we'll take API to the newer heights. So basically we started forming a team with the youngsters and the best of the organizers and the leaders to coordinate with the different sections. And year long we have tried in that mission. And in the process, we have enrolled more than 250 members. In this conference, we have 17 invited faculties and total more than 80 faculties as speakers and chairpersons, and around 700 delegates registered so far, online, offline, and also on the spot. And this webcasted program is visited by more than 12,000 members till today. Yesterday we had 7,000, today it has crossed 12,000. And I'm sure tomorrow it will cross 10,000, and the webcast is on all over the country and people are watching the scientific program. So we have with us Professor Shyam Sundar, who is an academician from BHU, and he has been working very steadily in infectious disease, especially Kala-Azar, leishmaniasis, and you have seen his CV, listened to him in the topic, My Journey in Leishmaniasis Today, where he has given that details of his work and summary, and the most important thing, he's been author in the Harrison's and the Davidson's Principle and Practice of Medicine. So we have such an academician who is holding the post of President API now, is with us. So I welcome him officially to the program. Please give a big hand for him. We have Professor Prasenjit Mohanty, who is the Dean and Principal of this college, but more than that, his respect towards physicians and recognition that medicine is a different subjects and physicians are diagnosticians who are working day and night to serve people, it affects me very much. So sir has been very dynamic and very helpful for API, and what you are seeing, this auditorium, this campus, these stalls, the food court, personally he has gone with us and guided. And you see the beautiful ambience and this conduction of event of so many people is possible because of only our Dean and Principal, Professor Prasenjit Mohanty. So give a big hand to our Dean sir, and we on behalf of API, thank sir for allowing us this premises and present today in our inaugural function. We have Dr. Y.P. Munjal, who is connected online, and he is the past ex-president of API, ex-editor of API textbook of medicine, ex-director of the PRF, the Physician Research Foundation, and he had some connectivity problems, and I'm sure that will be sorted out soon, and he'll put his opinion online here because of his health condition, he could not join physically. Besides our team, you know, our HOD, Professor Pishidas, who has not only encouraged whole of the faculty and the postgraduates to participate, but he himself has enacted in the drama in our entertainment program yesterday. And you have seen his involvement. Always he composes a poem, does some acting, and then administers the department very well, and a person with an organizational spirit who always encourages the organization. So he has been an inspiration to us throughout as chairman of reception committee, helped us from beginning of this preparation in every way for making this conference a success. We have Professor K.N. Padhiyari, who is a very senior teacher, teacher of teachers, my teacher. We have learned many clinical skills from him, and he is now a professor at KIMS, Bhubaneswar, and he has taken pain of formulating the scientific program and contacting everyone very meticulously over months, and what you are seeing, the academic feast, is possible only because of him. Please give a big hand for Professor Padhiyari, who at this age has spent so much of time for encouraging us and making the scientific program a success. Nihar has been an assistance and encouragement to me. He speaks less, works more, and thoroughly concerned regarding the API activities. And I'm sure under his stewardship, the API will grow further in the future years. Will continue for secretary next term also. Give a big hand for our honorary secretary, Dr. Nihar Mohanty. And Bhagyashri has organization in her blood. She cannot sleep peacefully if something is not achieved. And the day she was given the responsibility of organizing secretary, starting from the drama rehearsal to the invitation, starting from booking of the auditorium, she has always been with us in our team, working till late night, having a small kid at home, has given maximum possible time to the organizing committee to host it. Give a big hand for her. So besides the people whom you see, there are many people in the auditorium and behind who have supported us. Without much time, I thank everyone and I welcome our guests to the program. Thank you all.
Now I would like to request all the dignitaries on the stage to proceed for the lighting of the lamp ceremony. And I would like to invite Irishwani Didi for the sloka.
Hari Om. रत्नसानुसरासनं रजताद्रिशृङ्गनिकेतनं सिञ्जिनीकृतपन्नगेश्वरम् अच्युताननसायकं क्षिप्रदग्धपुरत्रयं त्रिदिवालयैरभिवन्दितं चन्द्रशेखरमाश्रये मम किं करिष्यति वै यमः पञ्चपादपपुष्पगन्धपदाम्बुजद्वयशोभितं भाललोचनजातपावकदग्ध मन्मथविग्रहं भस्मदीग्धकलेवरं भवनाशनं भवमव्ययं चन्द्रशेखरमाश्रये मम किं करिष्यति वै यमः चन्द्रशेखर 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 पाहि मां चन्द्रशेखर 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 रक्ष्य मां मत्तवारणमुख्यचर्म कृतोत्तरीयमनोहरम् पङ्कजासनपद्मलोचन पूजिताङ्घ्रिसरोरुहां देवसिन्धुतरङ्गशेखर सिक्तशुभ्रजटाधरं चन्द्रशेखरमाश्रये मम किं करिष्यति वै यमः यक्षराजसखं भगाक्ष हरं भुजङ्गविभूषणं शैलराजसुता परिष्कृतचारुवामकलेवरं श्वेडनीलगलं परस्वधारिणं मृगधारिणं चन्द्रशेखरमाश्रये मम किं करिष्यति वै यमः चन्द्रशेखर 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 पाहि मां चन्द्रशेखर 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 रक्ष्य मां हरि ओम्
Now I would like to invite Assistant Professor Dr. Nihar Ranjan sir for the annual report of API.
Respected dignitaries on the dais, Dr. Syam Sundar, Professor Prasanjit Mahanti, Dean and Principal, ACB Medical College, Professor Purnachandra Das, HOD Department of Medicine, Professor Jayant Kumar Panda, Professor Department of Medicine, Professor Kasinath Padiyari, and Dr. Bhagyasri, his colleague. It gives me immense pleasure to read the Honorary Secretary Report from the 2022. We took responsibility in January 2022 under the able leadership of Professor Dr. Jayant Kumar Panda, when still there was a menace of COVID pandemic and uncertainties due to changing IT and finance policies by the National Medical Commission. Besides scheduled EC meetings, we had CMEs in collaboration with different associations with more than 150 members attendance, which has also helped us to raise the fund. We have enrolled more than 250 live members and associate members and updated the directory, which will be released today. A quarterly e-bulletin is planned, which will cover the updates and ODISHA API news. State-level CMEs are scheduled in coming months in collaboration with Omron on hypertension in January, Dr. Maniar Group on HIV in March, and ICP will host Journal Critical Care CME at Odisha in April 2023. We have published Odisha Physician Journal, which will be released today, and the process for indexing the journal is on. API has collaborated for community awareness activity on COVID-19 diabetes, and master classes are conducted for postgraduates, and also mock MD examinations is also planned. Around 50 faculties have participated in National API physically at APICON Jaipur as speakers, chairpersons, and judges, and many also have received FICP from our state. More than 60 faculties are invited for National APICON at Ahmedabad, and FICP will be bestowed on 6 senior physicians of the state. We have started API ODISHA and Professor R.K. Parida Memorial Gold Medal orations, and amended the Constitution for President-elect, who will also be scientific chairman for the year. More than 50 national faculties and 100 state faculties are invited for this APICON 2022 event, and we have around 1,000 footfalls with an extra day of event, creating an academic halo around. With 42 years of experience and 40 years after last national conference conducted in the state, our preparation has started to host National APICON. And I am sure with all your cooperation and blessings of the seniors, we will succeed to build the largest physician event of the world. Thank you. Long live API. Thank you.
Thank you so much, sir. Now I would like to request Professor Dr. Prasenjit Mohanty, sir, Dean and Principal, SCB Medical College, Cuttack, to speak few words.
Good evening, everyone. Respected Professor Dr. Shyam Sundar, Dr. Jayant Panda, Dr. K.N. Padihari, Dr. Purnachandra Das, Dr. Nihad Mahanti, Dr. Bhagyashri Panda, and all the dignitaries of the dais like Professor Siddharth Das, Professor P.K. Das, who are the icons of medicine and from whom we have learned so much. And there also are stalwarts of medicine like Vijay Mishra, like Dr. Dare and Dr. Surendra Swai. So many of them are many more. And ladies and gentlemen, it gives me immense pleasure and with great sense of pride and honor, I invite you to the 42nd APICON 2022 being conducted in our college. I welcome all the eminent speakers, delegates and guests who have come from all over Odisha and other parts of India also to share your knowledge and vast experience with each other and with our budding physicians. The theme of this conference is Physicians Post-Pandemic, which is absolutely apt for you all. I am sure you all will learn from various sessions that broadly cover a wide range of topics related to medicine. As you participate in this conference, I encourage you to be passionate about medicine, as passion is the trait that will set you apart from being an ordinary physician to be a patient's favorite physician and a student's favorite teacher. I am also glad to know that API Odisha is bidding to host the National APICON in near future. I wish you all the best in your endeavor. I wish you all a very productive conference with exciting and encouraging discussions and exchange of knowledge. Thank you all.
Thank you so much, sir. Now I request Professor Dr. Purnachandra Das, sir, HOD Department of Medicine, SCB Medical College, Cuttack, to enlighten us with few words.
Respected President API Dr. Shyam Sundar, President API Dr. Y.P. Mujal, Dean ICP Dr. Alka Deshpande, Dean and Principal SCB Medical College Dr. Prasenjit Mohanty, Chairman Scientific Committee Dr. K.N. Padihari, President API and Chairman Organizing Committee Dr. Jayant Kumar Panda, Organic Secretary API Dr. Niharanjan Mahanti, and Organizing Secretary Dr. Bhagyasi Panda, senior physicians of the state, all the delegates, all the invitees, ladies and gentlemen. The physicians, the nurses, the patient, and the medicines. These are the four pillars upon which the healthcare system exists. But without physician, all other three are useless. A good physician can cure a disease, like a good pilot can land a boat to the sail without a sailor. In the present era of advancement of medical science, it is very essential for all of us to be up to date with the up-to-date knowledge. A person who only reads book is confused. A person who only listens to the lectures is like an ass with a bundle of sandalwood who knows the weight of the sandalwood but does not know the value of the sandalwood. So, this present era of super specialization, when there is a craze for super specialization, we physician has to be up to date in all aspects of the knowledge to be at par with others. Now, this conference was planned with a very short time. We have utilized our energy and brain for last 1 month to make it a success. Appreciation and realization by you will give a worthwhile to our effort. The memories of sweet or sour is purely yours. But we are definitely greatly honored and delighted for your presence today in this conference, so that we are encouraged that our effort has been successful. I welcome you all to this SC Medical College Cuttack and the venue for the 42nd annual conference of API. I think the hospitality, the scientific extravaganza extended to you by the scientific team has been appreciated by you, because every care has been taken for your comfort and convenience in the conference. So, as Dr. Panda has told that there is a plan for making other CMEs and future conferences, and there is a little changes in the pattern of API to encourage the new members to come to the association and talk about. So, we expect that in future API will grow with your all support and blessings. So, I thank Dr. Sam Sundar, who has come all along to grace us. I thank Dr. Prasanjit Mahanti, the Dean and Principal, who has always been encouraging for us. I thank Dr. Jayant Panda, who is always a very active person in the department and a very resource person. I thank Dr. K.N. Padiyari, who has been putting all his effort for last 1.5 months to make the scientific program palatable. I thank Dr. Nihar Mahanti and Dr. Bhagyasri Panda for their effort. So, I thank all of you for being here today. Jai Hind.
Thank you, sir, for your kind words of wisdom. Now, I'm happy to announce that we have released 3 books this year, and I would like to invite the editor of Odisha Physician Journal, Professor Dr. Namita Mahapatra, Madam, to the stage. OPG. Okay.
Actually, Odisha publishes a journal called Odisha Physician Journal, and it is almost 23 years of this publication. Professor Mahapatra is the editor. Please get it here. So this is the edition we are bringing out in the conference, and I request our chief guest, Professor Shyam Sundar to release it.
I would also like to invite the editors of Souvenir, Professor Dr. Shri Prasad Sir and Assistant Professor Madam, Dr. Sunita Madam on the stage.
Yeah, I think Dr. Sridhar Panda can join. He is in the editorial team. Please present your souvenir to our guest of honor for release.
Now it's time to release of our directory. Now we have entered the important event of this evening, the Felicitation with Lifetime Achievement Award. For this, I would like to request Professor Dr. Prasanna Kumar Das sir to come to the dais and kindly receive this precious award. In the galaxy of geniuses of ACB Medical College and Hospital, Professor Dr. Prasanna Kumar Das is one of the brightest stars. Professor Dr. Prasanna Kumar Das was born in 1952 in a remote village of Cuttack, struggled hard with utmost sincerity and devotion to step into premier medical institution of Odisha, that is ACB Medical College. He passed his MBBS in 1974 and MD degree in 1980 in Medical College, Cuttack. He had engraved among the best graduates with 4 gold medals to his name. In the year 1984, he received award for the research prestigious Ghanshyam Memorial in Sickle Cell Disease. He was trained in medical oncology from Tata Memorial Center in Mumbai in 1987. He has published 21 papers in national and international journals. He was awarded fellowship by Indian College of Physicians in the year of 2004 for his selfless service dedication to the healthcare sector of Odisha. He was the one of the most distinguished professor and head of the Department of Medicine, SCB Medical College, Cuttack from 2006 to 2008. He was the executive member of MCI from 2007 to 2011. Professor Dr. Das, an eminent physician and former DMET from 2008 to 2012. As a renowned physician, his reputation precedes wherever he goes. He is life member of API, RSSDI, Indian Society of Cancer and Society of Medical Oncology. Post-retirement, he continues to offer his selfless care to change the face of healthcare in Odisha. Today, we are extremely lucky and feel proud to felicitate him with Lifetime Achievement Award. We pray, dear Lord, for long, happy and healthy life.
I would request Dr. Prasanna Kumar Das, sir, to speak a few words.
Esteemed dignitaries on the dais, all delegates, my friends, my all past colleagues, students, and overall, all my well-wishers. Now, at the outset, let me thank the executive body of the API Odisha State Branch for deciding this year to give me the Lifetime Achievement Award here at SCB Medical College. And I must thank the executive body, all members who have selected me for this award this year. And I feel proud also that I was a student of this medical college. I did my postgraduate from this medical college, and I served this medical college for a long time. So this auditorium was also planned, and I am standing in the same auditorium today when I was the Director of Medical Education. And I have visited this so many times. So really I am proud to be in my institute, in my place, with my fellows to receive this award. Now, as a doctor, I had two duties, in fact. Since I was in the medical college, I was a medical college teacher. And since I was a doctor in a medical college seeing patients, I was a physician. So as a medical college teacher, I had tried to teach my students well, given them bedside training, the clinical medicine, which people still remember and tell me. I don't know how much they have remembered, but at different places when they met me in India or abroad, they tell that, sir, we remember you for your clinical teaching. That I have kept in mind. I have given them bedside teaching, given them theory classes from days when I was a postgraduate student in this medical college till I left this medical college and went as a DMT. Second, as a physician, my aim was to treat the patients with utmost care. The first thing that I learned, that you listen the patient carefully. And what Professor Ashok Das was telling yesterday, from his All India survey they have found, each doctor takes on the average 2 to 3 minutes to see a patient. But my principle is completely different. I see patients minimum, hear them, see them and write a prescription. So it takes about 15 minutes. And I do minimum investigations, thinking a provisional diagnosis and give them the minimum medicines required for them. Of course, Nowadays it is evidence-based medicine. If you go clinical, nobody will believe you. So the aim was to do minimum investigations and find out what will be the best for the patient at the least cost. And lastly, I see all my students here. Now at a different places they have achieved very high positions. Here also my students are sitting who are professors now. So with all their good wishes, possibly now I am able to achieve this award. My wife is here also. She has also devoted a lot of my time since I was a doctor, busy most of the time. And when I was a doctor administrator, I was so busy that I was busy from 9 o'clock till 1 o'clock at night. I think she has suffered all that, but with all her support, with the support of the family members, now I am standing here, now what I am today. So I thank all of you once again. Thank you very much.
Thank you, sir, for your kind words.
Next, I would like to invite Dr. Balram Panigrahi, sir, to receive his Lifetime Achievement Award. Dr. Balram Panigrahi, sir, is a passionate physician with extensive experience of 25 years in practicing medicine in outpatient and inpatient care. He is an expert in properly diagnosing and strategizing the best treatment plans. He has served the mankind always with the updated scientific knowledge and contributed to the medical science. He was a part of various government health programs. He was also involved in the active surveillance and management of malaria at endemic regions of Western Orissa. He actively worked for the API organized seminars, CME and conferences. He has served for more than 25 years at DHH Balangir as a medicine specialist. He skillfully introduced newer protocols, treatment plans for the management of malaria, dengue, snakebite, and diabetes. He introduced the practice of regular use of ECG, which was new to certain parts of Orissa. He was actively associated with critical care, being trained at Tata Main Center, Jamshedpur. He played a pivotal role in the use of thrombolytics for managing acute cardiac events in the headquarter hospitals. He is a life member of various professional associations, including API, RSSDI, to name a few. He has conducted midterm CME of API Orissa at Balangir as organizing secretary, and also conducted various seminars and CMEs from the various other associations. He is a man of multifactorious talents. He has received the Indian Achievers Award for Chikitsa Ratan in 2012 by the Global Society of Health and Education, New Delhi. He is a pioneer with a vision and a gifted personality. The encouragement we have received from him is really noteworthy. We at API always remain thankful for all his hard work and efforts he has put in the betterment for the life of his patients. We pray, Lord Jagannath, for your healthy and active life and have all the best wishes for your contribution for the growth of medical science in our state. Thank you, sir. I would like you to speak a few words.
Professor President Shamsundar, Professor Prasenjit, Professor P.C. Das, Professor Jayant Panda, Professor Kodiyari, and Dr. Bhagyasri, and Professor Nihar. Really, it is a proud moment for me as the Executive Committee of API, Odisha State, recognized my service to the people of Odisha, mostly Western Odisha, because I spent major time in Western Odisha. I all along associates with API in different form as a chairperson or as a delegates or a organizing different committee, different meetings of API. I conducted one zonal API state conference at Balangir, which is my home state, and all along I associates with API Odisha state, and it is seen that the API ODISHA is gradually more and more viable under the leadership of our dignitaries. I spent near about 35 years of my service. Initially, I posted to a place where it was a malaria agency area, and some 30 rupees or 40 rupees was given, and it was a very remote area of Balang district named as Kaprakol, which is besides the Gandhamardan belt. Gandhamardan mountains, everybody might be knowing it. And I was there for 5 years. I all along associates with the containment program of falciparum malaria, which was a very, very severe malaria found in that area, and many people were dying, and I started the containment program at Kaprakol PHC. Side by side, at that time, family planning was a major factor for our country, and I operated nearly 2,000 cases of pivectomy in 3 years, and I was awarded by the state government of Odisha. So, as a specialist, I posted to Balangiri Headquarter Hospital. At that time, there was not ECG, which is a very common tool for investigations, and I first started ECG at Balangiri. And many other drugs like artesunate, which was one of the best drugs for falciparum malaria, and many new protocols developed for the treatment of diabetes, ischemic heart disease, dengue, sickle cell crisis, etc. Many other things was managed with a very limited resource. Very limited resource. It is a challenging task to save the life of a patient. And we serve the people like better way, and probably we have achieved something, and we have missed some people also, patients also. And in 2006, I developed a ICU culture at Balangiri Headquarter Hospital, which was not there, and it is developed during 2006. Gradually things are improved, and the resources are available now. Now the full-fledged ICU is functioning in that hospital, as it's converted to a medical college. So many other things done during our period, and we have achieved something, we have lost also something, and now what I am seeing, I am very privileged to see this, all the dignitaries, and giving me the recognitions to this API state branch. Thank you once again to the dais and dignitaries of this house. Thank you.
I would like to request Professor Dr. Kashinath Parihari sir to speak a few words.
Respected Chief Guest, Professor Sam Sundar, Principal, Head of the Department of Medicine, Dr. Jayant, and others. And all of them belong to SCB Medical College, Kotak. They are the staff of SCB Medical College, Kotak, but I am not a staff of SCB Medical College, Kotak. And Dr. Sam Sundar is also not a staff of SCB Medical College, Kotak. But I feel happy that all the staff and students relied on me being outside to make this chairman of the scientific committee. What I gained, my age reduced by 5 years. By being a chairman of scientific committee, my age reduced by 5 years. How? Because I resigned from the job, say 5 years back. I was not in touch with the students. When I got students for last few months, every now and then I found that out of all the organizing committee members, Jayanto was the only experienced member, all are inexperienced. They never knew anything about the organizing a conference. I think for that Jayanto involved me in this year, and also Jayanto told sir, if you are coming, sitting, I have got a scope to emphasize on the students that you see, a man of this age is coming and sitting for 5 hours in the organization matter. Why you cannot spend time? So that is encouraging that I have been able to encourage the younger staff to work and make it successful. About the scientific program, all of you have seen the spectrum of speakers, the spectrum of topic what we have picked up. And in fact, it was very quickly arranged. One evening, the assistant of Jayanta told, "Sir, apan gote lekhik shigro dei dantu. We are going to apply for the credit hours to MCI, I mean NMC." So then what I told, I just made a handwriting. The program, the topics, the system-wise, I made a handwriting and I put it through WhatsApp to him. And with that provisional, it went for the MCI recording, and ultimately that became the skeleton and remained at the skeleton for the scientific program. And about young people, anything, suppose Jayanta will know that for last few days, every day I come and sit with them. I contribute or not, that is different thing. But any work assigned to me, if you make me a sweeper, I will sweep to the best. So any work assigned to me, any head of the department, any organization assigned to me, I try to do my best. I never escape from any work. Given, I will do it. I will do my best. This is what I want to tell to the youngsters. Never escape from given any work, for any purpose, for department, for organization, or for such a meeting. So get involved with the work. There will be some mistake. There are seniors to rectify your mistake, but you get involved with the work. Never escape from the work. This is my experience of working with the young group of students after, say, 6 years going away from the such type of activities. I have nothing else to tell. I thank all the students and the staff of SC Medical College, Kotak, that they have relied on me to make the chairman scientific committee. Thank you all.
Thank you, sir. Now I would like to invite our chief guest to address the audience.
Good evening to all of you. Professor Prasenjit Mohanty, Dean and Principal of SCB Medical College. Professor P.C. Das, Professor Padiyari, Dr. Nihar Ranjan, Dr. Bhagyasri, and above all, Dr. Jayant Kumar Panda. I know him for a very, very long time, and I think he's lovely and dynamic. These are very rare, combination. So he deserves a big hand, and I know that he has organized the whole show, coordinated the whole show so efficiently, so nicely. I come from Varanasi, and I don't know how many of you know that Varanasi and Cuttack have a close relation. In the previous scriptures by Vidha Dev III, he wrote that the Cuttack at that time should be named as Abhinav Banarasi. Abhinav Banarasi. Why? Because Varanasi is at the confluence of two rivers, Varuna and Assi, and Cuttack is again situated between Mahanadi and Kathajodi rivers. So there is a big relation, and I was very happy to know this, very, very happy. As far as I also want to mention Professor Siddhar Das, a long-term friend, 20 years friend in fact, and we have worked together in 2002-03. He was chairman scientific committee, I was the organizing secretary of APICON. And of course, other friends in the audience. This program has been excellent. Scientific program has been excellent. And then the speakers were very eminent speakers, expert in their field, and it was really pleasing to know that in Cuttack also, such a big conference can be organized. And thanks to Dr. Panda and his organizing team. As far as state chapters are concerned, they are important organ of API head office, because head office is made of hardly 10-12 people, but the total membership of API is around 23,000, and to coordinate the things alone, head office alone cannot do. So chapters, and I am very happy to tell you that most of the states, big states, have their own chapters. Some of the districts, city chapters are there, and they form a link between, most peripheral physician to the people in headquarters. So, and the state chapters are, as you heard, this is a big chapter with 1,000 members, and ODISHA, and they are actually organizing so many CMEs, so many conferences, and now so many webinars, master classes, journal club, and there is a lot of contribution from the state chapters, and particularly ODISHA chapters. I am very happy to know this and to tell you this. I think the theme chosen for this conference was fantastic, excellent. Post-pandemic roles of physician. Now, I must tell you, most of you will know probably, that even after somebody had mild COVID, not very serious, and many of them young people, they developed diabetes without any risk factors. Similarly, so many young people have died because of the cardiac arrest or severe myocardial infarctions, or have developed coronary artery disease. It is very important that we should know that corona doesn't affect only lung, it affects every organ of the body, and I really salute that you have chosen this theme for your conference. So, very happy to be here, and I hope the rest of the conference will also go well. Thank you all.
Thank you so much, sir. Now I would like to request Professor Dr. Jayant Panda, sir, to present token of appreciation to our chief guest, Professor Dr. Shyam Sundar, sir. Thank you, sir. Thank you, sir. Now, I would like to request Dr. Bhagyashree Madam for vote of thanks.
Good evening, everyone. On behalf of the organizing committee, it's my privilege to prepare a vote of thanks on this occasion. I offer my gratitude and respect to all our Honorable President, API Sri Shyam Sundar Sir, for sparing his invaluable time and gracing this occasion. I thank our distinguished guests, Dr. Y.P. Mujal sir, ex-president API, Dr. Samsundar sir, president API, and Dr. Alka Deshpande ma'am for accepting our invitation and coming to this conference, and also enlightening us with their commendable talk. I also thank our respected Dean and Principal, Professor Prasanjit Mahanti sir, for his support, guidance and encouragement. I would especially like to thank the torchbearer of this event, our respected HOD sir, Professor Punnadas sir, and especially Chairman Scientific Committee, Professor K.N. Padhiyari sir, and especially Professor Dr. Jayant Panda sir, for leading and inspiring us in working towards goal of conducting this conference. I thank wholeheartedly all the members of organizing committee for their dedication, hard work and support. I thank all our delegates for accepting our invitation and coming to this conference, and also who joined us virtually. I also thank all the pharma people, all the volunteers who are involved in all the capacity in this event and working hard for this conference. Hope you are enjoying this academic fest, and we have organized a delicious gala dinner at Cuttack Club after this event. Also, we are having some more scientific sessions tomorrow. Thank you all. Now, I request everyone to stand up for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
So the meeting is closed, and I request all the guests, all of you, to join us in the gala dinner at Cuttack Club. Thank you all.